check. Sir, Adav. Hello, hello, hello. Check, check, check. Hello, 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 hello. Hello,
Hello, check, check. Hello, hello, check, check.
Hello, hello, hello.
Hello, hello,
Uh,
check. Hello,
hello, hello.
check, 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 check. Hello, 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 check, check.
Check, check. Hello, hello. Check, check. Hello, hello.
hello. Check, check. Hello, 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 hello.
Hello, hello,
Hello,
hello, hello.
Seven. Seven. Yeah. Good morning. Thank you. Okay. Okay. I've been using it. Yeah. Good morning, everybody who are in the auditorium. Okay. Jelly. Okay.
Hello. So good morning, everyone. On behalf of organizing team of fourth edition of Endosurg 2026, I welcome everyone for this very exciting world of endoscopy. I am very fortunate to have today with us the so-called Pitama of Indian endoscopic surgery, none other than Dr. B.K. Rao. So thank you so much for joining us, and I'm looking forward from inputs from everyone throughout these 2 days to make it more interactive and more vibrant workshop. So thank you so much joining everyone, those who are there in the auditorium on site, and also I can see many attendees on Zoom platform across the country. So stay back and enjoy next 2 days of this endoscopy, Endosurg 2026. Thank you so much. Over to you, Dr. Rao.
Thank you, sir, for your kind introduction. It is a pleasure and honor to start the fourth endoscopic surgery program, and I am indeed honored by you to do the first case for the entire 2-day program. I'll go ahead the way in which I do my upper GI endoscopy.
Hello.
I normally talk to the patient before I do the scopy, before telling them what exactly I will be doing to them and what to expect. But here I have the pleasure of having our anesthetist to giving us the full anesthesiology, so the patient will not have any remembrance of what has been done to him. I do what is called as a check of the instrument before I use it to see that the air bubble, air flow and suction are working. I am confident that my assistant here has done that already, and I'm not going to go through it. Now, what I would like to suggest is the mouth gag has been kept in position. The scope is sent straight over the surface of the tongue, and when we see the uvula, I tilt the scope down to look into the larynx and the cricopharynx. Then I will go further. Here you see the epiglottis, the back of the tongue. I go further, you see an inspection of the larynx, and you look at the vallecula, and then we go down gently, and at the cricopharyngeal level, we give a gentle push to enter the esophagus. We have entered the esophagus. We distend. We don't advance the scope unless we see the lumen. And when we go forwards, you see the pulsations of the aorta, then the cardia, and as we go down, you see the lesions here, small mucosal nodules. The person has been having dyspeptic symptoms and has come for the upper GI evaluation. Now we are going down. We are looking at the gastroesophageal junction. We'll see the change in the color of the mucosa from the esophagus to the stomach here. And you see the gastric mucosa there. And this is the Z line that is coming up. Then as we enter the stomach, we see there is a fluid. I always suck out all that fluid. I don't want the patient to retch and this fluid to be aspirated, which will cause more problems at the end of the procedure. I'm giving some time to suck out all the fluid, particularly in the fundus. And then we go down. You can see the vascular pattern on the curvature. I have not distended the stomach fully. I see the greater curvature going down, turning my scope a little to the right. You see the incisura. Then you see the pyloric antrum. The mucosa looks a bit atrophic. I will do the contrast at a little later date. You see the pyloric opening. It is nicely open, and you can see the peristalsis going fully. Here you get a good view of the mucosal pattern and the villi. You have to wait for the pyloric opening to open up. You don't push the thing in. This is the going into the duodenum. You can see beautifully the duodenal villi. I'm in the first part. I turn the scope to the right and to the bottom to enter the second part. So far, we have not made a proper evaluation of the first part. We will do that as we return. We have entered the second part. You can see the concentric mucosal folds of the second part. The mucosal pattern appears normal. At your 11 o'clock position, you will see a small protrusion. That will be the ampulla. That will be the ampulla there. And you see the two vertical folds going up to the ampulla. We have inspected the second part, and the one is going on to the third part there. We don't go further on this diagnostic procedure. And as I am withdrawing, you will see the antegrade movement of the scope into the third part of the duodenum. Now I am withdrawing the scope. We draw it very slowly, otherwise you will come back into the stomach very quickly. By this, you're watching every nook and corner of the second part of the duodenum.
Upper GI folds.
This may be
No,
due trauma
September
due to the
25.
passage of the scope. It is not a pathology that you have it there. These small aberrations are common.
Okay, okay. Who have you? And whether
We are coming back into the
Coming
first
with,
part of the duodenum. And we are
simulators,
back
the Mikado model, at
into
least
the stomach.
minimum 2 of each.
I would like to go back,
have them, sir, in the
watch
another
the
demo because
posterior wall of the duodenum.
got damage during transport.
Do I have your phone number?
Yeah, yeah, we
sir.
are connected.
Then it's okay. I'll. Yeah.
Um, the villi are beautifully demonstrated over the first part of the duodenum.
Yeah.
I don't think there's any pathology there. Would you like to? You can see the pyloric antrum. I just show the first, the red one. Now we have made a J maneuver. We have looked at the fundus of the stomach. I do a rotation. I rotate my body so that my back is to the patient, and you see the fundus fully. Unless you have a look at the fundus like this, you have not done a complete examination. Now here you see 1 or 2 millimeter
You can
polyps in the
put pedal.
fundus of the stomach, which look benign. We can now transform and putting it in the you see further enlargement. Can I have the this thing, please? Now we have got a virtual endoscopy, and you can see the variations in the pits and the mucosa. You can see you have seen the red color of the mucosa. Now you have seen the chromoscopy doing on the stomach to see whether there are any abnormal areas visualized in this methodology of examining. That will complete the investigation. We are going into the duodenum just to see that we have not missed any pathology in the white light. I don't know whether there is a hookworm there. There's a hookworm there. You can see it moving. So there is one diagnosis which I don't think they have done a stool examination on him to see that, most of the thing is lost. Now I'll come back. Now question is, we are back on whether you want to take a biopsy for H. pylori, number one.
Yes, we can take.
Right? Routinely, and then do for H. pylori evaluation. We want a mucosal biopsy of the two small adenomas in the fundus of the stomach.
They are very small, so I don't think so. We'll.
Okay, we can. That's what I thought. Endoscopically, it is benign, and I don't think we will need to go do, but we will do the biopsy for H. pylori, because that is one of the pathological lesions for dyspeptic symptoms.
How will you describe the mucosa and the
I would say it is normal, sir. I won't say it is atrophic. It is not hyperemic. There is no congestive gastropathy. I would call this as
Take care of.
just because we have done an endoscopy, we should not give a pathology on this. It looks quite normal, and I wouldn't like to put in on some other terminology in the report, which will, what shall I say, confuse
So
the.
you are giving proper for already.
We take the biopsy at the pyloric level. Open, please. Close.
No. What is the normal site of biopsy for H. pylori which we take?
Normal.
Site of biopsy.
Usually I take it in the pyloric antrum.
The throat.
Sometimes if there is a abnormality in the duodenum, I will take one from the duodenum. But here I don't think there's any abnormality in the duodenum. I don't expect to find a pathology of H. pylori there.
Yes.
I think I'll take 2 bits.
Yes, that will be sufficient.
That would be more than sufficient. Okay, open. You have to give time for close. Okay. Now we do the H. pylori test. We have seen the fundus. And I'm sure some photographs have been taken of this to be given to the patient. I think that may be a thing that may be reviewed after a year's time, whether it has got. You see the GE junction from below, the mesenterus is tightly holding the GE junction. So there is no question of any hiatal reflux. As I withdraw, I suck out all the air in the stomach so that the patient is comfortable at the end of the procedure. We have come into the esophagus. We again make a slow and controlled withdrawal to see the mucosal pattern. And when I come to the cricopharynx, I'll apply suction to suck out all liquid in that area so that he does not aspirate this fluid. We also do a ENT examination here to see whether there is any pathology in the vocal cords and upper. It's quite normal, and we are gradually, there's no fluid in the cricopharyngeal area, and we are gradually withdrawing the scope. This completes the examination up to second part of the duodenum. Sorry.
Hello?
Yeah.
Any questions from the other side?
What I would like to say is that we have used the Olympus EVS 11 on this patient, which has given us
Dr. Urvi, Dr. Shafali?
Okay. Thank you. Thank you.
Hello?
Yes,
Hello, good morning, sir.
Yeah, good morning.
Dr. Shinde, ka?
Yes, yes.
Yes, any questions from that side, sir?
Very quiet and very comfortable.
Why should we take the biopsy in H. pylori at the antrum only?
H. pylori.
Why at the antrum they should take the biopsy? That's what he wants.
Oh, positive? We'll just show it to them.
Camera focus.
endoscopy camera. You can see pyloric thing is positive on this mucosal biopsy. So probably he may be put on H. pylori treatment to give him some relief from his dyspeptic symptoms.
So there's a question, why biopsy should be taken from antrum and not from any other place?
The concentration of the H. pylori has been found to be in and around the pyloric antrum and first part of the duodenum. You can take anywhere, but your chances of getting a positive response is much less if you take in other parts of the stomach.
So that answers your question?
Yes, thank you.
Hello?
Yes, thank you.
Thank you. Okay. So now we go to the second case.
Thank you. Thank you.
Case number 3, 25 years old male, came with chief complaints of dysphagia, solids equivalent to liquids in 7 days, and burning sensation over the chest region since 7 days.
You see the scope, you see the opening, right?
CCT,
It will be like this.
chest with
So you call it lax.
HRCT was done on July 26. Impression was hiatus hernia and mild circumferential asymmetric thickening of infracarinal esophagus with light mucosal irregularity as described. It was suggestive of esophagitis. Plan is upper GI scopy.
LES is lax.
Learning objective upper GI scopy for evaluation.
It is not tightly.
Hello? Hello? There are diagnostic standard version. I will symptom.
Good morning, everyone. On behalf of MGM Medical College and Hospital and Aurangabad Surgical Society, it gives us immense pleasure to welcome you all to the 4th Endosurg 2026, Endoscopy for the Surgeons. We've already begun with our first live workshop session on upper gastrointestinal diagnostic and therapeutic endoscopy. The session will provide participants with an opportunity to witness a real-time decision-making, advanced endoscopic technique, and therapeutic intervention performed by the masters in the field. We've already begun with our first live workshop on the upper gastrointestinal procedures. We request the chairperson of our first session, Dr. Jaiswal sir and Dr. Sami sir, to take their seats and please preside with the session.
Seen by people around me and also in the auditorium, but
Hello.
Auditorium.
Hello, hello.
Yeah. Keep it outside. You can clip it. Hello. Now, my dear chairperson, can you hear us now from auditorium? Give a thumbs up. Let's start. No, they are not seeing. Hello. Hello, can you hear us?
Sir, we can hear you, sir.
Thank you, thank you. Once again, after demonstration, excellent demonstration by Professor BKR, my mentor on a diagnostic endoscopy. We go in the same way, have another case of a diagnostic endoscopy, possibly may require some intervention depending upon what we are going to find. As you heard the history earlier, this gentleman is in his late 70s, comorbidity with a triple vessel disease. So he has some reflux symptoms, and he is expected to have a severe esophagitis, possibly a stricture. We need to see and we need to plan accordingly. So when you have such cases, very important thing is what I'm holding in my hand, the endoscopy itself, you need to understand the machine you are comfortable with. The machine seems to be performing well. What I call like a pilot before starting the plane, a cockpit drill. So I have already done a drill that the Fujifilm 8000, what I'm holding, is one of the high-end endoscopy. We have all the facilities to change the color from what we normally see, the white light, into various different lighting so that the image is enhanced and you will be able to see things with a clarity and precisely make a diagnosis without even a need for a biopsy. So that is the beauty. It's functioning good. Next thing is we have to see, I don't know whether how many of you are able to see the patient. Normally a diagnostic endoscopy has to be done in a patient in a left lateral position. Here the patient is kept purposefully supine position, one head turned to one side. And because of the privilege of being in a bigger event like Endosurg, I always see people 100 years ago, they used to go to Germany, Erlangen. There is a small little town in Germany, mecca of endoscopy. Like that, every year, it is like an annual pilgrimage now coming to Aurangabad for the Endosurg, because learn the tips and tricks of not only diagnostic, but also therapeutic endoscopy. This is a privilege to be part teaching the surgical colleagues in the art and science. So the way we do it, how I'm positioning myself. Ergonomics is not only for laparoscopy, also for endoscopy. The table, ideally, it's my waist level. I am a arm distance from the patient, and I have unrolled head is held in my, and I use both my hands not only for upper endoscopy, for all endoscopy procedures like ambidextrity. So that way you have a better control. How still weightage you.
Can someone adjust mic off, sir?
Yes.
We have some audio problem. Please adjust the mic.
Thank you. I'll go slow. You hear me now?
Yes.
Economics are important, so keep myself comfortable. So let me just go with a. Yeah. No, it should be audible. Is it audible now?
Yes, sir.
Voice is clear?
Yes.
Yeah, thank you. Cavity, and what you see now onward, all the people across wherever they're watching the monitor endoscopy view like a clock. So what you see towards 12 o'clock is the tongue in upside down view, short between, you see naso, what you 3 o'clock on the monitor, left pyriform fossa somewhere here around 9 o'clock. You just go behind and then gently nudge your way or esophagus. And the very important thing, watch my fingers in the control head, is superior button, and that is for the suction. We seldom use it. The inferior button is the secret. So you need to make sure you insufflate adequately as you navigate, and depending upon where you are, you can turn. This is called torquing the scope. So the navigational skill is demonstrated not only by your wheel movement, big wheel and small wheel, but also the torquing with your right hand and my body movement also. As you can see here, let me just start putting some color code to the lesion. You can see some columns of ulcerations as you can appearing in your monitor around 5 o'clock, and there is a circumferential ulceration somewhere here, and you will be tempted to go through, but I wish because of the severity of the ulceration all around, you don't push your scope, because the scope might find a false passage and cause problem. So let us do a screening exactly at what level we are having. Can we do a screening now? Can you just hold the scope? So I can see the upper end of the ulceration is around 30. We know we expected to find the Z line a little lower down. So I need to have what we call a path. So what I'm trying to do is something like a flexi tip, metallic guide wire, or even you can have a zebra guide wire. Just you pass it on, just push it in. So it goes through the access channel. Okay. So what you will be able to see in a minute is, you will be able to see the guide wire is coming. It is going freely. Let me just see whether I will be able to go in. See, I'm able to go in, okay, but I think the guide wire made me to go travel in a faithful passage, which is safer, and I would advise everybody, whenever you have a doubt whether I'm able to go through, always pass flexible, non-traumatic, follow the path driven by this. So I'll just come back and see you again. See, this is all the inflammation because of the reflux of acid. It happens around 30. Then I'm putting the BLI. I'll just change into, this is ACI. See, there are various color codes available depending upon where. This ACI is very, very useful, especially when you red chromatic imaging, something like that in Olympus. So whenever there is a bleeding site, you'll be able to see that. We'll go back to the BLI or LCI mode. So these are all the various terminologies we use in Fujifilm, whereas when you go to Olympus, they'll use like NPI. When you go to Pendex, then they'll use eye scan. So you need to get used to what car you are driving and what gadgets you are having. Accordingly, you can make yourself comfortable. So this is the level of inflammation around 30. If you go in, this is the diaphragmatic pinch. That is happening around 36. So he's having a 6 centimeter hiatus hernia. Let us take the backwards for the time being. And at 6 o'clock is actually the greater curvature. And what you see far away around 3 o'clock is where you have to travel. In other words, I have to travel along the greater curvature 6 o'clock. I just turn the scope to the clockwise so that I turn towards that. And you see the big wheel I turn towards me. That makes me to look more and more upwards towards 12 o'clock. So these two movements, big wheel towards clockwise torque, brings the pylorus right bang at the center of the monitor. Then it makes me easy to enter, and you see mild duodenitis. Okay, you can see all the blood vessels are brought in into focus thanks to the LCI mode, and I can change, to BLI. This is blue laser imaging. You can see it is more or less BLI and narrowband imaging are more or less same. You can see the vessels, and this is the post-bulbar region, and slowly the small wheel in your monitor, the control head, is the key to turn into our entry pass for you to enter into the D2. So you can see the inflammation keeps going. Whether the acidity is part of the reason for his reflux, we need to ideally do here also the H. pylori test, I would say. I've gone right into the proximal part, and what you see at 9 o'clock in the monitor is actually the small glimpse of the ampulla vata. Now I turn my body to the right and pull the scope like this. And you can see a patchy inflammation going even beyond into the D2, and also some mild inflammation in the antral region. Shall we just do quickly an antral biopsy? Because the H. pylori, preferentially, they stay in the antral. So in the duodenum, no need to take a biopsy in the duodenum. Try to take only in the antrum. Even though the book says 2 bits are required, normally take just 1 bit, and we'll put it in a what we call a rapid urease test kit available, and look for it, and that has to be treated if it remains positive, rapid urease test. So before that, when you are in front of the pylorus, what we call a pre-pyloric region, just take the big wheel in your thumb, have a small flick towards you, then you see a ridge appearing, okay, in front of you. That is the incisura. You will be able to see that is the incisura. And bring the big wheel completely towards you. You make something like a J maneuver, and then pull the scope, anti-clockwise twist, and you have a panoramic view, and you can see a patulous lower esophageal sphincter. And I wish all of you there and everybody, postgraduates, they go and read the Hill classification that has been the standard of the describing how lax the lower esophageal sphincter when you do a J maneuver. Here it is type 4. So type 1, type 2, type 3, type 4, I'll tell you later. This is something like close to type 4. Even you can see a glimpse of the esophagus. If I put, you can see even the ulcerated area here. So it is an upside down view of the Z line. So that part of the stomach, as you can see, has already herniated. So he's having a large hiatus hernia, mild inflammation of the stomach, severe inflammation of the duodenum, and a stretched out distended stomach. I just suck a little bit so that you have an idea. And then this is the, as I said, 6 o'clock is a greater curvature. And 9 o'clock in the monitor is the anterior wall. And I can see the posterior wall at 3 o'clock. You don't see the 12 o'clock, the lesser curve, but if you want, I can bring the big wheel, I can see a glimpse of the lesser curvature. Keep going back into the antrum, where I preferably take a biopsy. So, close? Yeah, keep it closed. Very important thing is, I'll just touch the basics, because always the foundation has to be strong before you build bricks to make the building bigger and bigger. So this is what I say. You instruct your staff, don't do anything when you are going through the channel, because they should not open the biopsy pools when they are in channel, of course. And I'm just going to exit. And you have to keep only 1:1. The metal is 1 centimeter and the plastic 1 centimeter. Don't take it like this way. This is ideally this one. Now the biopsy forces is in open configuration. You just go, like push the scope to go near, and just go to an area close. So we have closed. So lift biopsy. While the biopsy is, you keep watching that area, because you never know, these people on triple vessel disease may be still on the double antibiotic. Ideal world, we should have stopped one of them, at least the clopidogrel. Aspirin will not do that harm, so you have to be very watchful whether this induces a bleeding, which is unwarranted. So it looks reasonably okay. Let me just get the, one is enough. Guide wire again. So my plan is, for a demonstration, quickly we'll do a Savary-Gillard dilatation. The principle. Principle number 1 is, you need to have, because guide wire well into the duodenum if possible. Okay? Let us get the guide wire one more time, and we'll give some analgesics for the patient. It is a painful procedure, especially when you are going to stretch. And a very simple, important message I can give you is, whenever you use Savary, understand Savary-Gillard classification, Savary classification of esophagitis also. Just let me just go. The safest place to leave the guide wire, of course, is in the duodenum, if you are able to do well and good, or in the antrum. Yeah, Now, along the guide wire you can see a fountain of water is coming. So you have to use all the luxuries given to you. So this is actually a irrigation pump attached.
So we are changing the mic.
So we'll just leave the guide wire. Just to watch what I'm doing. Actually, I am not using my right hand to pull the scope. Don't leave it, leave it. I just come back. As I push the guide wire, I pull the scope. I pull the scope. I pull the scope. This is called railroading. And only the guide wire will appear at the end, and my assistants there in the mouse end will hold it, then take the scope out. From now onwards, it is like a leap of faith. We have to follow the path by the guide wire. We'll ensure, go for 10 size, 10 and 12. Just so, screen once. Can you see, can you just go a little higher up, esophagus? Yeah, 9 and 11. We'll stop with 11. There is a small scalpel blade, 11 blade, I am sure all of you can watch. That is actually more or less at the OG junction, okay. Then it goes into, and if you can zoom out, you can see it takes the curvature of the whole stomach, and it is at the 9 o'clock in the fluoroscopy, you can see it is entering the duodenum. So it is a long path. So our job is, can you just go a little higher, monitor, screen now? Yeah, that is a perfect one. So the guide wire is in the esophagus. The end point for me is about 2 centimeters below that little scalpel. So here is the Savary-Gillard dilator. So this is a conical radio-opaque dilator, very supple. If you buy one today, I can donate it to my grandson after 30 years. So this is so durable, so cheap, and so effective. But the only thing is, you should not use your force from your shoulder. The force should be from your wrist. It should be gentle. And follow what I call a rule of 3. What means I feel his diameter of the stricture is around 8. 8 plus 3 is 11. So I don't go beyond 11. So this is what I'm going to do. So I'm going to start with the 9 to start, and then we'll stop with 11. Okay. So there is a small Savary. We thread the guide wire like this. And very important thing is, this is a very important thing. I think it's a nitinol wire, is it? So that's why it is not buckling. See, some of the things, it will cause a buckling, and the force will be exerted, will be going laterally. So this is a nice wire, so it is not buckling. And also, I always take, you can just do a twisting motion like this, so that until it enters the oral cavity. So there is no buckling at all. And you have the privilege of having a look at the monitor. Use your left hand for pushing in. So for example, I am putting it here like this. Can I just screen once?
Can you see the outside hand movements?
So I am just slowly pushing. My force is exerted, not my shoulder, from a supinated arm. I don't use like a chisel. This is a strong arm. This is a weak arm. So I use a weak arm just to gently push. You can see a marker appearing. That's just now. Can we just go a little down? The fluoroscopy a little down.
Shinde sir, can you see the outside movements, hand movements of sir?
Yeah.
Now we can see.
Now we can see.
Yeah. Now what I'm doing is I have done a satisfactory dilatation, but I want to do one more to the size to 11. So what I do, I take the head of the dilator in my left hand. Then as I push the guide wire like this. This is called a railroading. So that there is no loss of the position of the guide wire. Otherwise what will happen, the guide wire tend to get displaced more proximally. That is the danger of this procedure unless it is done this way. So I'm just taking, just to relax. Yeah, that's right. And let us screen one more time.
223 camera, 223.
Yes. So we know the guide wire is still in place, and also outside the patient, I also know how far the guide wire is coming. So by roughly, I know there is no displacement. Finally, we'll go for the 11 size, because once the inflammation settles, most of his symptoms might settle down. He would require a high-dose PPI, H. pylori eradication if it is positive, revisit this area after 8 weeks, and he might require a redo dilatation if, but most of the time they settle down. Only thing is they may have to reduce the dosage of antiplatelets if they are in a high dose. Okay? So lubrication is a key. And the second thing is gentleness is a success story. Avoid over-dilatation. Never, because you have a powerful deltoid, doesn't mean you push even to the next size. Stop with 11 because his initial diameter is 8, rule of 3. Just gently go in, gently go in. Just can you screen?
Can you see the C-arm view?
Can you screen?
Yes,
one
yes.
more time?
Yes.
Yeah.
Yeah. See, this is one of the main advantages of this dilator over the CRE, if at all. Here is, you have a little what I call a haptics or a tactile feedback that is lacking in CRE. But having said that, this actually splits the esophageal dilate longitudinally. So this is a slightly different, whereas there it is circumferentially it dilates, whereas here it is a linear dilatation. So you have to, it will sometimes, in a very fibrous esophagus, it can even split. So perforation is a real danger, as you can see. If a patient has a tachycardia, or you put your hand on the neck, whether there is any crepitus, then you know you had it. So that situation should not happen, provided you take all the precautions we just mentioned. We always follow the rule of 60. What is the rule of 60? Wait for about 60 seconds. So that whatever is, you don't go for a recoil. We don't want it to spring back to normality. And if this keeps on happening, the recent trends are, can you think about something better? Like we can give the injection of triamcinolone or Kinacort locally to prevent it restenosis quickly, or even you can debate what is the indication for a stent deployment, fully covered, self-expanding metal stent, there for about 6 to 8 weeks, then you take. So that you can keep on going, but this is itself is therapeutic. With the high dose PPI, patient will be symptomatically better. So because I'm not doing any more dilatation, I'll take this whole thing as a unit. Do you need to do a check endoscopy, if you ask me?
Yes.
Unless you want to do, we can do here. Don't insufflate too much. Yeah. Don't try to do a biopsy. That's my, especially beginners. Right. If at all you do a biopsy, before dilatation, from the top end, you take a biopsy. Try not to do a biopsy now because it is inviting trouble. So, and one more safety precaution is, can I have the guide wire? Always have the guide wire. Even after dilatation, better you have a guide wire to pass. Over that, you pass the scope. That is the safest, surest way that you are going in the right path. So I am navigating again. Upper esophagus, because sometimes it will be all blood stained and you will not know the exact path. Here it looks okay, so I am just gently twisting without much force I am able to do. But I advise most of you, if you are in doubt, put a guide wire, over that you thread, then zero risk of any perforation. Suck all the fluid because patient is going to be extubated or come out, so he should not have a risk. So the way you see, this is a very important picture for all of you. When you enter, 9 o'clock is fundus, 3 o'clock is your path to pylorus. So when you want to, whenever you enter, is there any fluid in the fundus? How do I do? Take the scope, anti-clockwise twist, big wheel towards you, you see the fluid. You suck always. Empty the fundus, then enter the pylorus. How you enter? Walk towards 3 o'clock. So that secret you should know. And let us have a final how it's all looking. It looks fine. So let us deflate the whole thing, and then we'll just conclude the procedure, and that's it. Thank you very much.
So when will you redilate this patient? When will you be called for redilate?
Probably about 8 to 10 weeks.
Yes. And when will you use Savory dilators, and when will you do CRE balloon dilatation?
Yeah. And if you, there is no hard and fast rule, but usually anastomotic stricture, they behave better with a CRE balloon, in my opinion. And anything beyond esophagus, like pyloric stricture, duodenal stricture, anywhere, I think CRE is kinder. You can't use Savory, of course. Esophageal stricture, classical two cases are straight strictures, post-corrosive or post-radiation. And the first dilatation who has done should do the next one, because mentally I know the roadmap.
Yeah.
Otherwise, sometimes there is a pseudo-diverticulum, some tortuosity, and people will know. And the secret is never do without the C-arm. Even though some people bypass, C-arm is a guide, anesthetist with a good pain control, a still patient, in a supine position. So this is the one opportunity for you to learn the supine endoscopy, because you never know, you are asked to do an endoscopy in a patient during surgery also when lap failures and things like that. So this is the ideal starting point for all of you to learn. I usually do even a ERCP in a supine position. There is no discomfort at all. Once you enter, anatomy is same.
I'll ask in the second question. When the patient is in left lateral position, the anatomy changes. So again, you will have to reorient to the people, audience over there, how anatomy looks whenever we put in a scope.
Doesn't change much. As far as the endoscopy view is concerned, it is more or less same. Okay. Only thing is the pooling of fluid may differ from where it is initially, where it shifts otherwise. For example, in duodenum, for example, when you go in, there will be a lot of pooling of the fluid in the D2 in a supine position. There is a little uncomfortable. Whereas otherwise, as I said, the configuration, the clock position, all the anatomical structures. I wish next case, I'll go a little ultra slow to tell them. I usually teach a lot of youngsters because the problem in the surgeons is transferring them. They know what to do, but they don't know exactly how to do. That skill set transfer, what I call. So it's like ATLS program. We have changed the way. We say you have to do these maneuvers in 6 different stations. You essentially enter at the end. So like that, we teach them. So next case,
Internal anatomy is, we should be well versed, because when we are reporting, then only we'll be able to report it correctly.
Of course.
If we don't know what is lesser curvature, what is anterior wall, what is posterior wall.
Absolutely. Absolutely. So this is what we'll emphasize in the subsequent demonstrations, sir.
Thank you, sir. A very good demonstration.
Thank you too. Thank you, anesthetist.
Thank you, sir.
Thank you. Well done. Thank you. Thank you.
Now we'll begin with the next case. 85 years old male came with chief complaints of pain in abdomen since 3 days, weight loss of 3 kgs in 1 month, and history of heartburn. Our plan is upper GI scopy and evaluating upper GI scopy pathologies. Over to you, sir.
Hello.
Yes, sir.
Am I audible?
Yes, sir.
Yeah, thank you so much. So again, on behalf of organizing team of ENDOSURG, I welcome all the distinguished faculties, all distinguished our guests. I can see many senior surgeons and teachers there in the auditorium. Also, there are more than 20 medical colleges. They have joined online across the country. So I welcome everyone for this 4th edition of ENDOSURG. So again, I will be demonstrating basic steps of diagnostic endoscopy. I will just mention few important points which I feel it's very important while learning endoscopy. What I keep telling everyone, those who come to me, that pushing the scope in the stomach or duodenum is not endoscopy. So each and every moment should be meaningful and purposeful and scientific. So if you master these techniques of pushing the scope and coming out, so half of the battle is over. Another important aspect in endoscopy is the interpretation of the identification and interpretation of the lesions. So it's a long learning curve. So we have to keep watching many scopies, many atlases or videos available online to train your eyes to pick up these lesions. And fortunately now technology is there to help us, support us to identify this lesion at very early stage. So make use of technology very judiciously to pick up these lesions. So what is important, that you must standardize your endoscopy technique, because when you will progress ahead for the therapeutic endoscopy like ERCP, during ERCP the camera is on the side of the scope. It is not at the tip of the scope. So you don't get to see the lumen inside when you are pushing the scope. So unless your techniques are perfect, you will otherwise struggle to push the scope. If every time you aim at, looking at the lumen and then pushing the scope, then during ERCP, you are not able to see the lumen, and it will not be possible for you to then progress. So if your technique are perfect, even blindly, we can, push the scope, what is required during when you are using this side weaving ERCP scope. So as mentioned, so what is the right way is to hold the scope properly. Your this head should be in the left hand with this 3-finger grip and thumb on the big wheel and this index finger for the suction and irrigation purpose. So this is the right grip. Again, you must hold the shaft of the scope at least 15 to 20 centimeter proximal to the tip for any maneuver or pushing the scope. So this is the right grip to start with. So as mentioned by Dr. Ishwar Murthy, whenever you put the scope into the oral cavity, the tongue should be at 12 o'clock position. So that is your right, position. If you see my hand movement, if I even make my hand anti-clockwise, the tongue has gone to 3 o'clock position. Or if I turn my hand to the, clockwise, the tongue has gone to the 9 o'clock position. So this is not the right position to push the scope further into the laryngopharynx. So tongue has to be at 12 o'clock position. So this is a right position. Then push the scope forward till the oropharynx and then turn the big wheel up and push the scope gently. See, I'm making it up and pushing it, enter into the laryngopharynx. I can see the larynx, I can see the right piriform fossa on the right side. And now, once you are in the laryngopharynx, you have to make the big wheel down now. And so that your tip will enter into the posterior aspect of the laryngopharynx to enter into the piriform fossa. So I have make it, you can see I have make it down and I have entered into the right piriform fossa. So once you are in the right piriform fossa, just keep the scope against the cricopharynx and ask patient to swallow. So when patient makes this swallowing efforts, the cricopharynx get open up and your scope gently enters into the upper esophagus. See now, I enter into the upper esophagus. So this is like a blind procedure. You hardly see any cricopharynx when you are crossing the cricopharynx. So once you have crossed the this 15 centimeter, then it shows that you are into the proximal esophagus. So once you are in the proximal esophagus, now with this rotatory movements of the head and the shaft, we have to keep your scope in the center and keep examining the esophageal mucosa. Don't spend too much of time and don't inflate too much of air at the when we are pushing the scope inside. So I am just now going inside, watching, keeping my scope in the center of the esophagus. And once I come to the esophagogastric junction, okay, now you can see here I am at 40 centimeter, and you can also see the in the endo view there is a esophagogastric junction which is patulous. Okay, so at this stage the esophagus is on the posterior aspect, and while entering into the intra-abdominal portion, it turns posterolaterally. So to achieve that entry into the stomach, what we should do? Again, big wheel, a little bit up, and the head anti-clockwise. See, I have entered into the stomach without pushing the scope harshly through the this lower esophageal sphincter. So once I have entered into the stomach, I am facing at the greater curvature to the stomach. So what you should do, again, if you just see T. So you have to always, scopes doesn't travel into the air. It always, takes the some luminal wall to take the, to turn in right side or left side. So when we want to go to the pylorus, the scope must move against the greater curvature or the entry wall of the stomach. So for that, I am turning the big wheel up like this, and against the greater, I am turning my head clockwise like this and pushing the scope. See, the pylorus is in front of you, without doing any great efforts to reach the pylorus. Again, I will show you. I am now at the esophageal junction. Okay, this is esophageal junction. Big wheel down and the anti-clockwise. I have entered into the stomach. Inflate a little bit air. Don't inflate too much of air. And I am seeing the greater curvature here. Now big wheel up and head turning clockwise like this. See, I am at the pylorus. So this is. Once you see pylorus, again suck the air. So what if the stomach is inflated, deflate it. If stomach is inflated, you will take long axis to reach the pylorus. As I mentioned, the scope will always move against the greater curvature. So in the distended stomach, the greater curvature will be long, curve, and so it will be looping of the scope inside the stomach. So against the greater curvature, I am reach the pylorus. What happens if the stomach is over distended? The pylorus become eccentric. It is not at the end on. So you will not get end on view. The pylorus will live on the side of your view, and you will struggle to enter into the pylorus. So I have entered into the duodenum. So this is the first part of the duodenum. Now you can see all this anterior wall, posterior wall, inferior, and the superior wall. So what we have to do, again, push the scope, touching it very close to the anterior wall of the duodenum. Don't push it hard. Then this big wheel up, small wheel right, and turn it clockwise like this. I am now pushing the scope, and my scope is inside now. Can you see this? Okay, so I have entered into the second part of the duodenum without pushing the scope from first part to the second part. Okay, so these patients already stenting has been done before for the gallstone and with CBD stone. And now you can see, so once we have finished the second part, as I mentioned, what we have to do, that we have to lock the scope, big wheel, small wheel right, and pull the scope, straighten the scope. You will see that the paradoxical movement of the scope. When you are pulling the scope, the tip is moving inside. So that happens because we are straightening the scope. So in this maneuver, the scope will go up to the end of the second part of the duodenum, and it will give you opportunity to peep into the third part of the duodenum. So if you are suspecting any pathologies in the third part of the duodenum, like superior mesenteric artery syndrome, or there any lesion is there, definitely you can see, and if required, you can take even biopsies also with the side weaving scope. Okay, so then withdraw the scope gently by examining the second part of the duodenum, and then you will fall into the antrum. So once you see the antrum, again, at the antrum itself, inflate more gas, air, and turn the big wheel up. So you will see the incisura. Okay. Once you see incisura, turn your head anti-clockwise like this. See. Now I am seeing the stomach lumen, and then pull the scope. So I am now able to see this J maneuver with the esophageal junction and the fundus. Now you can see here, once you are done examination of the fundus and the esophageal junction, as mentioned by Dr. Ishwar Murthy, that in case of hiatus hernia, So it's very important aspect of seeing the esophageal junction from the J manure to classify the hiatus hernia as per the Hill's classification. So once you have done that, then again you straighten the scope and see the whole body of the stomach from the fundus. Okay. So what I noticed during J manure is there is a large ulcer at the incisura. Can you appreciate ulcer here?
Yes, yes.
Huh?
Good morning, Pravin.
Good morning.
I'm Dr. Makaran.
Yes, welcome Makaran.
Yeah, thank you.
Great. Nice to see you here.
Thank you, thank
I'm
you.
sure we will make all these sessions very interesting. Okay. So
Yes.
this is, how important to do all the manure before you label that this patient is normal or, I have done adequate examination. If I would have not done this J manure, I would have missed this ulcer. So initially when you don't easily see this lesser curvature when you pass the scope. Now I am in the, I am in the this esophagus. I have gone into the stomach. I am seeing greater curvature. I am pushing the scope and entering into the pilars. I have very, easily I have missed the incisura, and you will able to see only when you are doing this J manure like this. Is it clear?
Looking at the ulcer characteristics, what is your suspicion?
So whenever you see ulcer like this, this is at the incisura. So this is the commonest site to have gastric ulcers. Okay. So whenever you see such ulcer, you must start examining this ulcer from the floor of the ulcer to the edges and the surrounding mucosal fold. So everything has to be examined carefully, and you must differentiate whether this ulcer is benign ulcer or malignant ulcer. So as far as floor of the ulcer is concerned, in benign ulcer, we can see very clean, even floor without much significant slough at the base floor of the ulcer, or it will not bleed on touch very easily. In contrary to that, the malignant ulcer, the floor will be uneven. There will be a lot of necrotic areas on the floor, and also you can see the many bleeding sites if it is a anaplastic growth, and even it will bleed very easily on touch with the biopsy forceps.
Is there any use of NBI in?
I will come to that. I will come to that.
Okay.
Okay. Then you must examine the age of the ulcer. In benign ulcer, as you see in this case, edges are sloping edges, and they are regular. They are not punched out, or they are not well-like edges. So benign ulcer, sloping edges; malignant ulcer, punched out, or the everted, this undermined edges. And then the margins of the ulcer. Again, the benign ulcers, we can see margins, they are smooth and the regular. Okay. But on the malignant ulcers, margins are either they are rolled out, or they are nodulars, or they are irregular. Then you must examine the surrounding mucosal fold. Okay. So this surrounding mucosal fold, if you can see here, this mucosal fold, that you should see you must suck the gas. If the stomach is distended, you really don't appreciate this mucosal fold. If you see this mucosal fold, they are ending till the margin of the ulcer. So this is the sign in a benign converging edges. But if they are disappearing in between, or if there is a nodularity, there is ulcer here also, multiple ulcer.
Hello, good morning, Pravin.
Yes.
Dr. Katneshwarkar here.
Yes, sir,
sorry to intervene. For the newcomers or for those who are starting endoscopies, how would you measure the size of the ulcer?
Yeah, definitely.
So
I will come to that.
Okay,
Yes.
Okay, right.
Yeah.
Please go ahead.
Yeah.
You are very nicely demonstrating. Yeah.
So again, so you must go step by step. Examine first the floor of the ulcer, then the edges of the ulcer, margin of the ulcer, and then the surrounding mucosal fold. If the surrounding mucosal fold like this, if they are ending up to the margin of the ulcer, then mostly it is a benign ulcer. But if these mucosal folds are getting cut off before they reach the edge of the ulcers, this happens because of the submucosal spread of the tumor. So you don't get that typical mucosal folds in the surrounding gastric mucosa. And or if there is a nodularity, so there may be submucosal nodules because of the submucosal extension. So in that case also you get nodularity on the surrounding mucosal folds. So this is how. The next come, as you mentioned, is the size of the ulcer. If the size of the ulcer is less than 6 centimeter, mostly these are the benign ulcers. But if it is more than 6 centimeter, they are large ulcers. Every ulcer, but if you are picking up the early gastric malignancy, so even in small ulcer, there will be high chances of malignancy. So now size really doesn't matter. So any ulcer, on the morphology, we have to identify, we have to suspect whether this is benign or malignant. But whatever diagnosis you have on morphology, biopsy is mandatory for every gastric ulcers. To pick up these early malignancies, even if you are thinking these are the erosions, even you must biopsy these erosions to pick up early T1 lesions in the stomach.
Though there are some characteristics
again,
are just benign,
there
are some characteristics that makes me wonder whether it could be malignant also.
Yeah. So again, as I mentioned, that now the advanced gadgets, help of this advanced gadgets like narrowband imagination. So you must use this, in such cases to further differentiate between the benign and the malignant ulcer. So the mucosal pattern and the, can you see now nodularity here?
Yeah, that's right.
Here. So this, now we can appreciate this nodularity on the narrowband imagination. This is the ulcerated necrotic area and this is the nodular area. So this, you must examine this nodularity for the mucosal pattern and the vascular pattern. If there is a distorted mucosal pattern or distorted vascular pattern, then you must suspect malignancy. So to take biopsy in such a large ulcer, to identify from which area you should take biopsy, this NBI will definitely help. So the margins, where the margins are more irregular, where the mucosal, I will just freeze it. एक मिनट Can you see this mucosal pattern now? Hello?
Yes.
So this is, you can see this is quite fairly regular mucosal pattern and without much distortion of the submucosal vessels. So this, now you can see clearly. So
yeah,
we'd like to,
I agree, yeah.
Huh?
But
Yeah.
the one at 1 o'clock position, just on, there some corkscrew vessels and that's where I was.
So this, you must do very careful examination of whole margin of the ulcer and take biopsy from the highly suspicious, area. So so this is how this NBI of great help to take biopsy from the suspected site of the malignant transformation.
Yes.
So I think this is the, okay. This is the site where we'll take biopsy from the margin.
How many biopsies are advised, Pravin?
Minimum 6. Minimum
6 to 8 bits.
6 to 8.
Okay. Good morning, Ishwar Modi, sir.
Hi, good morning.
So now you can comment, Ishwar.
Yeah. See, this is a very nice demonstration of ulcerative lesion along the lesser curvature. Very important thing for beginner as a surgeon's perspective, how close. See, it is very close along the scope, and so it is on the lesser curvature, and it is a multiple nature and a clean base, and also, the slopy margin makes you think or suspect it could be a benign. But having said that, because of the size of the ulcer being quite large, and the areas, like especially in your monitor at 3 o'clock and also at 6 o'clock with a multiple nodularity, I put my money on malignancy as a first diagnosis. So because of that, you need to have, and the biopsy forces of choice I will use is a tooth forceps preferably, because I'm sure it is going to be a little curious. Do you feel it is chunky or how you?
Yeah, it's a tooth forceps.
Yeah.
Yeah. And see, another important step whenever you are taking biopsies, that paper le lo. Idhar rakho. So what we do in our institute, so we keep these blot papers ready like this. Ye dekho.
That's
Ye dekho. Can you see this blot paper?
Yes, yes.
Huh?
Yes.
So we take this tissue on this blot paper, open.
Is this cup having spike?
Yes.
This forceps doesn't have spike.
Ideally
but if it is from the side wall, from
Yes,
esophagus, esophagus or colon, then this spike is more useful. But if it is end on bite, then the more important is the tooth forceps, biopsy forceps is useful than the plain cup biopsy forceps.
Yes, yes. Some companies have produced side bending biopsy forceps also.
Yes.
For wall biopsies.
Yes.
Lateral wall.
So what is important? So you take this tissue on this blot paper, and that blot paper you put inside the formalin like this.
Yes.
Okay. So that because these tissues are very small tissues, they are not big tissue, so they easily, otherwise these pathologists can miss them, and they get stuck on the side of the container or at the this cap of the container, and then they say there is no biopsy specimen. So always put it on the this blot paper where it gets stuck, and then you put it in the this formalin container. Always most important thing is label the container before you start collecting the tissues.
Yes, Pravin?
Yes.
In my practice, I usually get the large piece and remove it with scope while withdrawing the scope, so that we will get the large piece. Because when pulling the biopsy forceps in the channel, there is some tissue loss.
No. See, we expect that the chunk of the tissue will be there in this cup of the forceps.
Yes.
Okay. Open. Catch. So take biopsies from the most suspected lesions. Otherwise, minimum 6 biopsies from the different quadrant of the edges, including suspected area where there is a nodulatory at the floor of the ulcer. If you are seeing vessels at the floor of the ulcer, avoid taking biopsy. If there is a stigmata of recent bleed at the floor of the ulcer, if there is a clot or if there is a pulsatile vessel, then again avoid taking biopsies from that side.
What is the challenge in patients with a suspected linitis plastica? Because very often you get so big an ulcer, biopsy report comes as evidence of malignancy.
Yeah.
If you are going for a second time, what are the other additional precautions you will take?
See, open, 1 minute. Until unless don't take back. Open. Catch. So whenever you are taking biopsies, your one cup should be on the floor of the ulcer,
Yeah.
and another cup on the margin of the ulcer. So you take, tissue exactly at the junction of the this edge and the margin of the ulcer. So there are high chances of picking the malignant tissue. Again, don't take biopsy from the necrotic part of the ulcer, because that is already necrotic tissue. It will not give any information. So this necrotic part of the ulcer is easy to catch, but they are not good tissue for the diagnostic purpose.
Pravin, can you demonstrate Wells technique?
एक minute. So as mentioned, as Ishwar Mutiada asked for the linatus plastica, open.
Yes.
Ishwar Mutiada in linatus plastica, the challenge in linatus plastica, how to first suspect linatus plastica is the whole stomach, the mucosal folds, they are conglomerated, they are very crowded, and in spite of insufflation, they will not be, stomach will not distend adequately. So in that situation, biopsy, catch, open. You must suspect it is a linatus plastica. So in linatus plastica, what you should do, as you ask, you should take well biopsy. So what is well biopsy? At one point, you take multiple biopsies. You discard the initial 2-3 bites, and then you collect the deep bites. So you make sure that you are reached into the submucosal plane, and from there you are taking tissue for the diagnostic purpose. So that is well biopsy. So it should be done whenever you are suspecting linatus plastica. Okay?
Yes.
So now what I will take, I have taken 5 from the margins. I will take 1 from this floor at this nodular part. Open.
Is it advisable to take laparoscopic full thickness biopsies if repeated biopsies are
Yes. So if you are, you should do CT scan in such cases, and if CT scan is showing there is a thickening, submucosal thickening of the stomach, which is more than 6 mm, then you should do diagnostic laparoscopy and take full thickness biopsy, because if it is limited to the this distal part of the stomach, definitely you can offer surgical cure to this patient. But it is whole stomach is involved, or it is extended into the if it is advanced for the chemotherapy, you need tissue biopsy.
One of the other standard of care is consider endo-ultrasound guided FNB, because that will do the T stage better, and also you'll be able to take a biopsy. That's also equally now, because the laparoscopy, you have to go from outside in. There is a chance of you are spreading it, theoretically at least. You may be able to take peritoneal tissues, but as such, I think for the stomach, you should persevere endo-ultrasound.
So again, I am withdrawing my scope, suck all the air from the stomach, and then examine esophagus in detail while coming back.
Thank you. Excellent demonstration. We discussed the characteristic of a large, giant gastric ulcers, and the tips and tricks of taking a biopsy, benefits of toothed, non-toothed forceps, number of bits, and the pathologist version, and troubleshooting like a well biopsy. Well done. Thank you.
Thank you, Pravin. Nice demonstration.
Thank you. Next.
We'll now be proceeding with the next case. 56 years old male came with chief complaints of pain in abdomen, nausea, vomiting, and dyspeptic symptoms since 15 days, history of alcohol intake since 36 years, and chronic tobacco chewer since 36 years. USG findings were suggestive of liver parenchymal disease with mesenteric lymphadenopathy, and CECT was suggestive of short segment asymmetric heterogeneously enhancing mass forming thickening involving second part of the duodenum causing gastric outlet obstruction. So as you can see, the yellow arrow is pointing towards the mass in the duodenum, and the stomach is very much distended. We are planning for an upper GI scopy with biopsy, and our learning objective will be management of gastric outlet obstruction.
Hello.
We cannot hear you, sir. Can't hear you.
Hello. Am I audible now?
Yes.
Yes. So I take great pleasure to welcome and introduce my very dear friend, Dr. Kanagwell. He is another great endoscopist and laparoscopic surgeon from Chennai. He is director of GI surgery at hospital, which is located very close to our Chennai head office. So he is a local guardian of our head office, who takes care of all issues there. And he is also a academic in charge of FIAGES academic wing. And welcome sir for Endosurg. In spite of very hectic schedule, he has traveled whole night to reach Sambhajinagar. Thank you so much, sir.
Yes, sir.
And over to you.
We cannot hear you, sir. Please, someone adjust mic.
Hello. Now we would like to felicitate the chairpersons of this session. I would like to call upon Dr. Chabra, sir, to felicitate the chairpersons.
No problem, sir. You're okay, ma'am? Hold like that. And then you change your hand. Change, leave this. Support. And then?
Thank you, sir, for chairing this session.
All right. No, okay.
As we move forward to our next scientific session, it gives us privilege to welcome our next esteemed chairperson, Dr.
okay.
Sri Krishna Kartneshwarkar, sir, and Dr. Santosh Somani, sir. Sir, please kindly commence the next scientific session.
Friends, warm welcome to you. Am I audible at the hall, please?
Is sir audible?
Am I audible to the hall audio team? Can you please check?
Yes, sir.
All right. Good morning, everyone. It's been a pleasure, and year we are here at Aurangabad to now Sambhajinagar. So we have a state-of-art device. In fact, this is the very latest 4K device, the EVIS X1 Olympus. And you have all the high-end assistance where it's like running from your mobile phone camera to a digital single lens reflector cameras, DSLR cameras. So it has all the facilities. You can go for light subtraction, yellow light, so pink light. So all these options are available. And then you can zoom selectively, and optic zoom itself is an advantage here so that you don't lose any vision. So I have the luxury of the anesthesiologist herself directly giving sedation. We certainly need to discuss a little bit about sedation, but then I think madam has given fentanyl and propofol, right? Yes, so that is usually a dual drug combination is to be administered in the presence of anesthesiologist. If it is a single drug combination, maybe you can attempt with midazolam alone. But then if you are going for a, this is a little tough proposition where you need to discuss with your anesthesiologist what case you are doing. This is a case, I was informed the patient is on starvation for the last 2 days as the CT has revealed outlet obstruction. Usually we have a policy of preparation of these patients with nasogastric lavage. Adequately has been done by the department. So they have kept him on starvation for a couple of days, cleared off. We use normal tap water. Aerated water also to an extent helps. But the written efflux helps you to understand whether you are prepared adequately. With that information, we will go step by step inside. So typically patient is in the lateral position. But as you evolve into your more into an advanced procedure, you can start doing supine scopes also. So now we are going to enter
I have a comfort of having a resident holding it. So depending on what position you have, you can go for entry into the, you can see that dental hygiene is not that very good, possibly consuming tobacco. I am going to hug along the tongue. See, you get to see some inflamed tonsils also. You can get the tonsilloliths. Document, spend some time in the pharynx. This is a uvula. You can see the other side of the tonsil not that much inflamed, but this side of the tonsil is certainly inflamed with the punctate pustules coming up, and you can see the degree of inflammation in the tonsils. All right, so as much as possible, don't touch this palate. That's the most important thing I would like to tell all the beginners. It is very easy to stray along and touch the palate, then it becomes unpleasant. All right, so stay along close to the tongue, and then as been repeatedly told by both Dr. Ishwar sir as well as Dr. Pravin sir, keep the tongue along the roof. That's a very simple and safe approach. And then there you enter from the oropharynx to the hypopharynx, where you get the epiglottis. Spend time to see above the epiglottis. This is one area people should learn at the beginning of their career. So this helps you to understand and exclude laryngeal reflex. So this is a normal vascularity. You can see the mucosal vessels are not that very inflamed, and they are sparse and looking normal. But when you see severe laryngeal reflexes, then you get inflammation around here. But here I could see a little bit of dilated veins, not a very common thing here in the pyriform zone. But let us go inside. Again, you please examine the laryngeal inlet. This is a very favorite thing for the anesthesiologist, I am sure. But as the endoscopist, you should see whether the cords are moving. There will be a bit of mist as the patient is breathing. Generally, if the patient is deeply under anesthetized, you may not appreciate the cords moving. But as you come out, when the plane is little lighter, you can appreciate the cords moving. This looks, the cord is in neutral position. Both the cords look quite active, and the vascularity and other parameters of arytenoids and other things are looking pretty normal. Now you can see both the cords moving. They are fairly approximating well except the 6 o'clock zone. Now we move on down inside. This is the right pyriform fossa. This is the left pyriform fossa. All right. So take time off. Now you go inside. As you say, now you have gone past the cricopharynx. I have gone deep into the upper third of the esophagus. Otherwise, the supracarinal and the infracarinal are the typical thing. You get to see first the aortic pulsation, then the atrial pulsation. At times, if it is a very thin patient, you can see the left main crossing over as an impression also. So the first one to cross is the arch, the second one is to cross the cardiac impulse itself. Normally speaking, a full esophagus is seen all around in a single window. If the esophagus is, you are not able to see the entire circumference, it means it is ectatic. So ectatic esophagus can be because of age or because of some form of pathology also. So we will move on. This looks pretty all right. This gives a rough clue how much of heart rate you are dealing with. I have the comfort of having a very senior anesthesiologist, madam, so I can concentrate on the endoscope. That's the next thing we'll be discussing. You can see some abnormalities here, little bit. So this is about 28 centimeters. That makes it infracarinal. Possibly this is because of the stasis of the gastric outlet. We'll re-inspect when you are going to come back. You can see the inflammation here. You can see the type of inflammation. If you are in doubt whether you are dealing, this is the yellow light scope. Yellow light is useful only for bleeding manifestations and control of bleeding. Now, if you see there is an element of doubt whether you are dealing with mucositis or mucosal inflammation or mucosal lesion, unsure, then you go for narrowband imaging, where you can typically see the degree of inflammation which is happening. There is certainly something which is fishy here. We'll come back to this little bit later. So I am going to enter into it beyond. You can see the severe esophagitis because of the stasis. This is a bit ectatic esophagus. You can see linear ulcerations because of multiple or long-term reflux of acid and probably bile also. Let us see what we are dealing with. So now we are slowly negotiating, going into the GE junction. Little bit of granularity I could see. Can you appreciate, all of you? So this could see, there you can appreciate little bit of filiform changes happening in the esophagus. Let us try an NBI. Now you can identify more and more filiform changes in the lower end of the esophagus. With that seeing, we will enter into the stomach. In this area, possibly because of the stasis, these changes have happened. Esophagus is certainly ectatic. Unfortunately, I think we have to do some more preparation. Let me try clearing in this off. If not, we may need to technically stop pursuing. Let us see how safely we are able to clear this off. This happens. This certainly happens when you have a tight obstruction. This indicates the entire stomach is totally obstructed. I'm trying to clear. Let me see if it is not. Probably we can re-prepare the patient and take up for the scopy. It looks fully loaded with bile fluid. Let me try aspirating. So as you go into the esophagus, just stay at like a bird's eye view. What the bird sitting onto the mountain for a prey. Just get into the esophagus. Never show in the scope. Just go in. Ongoing itself, you get to see a lot of bile fluid. Let us see. Bile fluid technically means the obstruction is beyond. That is beyond the entry of the common bile duct. Or at least some amount of biliary reflex is happening. Is the suction on and it's working? It's working, no? Right. So I am trying to, this looks, because of the preparation, I don't see much of solid element, but then lot of liquid element is there. You can see it is being suctioned. I have almost suctioned now 500 ml. Almost 500 ml I have suctioned. I will try and do clear as much as possible.
Sir, is there any risk of aspiration?
100%, sir, 100%, because I have the luxury of anesthesiologist here to protect the airway. I can certainly try and proceed. But still, they have not intubated the patient. We have just sedated the patient.
Yes, that is
so I am very, very carefully suctioning this, just allowing everything to come into the endoscope rather than going into the esophagus. So I have not gone into the stomach really, just entered into the OG junction. Let us see. Being in the lateral position certainly is little beneficial, because if you are doing supine endoscopy, if in case intraoperatively like that, then you have a risk of aspiration. Here, lying on the lateral side technically protects the airway, but then if the patient is in a lighter plane, this can certainly give a nuisance to both the anesthesiologist as well as the endoscopist.
In gastric outlet obstruction, if it is suspected, it is better policy to put the Riles tube and prepare the patient for 2 days.
100%, sir, I am with you.
Yes, thank you.
So it is fairly now cleared. Still you have some amount of residue at the fundus. This happens. All of us have gone to PG days, getting pulled up for not preparing the stomach well. That happens to every one of us, even at this part of the thing. I think we are fairly okay. Little bit of fundal residue alone there. So I am going to take a chance and go along the lesser curve so that I don't instigate the stomach. The most important thing is, when you have so much of residue, do not attempt to insufflate the stomach. This has been reiterated by both Ishwar sir as well as Pravin sir. If you are going to insufflate, stomach gets stretched and it may have some nauseating results. So I am going to advance the scope. The stomach looks featureless. You don't get to see the normal rugosity. Otherwise, it looks atrophic for my eyes. We go beyond.
Can you tell about the anterior posterior wall, posterior
I
wall.
will certainly tell, sir. I will certainly tell. Sure, sure, sir. So, if you see, I'll come back to, for the benefit of all of you, I'm going to come back a little bit to discuss little more about the orientation of the stomach. So, I've come to the esophagus. So, I'm entering. This we have already seen. This certainly is because of the food stasis esophagitis. You can see multiple linear ulcerations. Sir was asking to orient all of you towards the sides, anterior, posterior, greater and lesser, and then how do you stay? See, this has food residue, so I will be going along the lesser curve. If you see the patient, when the patient is lying on the lateral side, the lesser curve is towards your right. All right. So, I have not turned any wheel at this point of time. I am going to go inside, just entering into the stomach. If you see, I have just come into the esophagus. What I am seeing farther is the greater curve. Very simple, right? I will make life much easier. I have just gone into the esophagus. I have not turned any of the wheels. So, I am just entering. If you see, along the 3 o'clock position is the posterior wall. Along the 9 o'clock position is the anterior wall. What is seen in between is the greater curve. And I will try to show, I am going to take the big wheel towards me. This part is the incisural part, or this part is the lesser curve. So, generally speaking, what you see down on entry will be the greater curve, the rugosity and other things. Along the 3 o'clock side will be the posterior wall. Along the 9 o'clock side will be the anterior wall. And in between the 3 and 9 o'clock will be the greater curve. I am going to show little bit of big wheel is pulled towards me, and I am going to little bit of torque the scope clockwise. So, this is the lesser curve. What we see at 12 o'clock now is the lesser curve. Multiple ways to reach the pylorus have been taught. As you evolve, say start completing 50 upper GI scopes, 100 under GI scopes, you get your own skills. It's like we call it as endoscopic thumb printing. You have your own way of performing, but I will teach something very, very simple here. I have just gone in, I have seen the lesser curve. I am only using the big wheel towards me. I am only using the big wheel towards me and advancing the scope. I am not going to do anything else. I am just going to advance the scope. You get to see the pylorus. Here the pylorus is little bit eccentric, but we will be able to see. You can see the pylorus is placed towards 2 o'clock zone. Little bit of food residue inside the pylorus is also noted. Maybe the outlet obstruction is not at the stomach outlet, beyond into the duodenum. So, the CTS mentioned a probable duodenal lesion. Sometimes pancreatic head lesion can also manifest like that. Let us see what we have in stock. I am clearing the fluid in the duodenum. With the regular endoscope, you can do deep endoscope also. Deep endoscope, I guess this is the lesion. No. So, I could see, I could see probably this is a extramucosal lesion. Let me see if there is any changes inside the mucosa. Still lot of residue is there. You have the advantage of having irrigation pump here. Here being into the duodenum, can you switch on this please? Yeah. So, little bit of flush can be given because if I am in the duodenum, I guess a little more fluid is still there. Slowly we are clearing up. And, sorry, sir. Maybe somebody can show how much of fluid we have removed from the almost I think I am informed 1.5 liters or so of fluid has been removed. See, because of the gastric and salivary secretion, see on an average per day salivary secretion is 600 to 800 ml. You say you have done preparation well, but the saliva should be going beyond into the duodenum. Otherwise, you get 800 upfront there. Gastric secretion, depending on the type of state of fasting, it can be anywhere from 1500 to 2500. So you don't need to blame anyone. You don't think the patient has consumed liquids or in your absence or something. Mere food secretion, like mucosal secretion itself is running to that much amount. So let us re-quantify. I am trying to aspirate as much of fluid from the duodenum. Still lots are there. Till at this point of till D1 it looks quite healthy. I am sure there is an ulcer here also. I am not sure. Let me wash. No, it's not an ulcer. It's a food residue. So there is certainly something which is pushing along. Ishwar sir, what is your take, sir? Mic on. Mic button down, sir. Button down. So as the mic gets in, I am trying to clear more fluid from the duodenum. You can see certainly this is something which is pushing. I would say along the inner curve of the duodenum, there is a lesion which is essentially extramucosal. I think this could be a possible mass arising from the head of pancreas. Let us see if I could see some mucosal. Ishwar sir, what is your take, sir?
Yeah, there is an extrinsic compression in the duodenal bulb anterior wall as you entered.
Yes, sir.
But even beyond that, there is some pooling,
Yes,
suggesting there may be something at the D2.
We'll see,
just
sir.
to go till you suck all the fluid down, that area. See whether you can navigate either with the help of a guide wire or with the scope itself through the channel.
Yes, sir.
With the water irrigation, keep going. Yeah.
Is there any external indentation in first part of duodenum?
We do have, sir, the first part, more along the inner curve zone, it looks there is a mucosal push from a lesion extramucosally. First, let me see how well I can negotiate beyond this and go into D3. See, when you have no geometry or no path, never show in the scope. Just wait for the things to open up. Where locate the anatomy, because this is a distorted anatomy. It is not having the normal passage. I could see the scope does not struggle, but the lumen is not opening up. That's a message I'd like to tell here. I am working in a narrow zone. Normally duodenum, I think earlier two cases, both Dr. Pravin sir and Ishwar sir would have demonstrated the capacious duodenum.
Sir, can you increase the air insufflation pressure?
Sir, I am very gently taking, sir, at this point. Little bit of air I am using, but very little bit of air.
Okay.
Let me understand what I am dealing with, then we can certainly put air. The normal folds itself is missing in the duodenum. I think probably that is a lesion. That is a lesion, yes, sir. So there is dual thing. One is the extramucosal lesion, and I am now just beyond the D2 where the ampulla enters.
Is it something like a submucosal gist tumor of D2?
Possible, sir, possible. Let me see, sir. At a moment, I was able to see, but now this mucosa looks definitely edematous, but I don't see a breach of mucosa here.
Hello.
Yes, sir.
Mucosa looks edematous.
Yes, sir.
There is moment you enter from the pylorus, looking at the lie of the pyloric opening,
yes, sir,
or its regular circular shape, we start suspecting something in D1 and D2.
At this point, let me see whether I am able to negotiate beyond this lesion. I am going to do a little bit of scope shortening because it is consuming the scope.
Yes, yes.
So scope shortening has been done.
Decompression.
Definitely the scope is not that easily negotiable beyond the lesion. Let me see.
Yeah, mucosa is very
I'm
extremely
clearing
dilated.
again. I'm reorienting myself.
Yeah.
I'm shortening the scope. Shortening the scope is when you pull out, but still you retain there. You use little bit of bend there so that the scope remains in the duodenum. The scope becomes more steerable and more maneuverable when you shorten the scope. Otherwise, the scope takes a curve along the greater curve. They don't respond to your push and pull. Even now it is taking a... Sir, it is a wall lesion or extra? All right, sir. Unfortunately, there is no mucosal thing there. Let me see. Once again, coming back, reorienting myself.
Sir, can this be eosinophilic enteritis?
No, sir.
Jejunitis?
100% no, sir. Eosinophilic enteritis is something totally different. We will discuss, sir. That is definitely you get to see a mucosal inflammation.
Yes,
I am
sir.
taking the greater curve route here so that the scope remains more stable. So once again, we are going into the D2.
Are you able to locate the ampulla?
This is a straight wing
It looks
scope,
like
sir. I will
this
not
is
be able to
someone-
look
no,
for the ampulla at this point of time.
Yeah.
Anatomy is distorted, so it's
Yes, sir.
Completely disturbed and the mucosa is completely edematous.
Maybe I will
Something
request
in the
Pravin sir
ampulla-
to do a EUS for this patient.
You could consider passing a guide wire. Over that you
Pass
go
it.
whether you
Yes,
can
sir,
go
that's
another.
the next plan, sir.
Hmm.
That's the next plan, sir. Yeah. I think the
Looks
scope
like are
has
you
not
at
been
D2
able to
to
go
D3,
beyond the
I think.
lesion. I think Pravin sir unit is blessed with so many learning opportunities here, because normally workshops end up having not of normal
definitely
endoscopes.
challenging
Here
case.
I think he has meticulously collected for the audience across the country to get benefited.
Is there any scope to use enteroscope in such situations?
Sir, possible, sir, but let me see, sir, how much I am able to negotiate here. I am taking time to understand
yeah,
because
needs
time,
patience
duodenum
and
is a
keep
very
going,
soft
doing it.
fellow. It's I don't want any trouble on that side.
And
Can
if
we
we
have a 0.032 guide wire, please? Guide wire. Certainly, it is not taking the scope beyond that. Probably it is still narrowing than 9.8 millimeter of the scope diameter.
Patient is sedated or
So, sedated, sir, adequately
Yeah.
sedated.
will Buscopan help in this situation?
No, sir. Buscopan certainly will not help, because only Buscopan helps if you are not able to get into the pyloric opening, because that is where the Buscopan is some use. But sir, all of us will agree, if you are using Buscopan, then certainly you need to be little more wary, because the sort of a post-operative ileus feeling, the distension feeling remains in the stomach for a longer time. Sending the patient, especially with the background of possible obstruction. I'm trying to advance this.
Sir, which guide wire you are using?
0.032. I think what make, I'm not sure. What make is this? Boston Scientific guide wire, sir. This is a soft tip guide wire.
Yes, yes.
Floppy, I would say. I'm not sure it is taking. Let me see.
Distensibility is very much compromised.
Sir, that part
Yeah.
is a bit
Yeah.
narrowed. Let me see. I am able to take the guide wire.
and in any endoscopy, if you cannot see, don't push.
Of course, 100% I'm with you, sir. looks like a long-standing. I could get the smell of fluid, what is coming out is followed.
It's a long-standing obstruction.
Possible, sir.
In this view, around 11 o'clock is
11 o'clock
that
you want to
ampulla
try
is
there,
there
I can
or-
try there, but
Yeah,
I can try,
Yes,
no problem. But
ampulla is there.
I don't think there is
Now 11
anything,
o'clock.
the lumen is not there. Let me try, sir, no problem. Nothing wrong in trying. Possibly that is the narrowed part. Let me see. That doesn't look like, sir.
Left side is open.
Left side is the opening, certainly. First time, I think, once we got access to that.
At one time we could see it partially.
Yeah, once we partially see, yes, sir.
Yeah.
Yes, I think that is.
It's not taking the guide wire, sir. Guide wire is returning back. This looks like the lesion.
Mostly
But,
you are
even
hitting
I
the
won't
lesion.
say it is a biopsyable pathology at this point with the
Yeah,
regular
it will be
biopsy
difficult to
code.
take a biopsy.
Yeah, no, biopsy could be taken, sir, but may not be representative of the lesion.
Yeah.
As such. Let me still see, sir. Pravin, sir?
Sir, can you push some water and try to distend the lumen?
I'll try, sir. I'll try, no problem. Because of the pylorus patulus, sir, it is not having the desired benefit. Technically, it has consumed. One second, this looks.
He's here, Dr. Pravin.
Sir, would you like
Yes,
to
yes.
try this once by?
No, no, what I think we should do, I think you can take biopsy this way. Yeah,
Sir, this,
because
from there also, sir, it looks like more of a extramucosal lesion.
No, no. Let me try.
This scope is even guide where I could not pass beyond. This looks like the probable potential opening. Once I was able to see, I guess, sir, because I'm not sure.
Only once we could see it.
So, yes, sir.
You can take, and pass the biopsy person.
Yes, sir.
Feel the indurated lesion.
Okay.
Take blind biopsy.
That's sir.
To be positive, it's fine.
Yes, sir.
Otherwise, we can make with patient consent, we can take US guided biopsy.
You want to demonstrate US, sir?
Now we are at
Okay, sir. Okay.
So this you can try.
I can do biopsy, sir.
Indurated portion. Feel the
Yes, sir.
indurated portion with the biopsy.
True, sir. True.
Blind biopsy. So on CT scan, I can see
Yes, sir.
there is a circumferential lesion
Yes,
on
sir.
the duodenum.
Yes,
you can
sir.
see some part of lesion.
This part looks unhealthy, sir.
Yes, yeah. So you can biopsy. If
Sure, sir.
always you can explain patient there are chances that we may miss the the target
Definitely,
lesion.
sir.
Still, if it fails, then we can go ahead with the EUS guided biopsy.
This part looks.
Pravin, can we flush with 50 cc of water and
Sir, we
try
have
to distend?
flushed with more than
Sir,
200,
this,
300.
this.
Yes, sir. I think I
You
was
want me
able to
to-
see. I was able to see for a moment, sir. Sir, you wish to try, you try once, sir. No problem.
I will try.
Please try. Sir, give a glove to sir.
Yeah, we are giving.
Sir, can you show the attachment of water jet to such advanced
I think
endoscopes?
I will ask the camera person to do, sir.
Yes, yes.
This part looks suspicious pathology, but one second. I could see a bit of difficult look. Want to try, sir, please?
Change of the position of the patient, will it help, sir?
First, let us see, sir. Pravin sir is attempting now. The scope is recruited fully, sir. Maybe you can shorten the scope.
Mucosa is not healthy, may get perforate on pushing.
It's okay, sir. Yes, sir.
At the third part of the duodenum. So you are already explained to the relatives that we will make an attempt. If we can, we will have tissue. Otherwise, we will do EOS guided. So with that proper understanding, this patient has been taken for this procedure. So again, all this difficulty you must anticipate before. Yeah. Biopsy.
This is the only suspicious.
Can you see
part.
this suspicious lesion here?
Sir, maybe put NBA, sir, if something is taken. I want to try sliding scope, sir.
Yeah, open. See my biopsy first was gone inside this narrow portion of the lumen. Can you appreciate?
Yes, sir. Yes, sir. Will it be keep the biopsy forceps closed? Can the biopsy forceps guide your scope inside, sir? Is that possible? Gently attempt.
But this.
If it is
biopsy
not,
forceps
I
no
think-
perforate.
I know, sir. I know. Just curious.
Open.
I think, as you say rightly, we'll take biopsy from this unhealthy zone and. Pravin sir, they're keeping a microphone for you, sir. Yes.
These are really challenging cases to take biopsies, but with proper understanding, we definitely can make an attempt to have tissue for the diagnostic purpose. Otherwise, second option is the EOS guided biopsy. So if possible, tomorrow we can demonstrate EOS guided biopsy.
After taking the proper consent for you.
Yes. Open.
Pravin sir, what is your take on multiple chunk biopsies in one go? That the one which has a long cylinder, do you use that and recommend?
Pardon?
Taking multiple tissue bites, multi-bite biopsies in the same passage?
No. See, if we are taking blind, then I don't think
Of course.
we should do
yes,
that.
sir.
Duodenum, because it's very, the wall is very fragile, thin wall, so better not to do there, like well biopsy in the duodenal lesions.
I'm with you, sir. I'm with you.
Yeah.
Can it be
Yeah,
lymphoma,
good
sir?
chunk of tissue. Wait a minute. If you give me. Show this tissue. No.
Zoom.
Can you see this biopsy tissue?
You get a wet tissue. Can camera person take it closer, please, to share index finger and.
If you get strip of tissue, mostly it is a normal tissue. But if you get a,
Variegated type of tissue. Yes, sir.
tissue, then mostly it is a
Pathological zone.
tissue. So we have this variegated tissue, so hope
We get some yield of it.
Cunning.
Fundus side I have not completed.
Okay.
Maybe you can see little bit of food residue and GE junction. You please inspect and come out. Lot of food residue.
There is some food residue.
So we suck the superficial component of fluid alone. Maybe this becomes an incomplete study, and then we can again prepare tomorrow well and take up the remaining part. No other finding except for little bit of atrophic mucosa. Lesser curve is well made out. All other points are taken. Little bit of food residue is still there. So probably today again they can go for preparation, and tomorrow you can keep for EUS assisted study. You can stasis esophagitis.
Next कौन सा बोले सर?
Stasis.
सर ने कौन सा बोला है लेने को?
Thank you, sir. Thank you, madam. Thank you, team.
We'll now proceed with the next case. 80 years old male came with chief complaints of difficulty in swallowing since 1 month, liquids more than solids, and pain in abdomen since 3 months. He was operated case of radical gastrectomy for carcinoma of esophagus with esophagojejunostomy done and jejunojejunostomy. This is the post-dilatation video when dilatation of the stricture was performed for the first time. We are planning re-evaluation and SOS stricture dilatation. And we'll be discussing about the management of esophageal strictures. Over to you, sir.
Case 5, day 1 of Endosurg here. And this case is a classical demonstration to emphasize the fact why a surgeon should be doing endoscopy all along. Because when you have a patient who has had a surgery in the last few months or years, and the surgery post-operative complications like stricture or any other associated, I think we know the anatomy, what we have created, and we will be able to understand better, and we will be able to alleviate whatever problems he has come with. I understand he has some degree of dysphagia, and it was suspected to have an anastomotic stricture at the esophageal anastomosis. And the esophageal anastomosis is something like a end to side anastomosis. So I'm hoping to see a blind pouch and also a direct esophageal. Let us see. So I am in theater 3 where the Fuji filmed 8,000 things. So you've been watching the Olympus in action, now Fuji, and we have the comfort of anesthesia being given with Tiva propofol, and the patient is already in a supine position because of the possibility we may use a screening, and with the patient's head turned towards me with a table at my waist level, I am holding the scope in my left hand, and I am just passing the scope. Can we put the light on one more time? Yeah. As we keep on emphasizing, station 1 is a oropharynx. Okay. Here is a station 1 tongue. In your monitor, 12 o'clock, short palate at 6 o'clock. Then you go in between slowly and watch this tube and the airway, and then go beyond that, beyond the, and you see a glimpse of epiglottis. Then go beyond that.
Meanwhile, good morning, everyone. Tea and coffee are being served outside the conference hall. Please feel free to avail the refreshment while the session continues. Thank you.
Yeah, yeah. So I enter the esophagus. Let us stay in the upper 1/3 of the esophagus, and you have a clear view. And as you come around 25 centimeter, normally we will enter the esophagus at 15, exit at the Z line around 40, and around 25 you sometimes notice a little degree of extrinsic compression, and even here something looks like a pseudo diverticulum like appearance. It is not diverticulum, and this is the left bronchus level. And then what you and all of us can recognize is a pulsating left atrium seen around 30 centimeter from the incisor or teeth. That immediately puts, which is the anterior wall of the esophagus, that is a pulsating heart. and just behind is the vertebral column. That is, so it is important to orient yourself, especially when you are able to do a myotomy, whether you are going to do anterior myotomy at 12 o'clock in your monitor or a posterior myotomy at 6 o'clock. So I just keep insufflating and then keep going down, and this is where we are going to see the anastomosis, and immediately you are going to see a two roads. So which one to take, which path to take? So this is the million-dollar question. Now, and I've been told, because that's a very important thing, try to read the reports, and if they've done a previous endoscopy, they might have seen where exactly. So I've been told whatever on towards here, this is the blind lobe, that is around 10 o'clock, and this at 3 o'clock, this looks like the normal passage. Just let me just confirm. Let us come back a shade. Yes, we'll check again. So this is the blind lobe, as you can see. So we come back. I think, it looks okay, and there is not much. If you see, there is a little fibrosis. Can you see? There is a circumferential fibrosis. So what do you do in that situation? We'll just station ourselves in the efferent loop, or the loop in which the food is going to go, and fix my position there. Just hold the scope. Can we just have the screening done? And what I'm planning is to pass the guide wire as a path to take, so that I know that we are in the right track, and retreat the tip of the scope a little backwards. As all of you should know, as a beginner, the trajectory of the thing, usually around 7 o'clock here, as you can see. Just let me come back a shade. Just hold the scope. Hold the scope. So I just actually, I don't want, the dilatation should happen right at the anastomotic site, giving importance to the efferent loop, like this. Just hold it like this. Hold the scope. Rotate it like that. Now you pass the, so what I'm planning is, it is much kinder to do a dilatation under vision, so that we have the TTS balloon. Through the telescope, balloon is available. It will not go through the scope. The 18. The channel will go. Okay, is it not? Okay. Should go through the balloon. How do we know? Okay. Just hold the guide wire for a minute. Let me just see. Which is the, is it not going through this? It will go through. See, you crunch it, it will go through. Through the, through the scope itself. Normally, what I normally do is through the channel, because the channel here, what is the channel? Is 2.9, isn't it? So the channel is quite big. It should have gone through this, but now we are going to do what we did with the Savory. Directly, we are pushing. Can we just screen once? Let me just see the wire where it is. So we know where roughly where the scalpel, that is where the anastomosis, and the guide wire continue to progress beyond into the efferent loop. We keep it as a reference point. We'll try to push the balloon push, pull, pull, pull. Can you suck? Pull. As you can see, the balloon is going, but ideally this balloon, personally I feel, this could easily can go through the scope, but one of the problem is when you use repeatedly through the scope, the balloon gets damaged. So the longevity of the scope, I mean the balloon, will be lost after 2 or 3 times. That's why I'm sure here the unit policy maybe because they wanted to preserve the balloon also. So let's go by that. Otherwise, I tend to put it through the channel itself. Very well can be done. The second important thing is you need to make sure the whole thing is straight. Otherwise, it will not go easily in. Let me just screen one more time. Let me just see.
Hello.
Screen.
Size of the balloon?
Yeah. Keep it there. Yeah.
Hello.
Yeah.
Size of the balloon?
Size of the balloon is 15 and to 18. Just hold this. Just hold this. So what we are going to do is we are going to keep the scope along. So scope along techniques. So we could have pushed it through the scope also, but we want to be kind with a balloon. That's one of the reasons we are doing this technique. Otherwise, you can do the other way, which I usually do it. And there are...
Under the vision of scope.
Yes. Because you need to know exactly whether the balloon is in the right place. So you can see at 6 o'clock on the monitor, the balloon has gone. Let me just see how far. So this torquing, you can see, can you just keep the scope in like this, hold the scope. I just bring back the balloon catheter a little backwards, pulling, because it's gone beyond the required length, and it is 6 centimeter length, so you have to be ultra careful. Can you see now? It is just started. Yeah, just to rotate the scope. Yeah, rotate the scope. Yeah. Yes. Can you just start inflating? Can you screen one more time? So where you can see the tip of my scope, and now what we have done, just for people to understand better and also for me to have a better orientation, we fill the saline. See what he is having on my assistant is something like an Alliance gun, which will control the radial expansion of the balloon he is going to do. So as you just pump in saline, which is actually not simple saline, along with a little bit of contrast. Can we just screen one more time? Let us see whether, have you screened? Yeah, just screen. Have you, yeah, keep putting. Yeah, keep on, yeah, keep on doing. Keep inflating. Keep inflating. Keep going. Screen one more time. Is it screen? Please screen.
How much ml of water?
Yeah, just to hold this catheter.
Hello?
Yeah.
How much ml of water?
How much?
ml of water.
Yeah, it is not the ml of water. It is important, but what is important, it is a pressure-controlled device. Okay. So as you can see, he is having a pressure transducer. So if you can, camera person can come here and watch. There is a pressure transducer here. For a preset pressure, it will inflate to a diameter of 13.5, 14.5, 15.5, like that. So we have not touched. And normally, can you see in the screen, what was something like a dumbbell, now it's like a banana. Can you see the banana? The whole thing is uniform diameter. So that means the waist of the stricture has been dilated to the size of the balloon. And the scope is sitting next to the balloon. Even if you want, I can come a little bit proximally just to see the proximal summit of the balloon. See, this is now you will see better. You will be able to understand. Hold the scope here. Okay, this is what exactly we do when we do an achalasia pneumatic dilatation, but there it is a pneumatic dilatation. Here it is with a controlled radial expansion using the saline with a tinge of contrast that helps me to radiologically see the configuration of the balloon. the waist, it's like what we call usually the British ladies' waist, it will become like a other. So once you put on weight, you put on the waist is disappearing. The disappearance of the waist is a end point for a satisfactory balloon dilatation. Can you just tell me what is the pressure? So what is the diameter we reached for a 2? See, there is a small piece of paper I wish everybody to keep that with a thing. So for an atmospheric pressure of 3, it goes to 15. You make it 4.5. Yeah. You make it 4.5. Yeah, just to hold. Yeah, hold this. Yeah. So can you just screen one more time? So can you see now? There is a faint, waist about the lower 3 centimeter, upper 4 centimeter. I don't know how many of you can appreciate. There is a faint waist is there. So let us wait for the waist to disappear. Can you just go a little? Yeah, go a little further. So this is a controlled radial expansion, but because you have a control, doesn't matter, you will dilate, because normally esophageal anastomosis can be dilated right up to 20 millimeter, that is 18 to 20. So if you are very gradual, I think I am happy with, screen one more time, please. Yeah, now I am very convinced the balloon is uniform diameter and it is very dilated, and let us deflate it now after 30 seconds. We'll count from 1 to 30. So 30 seconds we remain in the same place with the same pressure. So the balloon keep on remodel the fibrous tissue throughout the 360-degree circumference, so that it is a radial expansion. The chance of recoil is less, and the weight, and then after that slowly deflate. If you want, you can inflate one more time. Then as you withdraw the balloon alongside the scope, you try to insert the scope and see what improvement has happened. This is what we are going to see. So let us start deflate the balloon now. As I said earlier, this balloon, in my opinion, can very well go through the channel. But the only thing is the balloon can get damaged very easily unless you have a way of preserving it, reprocessing it. That's why the technique adapted here is what we use in a Savory along the scope technique, what we use in achalasia, things like that. We'll take the balloon to the side like this, keep the guide wire. I'll just go again the passage. Okay? So this is where we have dilated. Now it is much easy to go in to the afferent loop. So we can do an enteroscopy. Taking the wire as my path, we can go further in, all the way along like this. You can go. See, very important, just keep twisting the scope, and if necessary, you can irrigate the water, and you can just go deep into the jejunum. So we have done a decent demonstration with a guide wire directed along the scope, CRE balloon dilatation, using a controlled radial device, and the contrast helped us to radiologically monitor our dilatation from the disappearance of the waist. And of course, you should not over-insufflate that area. Try not to take a biopsy this region, because that area is having a little tear. There is every chance of a pneumomediastinum. Just to slowly come back and come out. So essentially, that is the principle of anastomotic stricture dilatation, and very efficiently can be done by a surgeon who has the equipment, tool, and also the team, and you know the technique. Thank you.
So it was very nice demonstration, sir. It was a good variation for TTS.
Yes.
Yeah, along the side of the guide wire, you very nicely demonstrated. Thank you very much.
Thank you. Thank you. Thank you, team. Thank you. Thank you very much.
We'll be proceeding with the next case. 46 years old female came with chief complaints of blood in the vomit, pain in abdomen, and chest pain. She is a known case of coronary angioplasty. We are planning for a gastroscopy for her. Learning objectives, evaluation of OG junction. Over to you, sir.
Should I begin? Should I begin? Yeah. So, good morning, everybody. First of all, I would like to congratulate Dr. Suryawanshi sir for this successful third edition of Endosurg. It's a concept of endoscopy by surgeons and for surgeons. And I'll be showing one case of diagnostic upper GI. As you can see here, I am holding my scope like this. We actually block the small wheel in the neutral position so that most of the time the patients are awake. So with their tongue they can move the scope. So sometimes it becomes a little difficult to intubate through the pharynx. That's why we, before entering into the oral cavity, we lock the small wheel in the neutral position and then pass the scope. The patient is kept in left lateral position. Today, because we are showing it in a workshop, we have given her some sedation. But normally this procedure can be done without any anesthesia, just by giving local spray. So I am going through her oral cavity. This is the posterior third of the tongue, and I am walking over the tongue. Once I cross the tongue, I'll start seeing the uvula. I'll go behind that, enter into the oropharynx. We see the epiglottis, go behind the epiglottis into the pyriform. Now we start seeing the cords. Then we enter into the pyriform fossa. Then we ask the patient to swallow, and as she is swallowing, at the same time you have to insert the scope inside, and then you enter into the esophagus. Like this. Now once you enter into the esophagus, further progress will be like driving a car. You have to keep moving the scope a little bit. Now you start seeing the mediastinal pulsation. That tells us that we are in the mid-esophagus. You go further beyond that, if you see any fluid or any secretions in the esophagus, you have to suck them out. Normally, you are not supposed to see anything in the esophagus because esophagus is just a conduit. It is not supposed to have anything. If there is any food material or saliva or blood, then that is a sign of distal obstruction or some pathology. Now I come near the distal third of the esophagus. As you can see here, these are the peristaltic waves. We wait for the peristalsis to go, and then you go into the lower esophagus. Now, nowadays, most of the scopes have this digital chromoendoscopy. Here we are using Olympus scope, so it has NBI or narrowband imaging. So like this, I have put on the narrowband imaging. That will tell us whether the patient has prominent GERD or not. Again, I wait for the peristalsis to go. Sometimes it is a good idea to give patient Buscopan before the procedure is started. It is particularly good for the beginners because it will relax the pylorus and entry through the pylorus becomes easy. Now sometimes it is not opening, then you should pass the scope inside and then come back. So the entry of the scope across the G junction will open the G junction and then further examination becomes easy. Now here if you can appreciate the Z line and the diaphragmatic pinch almost are coinciding, and there is no obvious GRD which is seen in the lower esophagus. After like this. This is a...
Hi, Mandar.
Good morning,
How are
sir.
you?
Good morning, sir.
Good morning. Good. Once you navigate all along to D2, let's come back, revisit the OG junction, and give them all the important messages, how to assess OG junction. That is the objective, learning objective for this case. Thank you.
Now, once you go, cross the G junction, you have to go along the, do a little bit anti-clockwise rotation of the scope. So then you enter into the stomach, then you distend the stomach lumen. If you see any secretion, you should suck them out to prevent aspiration. After that, you just correct that torque and then progress along the greater curvature of the stomach. You should do little bit up on the big wheel and go further along the greater curvature. Now you start seeing the incisura. That is a sign that you are going towards the antrum of the stomach. This is the antrum, and you can see the pyloric opening. If you are fortunate, you will find this open pylorus. If you find this, then you can pass your scope across the pylorus. If not, then you wait for the peristaltic wave to go and then try to go into the duodenum. Once you cross the pylorus, many times the scope gets abutted against the wall of the D1. So if that happens, you take a breath, withdraw the scope a bit, distend the lumen, then observe the duodenal mucosa, and then at this point you can unlock your small wheel, rotate the scope anti-clockwise, then turn the small wheel towards right, lock the small wheel in the right position, do up and slowly withdraw the scope. This is called shortening of the scope. Initially, while going inside, I went across the greater curvature of the stomach. Now I have brought the scope along the lesser curvature. So this is called shortening of the scope. So even though I withdrew the scope, I could advance further into the duodenum. Now, in normal case, this should be the summit of your examination. You are supposed to see only till D2 or D3 at the most. But in certain situation, like if you are suspecting condition like malabsorption or anything, if you want to go further into the jejunum, then you can go sometimes. But in majority of the cases, this should be the summit of your examination. Then you examine the duodenal mucosa thoroughly, put NBI again, see the characteristic features of the villus pattern in the duodenum. If you are suspecting anything, then you can take biopsies. And once you finish taking biopsy, then slowly start withdrawing the scope. In some patients, you will be able to see the ampulla also. Let's see in this patient whether we are able to see the ampulla or not. Because the ampulla is situated on the medial wall of the duodenum, it is not always easy to locate the ampulla using a gastroscope. For that, you need a duodenoscope or the side viewing scope. In this patient, here somewhere is the ampulla, but I am not able to see it properly. So I will not waste more time in this. I'll slowly come out in the D1. Again, look at the mucosa of the D1 properly. Like this. And then you will fall in the stomach. Now once you come back into the stomach, again go in, look at the incisura, and then do what is called a J maneuver. That is extreme upward reflection of the big wheel. Then you will start seeing the fundus of the stomach. If you can appreciate, there are some erosions in the fundic area of the stomach. See this part of the fundus and rotate the scope completely 180 degree and look at the other side of the fundus. This movement is very important. You should all learn this movement, because for two things: if you see any pathology, then you should be able to take biopsies from that area, and for that you have to be able to reach that area correctly. And another thing is, if you are doing a case like foreign body extraction, for that also you should be able to reach every area of the stomach using this scope. Once you do that, then you straighten the scope again, go back into the antrum, put NBI, and examine every centimeter of the stomach very thoroughly. You should spend at least 10 minutes for doing a normal diagnostic upper GI-scopy. You should not hurry. If you do that hastily, then you are sure to miss many lesions. So that you should never do. So look at every area of the stomach using both white light and NBI. If you find anything suspicious, you can go closer to that, put magnification or near focus. Nowadays, most of the scopes have this ability to use the digital chromoendoscopy and magnification also. If you find anything suspicious, you can take biopsies. If the patient is suffering from a condition like dyspepsia or hyperacidity, you can take biopsies for rapid urease test, which will tell you whether the patient has H. pylori infestation or not. If you find anything positive, mala biopsy lagel. So here we can see multiple erosions, both in the antral area and as well as in the fundus. That's why I am taking rapid biopsies for rapid urease test. Sir, what is your protocol? How many biopsies you take for RUT?
2 is enough, 1 to 2.
Okay.
If you're going to do a rapid urease in a slide, that's what we normally do, maximum 2. But if you're going to do a biopsy, you can as well take 4 to 6 bits, send it to the pathologist.
No, sir, for RUT, RUT 1 or 2 is enough. Open?
One of the areas which less understood for the beginners is what is an erosion, what is an ulcer, for example, duodenal ulcer and multiple duodenal erosions. So this is a little difficult area that needs also little clarity in our understanding. I just make things how I understand pathologically and endoscopically and how we differentiate. For example, erosions are normally one which with the heals, it heals without fibrosis. It is limited purely to the mucosal level. It doesn't breach the basal membrane. So it usually presents like what you saw here, small multiple red spot, or if at all they may have a small yellow head on the top. Whereas if it is ulcers, usually ulcers are slightly larger than a pinhead, and usually they are gone beyond basement to the submucosa, a superficial submucosal layer. They heal with a small amount of fibrosis, and if the ulcer is big enough, that fibrosis area becomes avascular once it's a healing process. You will always see the scar left over by an ulcer, whereas there is not be any scar in an erosion. That is the way you see. And erosions heal within 24 hours. Yes, because sometimes you give a high dose PPI, next day you do endoscopy will be normal. This is one of the problem of gastric erosive gastritis, patient present with GI bleed. If you delay beyond 24 hours in endoscopy, sometimes endoscopy say it is a negative endoscopy. So that's why always we say esophagitis in particular, if you are in a patient with GRD, people say you stop PPI, do endoscopy. Otherwise you'll have a falsely endoscopy negative GRD. So these are all the small points. Yeah.
And another thing is I wanted to people understand the way you hold the scope. So the scope should be resting on this. You should not grab the shaft or grab the handle of the scope. It should be just resting on this. So all your fingers are available for all the movements. Your middle finger should be used for using the air water button, and the index finger for the suction button. And it should be resting on your palm. So if you are doing a longer procedure like POEM or ESD, your hands or your shoulders will not get like injured or fatigued with this. So those are few, I would say, practical points that everyone should follow. If you are doing a normal diagnostic procedure, the procedure takes hardly any time, so that will not matter in those cases. But if you are doing a longer procedure, those things definitely come into picture. So once you finish this, then once you start coming out, make sure that you suck out all the air which you have instilled in the stomach. Otherwise, the patient will have a lot of discomfort.
So sometimes when we are doing scopies, when we go near to the mucosa or zoom, we see nodularity in the mucosal area, in the majority of the times in the antrum. How do we interpret that and how do we report that?
I mean, normally the mucosa is supposed to, like in this case, would be very smooth. And nodularity means it's a chronic gastritis. So there is probably an evidence. And there are other pathology you need to aware of is like atrophic gastritis, intestinal metaplasia. So these are all the things of evidence of chronic changes. If the patient has a repeated acute attack, those areas becomes more nodular, like a lymphocyte infiltrate more than a neutrophil infiltrate, and they give that appearance. Thanks to the high definition endoscopy, now we start seeing things which we not used to see. And sometimes the problem for the beginner is they overdiagnose some pathology. Sometimes normal also and as a mild gastritis. So my request for all of them is use standard internationally accepted terminologies to be used, and that has been documented. What you interpret as, like you try to adapt a client. Like for example here, Mandar, you just look at the J maneuver, you look at the laxity of LES, adapt a Hill classification, all of you there, and it will give the same interpretation people across anywhere in the world. So it is to me it looks like Hill type 2,
type 2, yes.
Isn't it?
So
like that, you need to standard classification. If you are using esophagitis, try to use either Los Angeles classification. Yeah, that is a type 2.
So
If you go closer, at one point you will be see phasic variation. Normally, during every inspiration, some laxity was there.
Yes, sir.
So,
this is definitely type 2.
Yeah.
Sir.
Yes.
This is fungus. J. Manohar. So you should mention all this in your report. So your report becomes standardized.
Yes.
So if the patient goes to another doctor, just seeing at the report, he will have some idea what he is dealing with.
And this is what we call, sometimes people, especially this is only fundus alone gastritis, isn't it? Mainly, predominantly fundus is involved. Like a type A gastritis or sometimes you need to suspect whether this is associated with something like a parietal cell disease or a B12 deficiency. People also can have such anomaly. I don't know about her. She is vegetarian, and that is the one thing. Type B is predominantly in the distal stomach, bottom gastritis. That is in the H. pylori, you see, tend to have more antral pathology. Here it is more proximal gastritis. I suspect whether it is something of significance.
And if the patient has hiatus hernia, then you see those prolapsing gastritis.
Can you show us exactly where did you see the Z line and the hiatus pinch when you come back, so that we'll assess the hiatus?
Yes, sir. Yeah. Now, as I said, this completes the examination of the stomach. And then slowly straighten the scope, suck out all the air. See, at most centers, they use air for doing endoscopy. So it is very important that suck out all the air. If you are using CO2, then that problem is little less, because CO2 gets reabsorbed very fast. But even at my center, for therapeutic procedures, we use CO2. But for diagnostic, we still use air. So now slowly come out. Look at the proximal part of the body of the stomach. And here you can give little bit of air, but keep on sucking it also to prevent over distension. Yeah. Now I have come back into the esophagus. So as I said earlier, here the two are almost coinciding. So this is to make the Z line more prominent, we use NBI.
Probably hardly a centimeter distance between the Z line and the diaphragmatic pinch.
So normally on NBI, the bluish mucosa is the esophageal mucosa. You see a typical IPCLs, and this red is the gastric mucosa. Even if you don't have NBI, still these two things are quite obvious. You can nicely see the Z line. That is a distinction between the red mucosa of the stomach like this and the pink mucosa of the esophagus. So here, this is the Z line, which is at around 34 centimeter, I would say, and this is the diaphragmatic pinch.
Hello.
So they are almost coinciding, hardly 1 centimeter apart.
Hello.
So if the distance is more than 2 centimeter, then that is one of the signs of hiatus hernia.
Hello.
Yes, sir.
How will you classify the LA esophagitis?
So that is a standard method of classification of GERD. So they are classified into LA grade A, B, C, D. 4 grades are there. In LA grade, you see small mucosal breaches less than 0.5 centimeters, like this. In grade B, they are more, but they are not extending beyond 1 centimeter. Grade 3, the mucosal changes are more prominent, but they are covering less than 75% of the diameter, less than 3/4 diameter of the esophagus. And grade 4 are always with some complications, including more than 3/4 of diameter, or some complications like stricture formation, Barrett's esophagus, circumferential. So that is grade 4.
Bleeding?
Or bleeding, yeah. So like this, sir.
I think we are now living in the era of image enhancement endoscopy.
Yes,
now,
sir.
Things got very much better. Those days, like trying to identify exactly where the transition of Z line into gastric is a challenge. Those days we used to use a dye-based endoscopy, chromoendoscopy. We spray some methylene blue or Lugol's iodine, wait for a few minutes, then you see the transition zone. But now with a click of a button, depending upon the type of the scope you are having, either NBI or a LCI mode or eye scan mode. Will give you within a few seconds exactly what you're dealing with.
So
Thank
while
you.
going, I think I saw incomplete Shaski's ring. Let's see now.
See, yeah,
Yes.
you are absolutely, I was about to ask you, that is Sotsky's ring.
Yeah.
See, if you see there is a fibrosis also, if you can put as, again, NBI,
Yes,
that
yes.
area, you can so clearly, this is a classical Sotsky ring, signs of recurrent inflammation. You can see scarring at
Here.
3 o'clock and 9 o'clock, exactly.
Can you appreciate, sir? There.
Yeah. Yeah.
So
I think the patient has some degree of reflux issue. These
yes.
are all background inflammation, healed.
Probably they must have given her some PPI, so that has healed the mucosal changes, probably. So, okay. So,
Thank you. There's
once
a
you
X.
did this, then slowly withdraw the scope. Again, look at the esophageal mucosa, inch by inch. Put NBI wherever you find anything positive. Then come back into the oral cavity. Now, you can ask the patient to say ah to look at the vocal cord movements. Many times while going inside it is difficult because the patients are anxious, they will have some retching, but when you come back, by then the patient is also quietened down considerably, and then you can appreciate the vocal cord movements very nicely. Look at the larynx, laryngopharynx, pharynx, oral cavity.
So just if you could show me the vocal cord. One of the other additional challenge for the beginners is which is the right vocal cord, which is the left vocal cord. They'll have their own doubts. So the way to see is you treat the monitor like a clock. So what is more towards the 3 o'clock is the right vocal cord, arytenoid fold, right pyriform fossa. More towards the 9 o'clock you see is the left vocal cords and arytenoid fold pyriform fossa. So that also helps when you document.
So earlier I used to use fiber optic scope, so and both video scopes. So fiber optic, this is a real image. So there I used to follow that patient's right is right. Now with this, my right is right.
That's
how
right.
Thank
Excellent demonstration all the way, not
Thank you, sir.
having any blind spot and careful evaluation using the technology available. Wonderful.
Thank you, sir.
Thank you.
Thanks a lot.
And now we would like to express a heartfelt gratitude towards
32 years old male came with chief complaints of difficulty swallowing, liquids more than solids. Upper GI scopy was done in April 26, which was suggestive of achalasia cardia. Advice was esophageal manometry, which suggested type 1 achalasia. As we can see, IRP is elevated with failed peristalsis. This is the barium image of the patient. The plan is per oral endoscopic myotomy, and learning objectives will be management of achalasia cardia. Over to you, sir.
Hello. Hello.
Firstly, now we
Hello.
would like to request Nikhil Chauhan sir to felicitate our chairperson for this session.
Okay. Can you take us through your thought process in this case, Pravin? What exactly?
Yeah. Hello. Am I audible?
Yes, sir.
Yes. So again, as mentioned in the history, he is a 34-year-old male having dysphagia for more than 6 months. And on initial endoscopy, the esophagus was dilated and there was, little bit resistance at the esophageal junction without any mucosal lesion. So this was indicative of achalasia cardia, and then further it was evaluated with manometric study. On manometry, it has been explained in the presentation that there is an increased IRP with total peristaltic esophagus. So it shows it is a type 1 achalasia cardia on manometry. So for the now effective management of achalasia cardia, manometry is mandatory investigation. It is not like an optional. Unless you subclassify achalasia in type 1, type 2, type 3, it's very difficult to explain or select the right way of managing it. And second thing, you can also explain the further prognosis also to the patient in advance. So this manometry is very important tool for the complete evaluation of achalasia. So since this patient is having type 1 achalasia, that means that there is totally a peristaltic esophagus. So this is actually end stage disease of the achalasia. And in these cases, you get sigmoid esophagus because this is totally a peristaltic. This is a flaccid esophagus. So there is a significant dilatation in these cases. So as far as this achalasia typing is concerned, type 1, type 2, type 3. Type 1, we can do anything like POEM also you can do, or Heller's cardiomyotomy you can do. In type 2 also, we can select any of the treatment options, whether Heller's or POEM. But type 3, where there is it's a spastic esophagus in the distal esophagus, then we need to do long myotomy. And that long myotomy only possible with POEM and not with the Heller's cardiomyotomy. So if given a option, then for type 3 achalasia, POEM should be done. Which are the other indication where in our institute we prefer POEM over the Heller's cardiomyotomy, because we ourselves are doing both the procedures in our department. So we wisely select cases for each procedures. So the cases which are selected over Heller's cardiomyotomy, as I mentioned, first is the type 3 achalasia. Second is patient with high risk for the laparoscopy, where we cannot really go for the insufflation and cardiac compromised patient. So we prefer POEM over the Heller's cardiomyotomy. Third cases are where already upper GI major surgeries has been done. So then we expect a lot of adhesions in the around the stomach and the esophageal junction. So again, to avoid all those challenges, we prefer POEM over the Heller's. And then third is the recurrent cases after Heller's cardiomyotomy. So most of since in Heller's cardiomyotomy we do anterior myotomy. But if we want to redo myotomy with the same Heller's, then again we need to release the flap, whatever we have done, partial or complete wrap. Again, there will be a lot of adhesions, and again, high chances of injuring the esophageal mucosa in that cases. So in POEM, we do posterior myotomy. So we get very virgin plane endoscopically. So in such cases also, we prefer POEM over, like it is like, if there's open hernia recurrence, you do the tape or tap, because posteriorly it is a virgin plane. Or if it is... Yeah.
The patient has diverticulum, and then also POEM is preferred.
Yeah. As rightly mentioned by Dr. Mandar, if there is a diverticulum, esophageal diverticulum, then the POEM is preferred over the Heller's myotomy, because both the condition can be treated simultaneously.
Hello.
Yeah.
Sir, friends, 2 minutes we'll introduce the new chairperson for this session.
Okay.
For the next session, we would like to call upon Dr. Harish Umradkar sir from BJ Medical College, Pune. Dr. Kailash Paithankar sir, is Senior Surgeon from BEAD and President Maharashtra Surgeons Association. Dr. Anil Devgakar, Professor from Government Medical College, Nanded. I would request the chairperson to kindly come forward and commence the next session.
So welcome all these distinguished senior faculties from Maharashtra, especially Marathwada region. And I really express gratitude for taking out time and joining us. Also, I appreciate efforts made by UP State Chapter Secretary Dr. Akshay Anand for making it available across the UP State Chapter, UP State medical colleges online. And also I welcome all the faculties and the teachers from across the country who have joined us online. Thank you so much. So once you start this poem, first important step is the assessment of the esophagus. We must make sure there is no significant esophagitis and there is no any other lesion, like, it should not be pseudo-achalasia. That also we must make sure. And then after, if at all there is any food residue or any liquid residue, then you must suck it completely, give thorough wash, make sure there is nothing in the esophageal lumen. And then we pass the scope across the esophageal junction. So this is a esophageal junction and measure its length. So in this patient, if you can see, it is almost at 42 centimeter. Camera either. So this is 50 centimeter here. This is 45 centimeter, and these incisors are at 47 centimeter. So esophageal junction has 47 centimeter. Since this is a type 1 achalasia cardia, I can do up to 5 to 6 centimeter myotomy on the esophageal side. So 5 to 6 centimeter myotomy on the esophageal side. There has to be normal mucosa with normal esophageal muscle, about 3 centimeter. So 6 centimeter plus 3 centimeter, 9 centimeter. And I need to do mucosotomy of almost 2 centimeter. So 9 plus 2 is 11 centimeter. So what I will do, I will withdraw my scope for 11 centimeter. That means esophageal junction 42 centimeter. So I will bring my scope up to 31 centimeter. Show you. So this is, can you appreciate? This is 30 centimeter. This is 30 centimeter. Okay. So I am bringing it to 31 centimeter. So again reverse calculation. At 31 centimeter my scope tip is there. 2 centimeter mucosotomy. So up to here there will be mucosotomy. After that 3 centimeter normal mucosa and the normal muscle layer, that is 36 centimeter, and from 36 centimeter to 42 centimeter, 6 centimeter there will be myotomy. Yeah. Okay. Again we need to go 2 to 3 centimeter on the gastric side. So total length of myotomy will be 8 to 9 centimeter. So as I mentioned again, there are 2 ways of doing, creating submucosal tunnel. We can do posterior or we can do anterior also. I prefer to do posterior myotomy because again very simple reason. If HELARS it fails, we can do posterior, and if it fails posterior myotomy or there is a recurrence of posterior myotomy because of POEM, I can do anterior HELARS when I have to redo myotomy. So that's why I prefer to do posterior myotomy. So now my scope is at 31 centimeter. This is 30. And how to now identify the posterior? First is that you can see the spine posteriorly, prominent. Can you appreciate spine here?
Yeah.
Huh? Yeah, and the pulsating heart. If at all you are in doubt, what you can do, a patient is in supine position, inject some normal saline, and the normal this water will accumulate on the posterior aspect of the esophagus. So if you see here, the saline is on the posterior aspect. So we are right that we are doing, will be doing mucosotomy on the posterior wall of the esophagus.
It is not a classical, it has a little sigmoid curvature is there.
Yeah,
it looks a little tortuous.
Yeah.
And
so you can see there is a curvature here, like this.
Yes.
ठीक है. Any questions so far? Dr. Shinde, just check any online questions are there. Open. The first step is the creation of injection of submucosal normal saline and getting a mucosal bulge. Inject. Can you appreciate now?
Yeah.
I have injected submucosally normal saline with methylene blue. So we need to inject minimum 20 centimeter of 20 cc of normal saline to get nice bulge. Yeah. So what I will do, I will raise my scope on this puncture so that this fluid doesn't get leaked out. By the time I exchange my needle with the TT knife. What I have to do, I have to go 2 centimeter distal, open, and give the mucosotomy incision. So 2 centimeter incision I will give. If there is vessel, I can use. Yeah, I think it's enough. Okay. Then I will go inside the submucosa, like this. Open. Open.
Sir, which is this cautery, sir?
This is Arbe cautery right now I am using, but you can use any cautery. There are good Indian cauteries also available. They are also working well. Initially, maybe 5-6 years, I use Indian cautery Shalla. So you can start. Really you don't have to invest. Only investment what you need is this TT knife. Otherwise, the routine gastroscope what you are using in your day-to-day practice, same gastroscope, same cautery, you can use for the poem also. Open. Open.
And the type of current, what sort of current which is delivered over there?
So I am now creating submucosal tunnel. So you need to create this submucosal tunnel from 3 o'clock position to 9 o'clock position. And the trick, especially in this sigmoidesophagus, trick is stay perpendicular to the circular muscle fiber so that you don't miss the plane.
YouTube.
Yes.
From UP
Open.
Association.
Open.
What are the electrosurgical settings you are using?
So in this Arbe cautery, you get fixed setting for a different procedure. So my setting is on the poem camera. Can you show? Could I Arbe? I can show this.
Endocut Q.
So
3.
there are the factory settings are there for this poem procedure. So there is the cutting is endocut Q on 3 and the force coagulation 4. Open. Catch. Open. So proper hemostasis is very important because it is open, very small space. So minimum bleed or ooze creates complete red out. Then it's become very difficult. Catch. Open. To progress in the right plane.
You already entered the space.
Yeah.
And the muscle is at 6 o'clock and the mucosa is more towards 12 o'clock in the monitor.
That's right. Inject. So you need to inject repeatedly to raise the mucosa from the submucosa. Open. Now there are different ways of doing it. I prefer to do from like this, keeping this lumen or vertical and going from 3 o'clock position to 9 o'clock position like this. Inject. Inject. Bas. Open.
So ideally you are doing in the deep submucosa where it is hugging the muscle.
Muscle.
So that the
So
chance
stay
of
close
mucosa.
to the muscle, yeah. Can you appreciate the circular muscle layer here, posteriorly?
Yeah, absolutely. You can. Just one flimsy layer is in front.
Yeah.
Otherwise you are able to see.
Open. Open. Can you appreciate now this circular muscle fiber?
We can very well appreciate.
Yeah. Inject. So every 2 to 3 minutes we need to keep on injecting this normal saline with methylene blue. So at a time we inject 6 to 7 cc. Open. Bas.
Can you give some tips regarding the movement of the tip of your knife?
Yeah.
It looks
See,
at the tip of the knife you are not moving, you are rotating
Yeah.
the scope, isn't it?
See, that's what, I am not fiddling with the tip. See, I keep it at fixed length. Okay. Then whatever movement I do with the scope and the twisting the shaft. So every time I am not just, making any movement with the
It
this
is the movement of the scope.
tip. Yeah.
The muscles are kept on the 9 o'clock and the mucosa more at 3 o'clock. Is working from below upward,
Yes, sir.
taking the scope tip for rotating.
So since I cannot see this, for a second. Ah, yes, okay. Yes, 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 yes.
While Pravin is proceeding down along the esophagus to do the mucosal, submucosal tunneling, so we are moving to the theatre 3, wherein there is a esophageal CA, where there is a palliative metal stent deployment is going to be demonstrated. Thank you.
We'll now be shifting to OT number 3. 39 years old female with chief complaints of difficulty in swallowing, solids equal to liquids since 4 months, increased severity since 2 months, and weight loss of 9 kg in 3 months. Operated case of feeding jejunostomy in May 26, and that came out spontaneously. USG was suggestive of CA esophagus with no metastasis. CT thorax was suggestive of long segment circumferential wall thickening involving lower esophagus and GE junction, causing luminal narrowing. And PET scan was suggestive of primary malignancy involving the distal esophagus and GE junction with multiple hepatic and pulmonary mets. Histopath was suggestive of squamous cell carcinoma of esophagus with liver lesion. Upper GI scopy was done, suggestive of metastatic CA esophagus with malignant stricture. This is the barium swallow, showing the classical rat tail appearance.
White balance
Our plan is esophageal stenting, self-expandable metallic stenting. Over to you, Mandar sir.
Yeah. Hello, am I audible?
Yes, yes, yes.
Hello, yes, sir. Okay, so now, as you have heard of the history, the patient has metastatic CA esophagus, and the plan is to do palliative stent placement. So here we are using the latest FIAGES system. It is a FIAGES 8000 series. They have specifically developed it for third space endoscopy. So it comes with a dedicated scope of only outer diameter of only 7.5 centimeters. But even though the outer diameter is so small, the working channel diameter is 3.2 millimeter. So through that, all the accessories, third space accessories can be passed through the scope. And that's why the scope is very well suited for doing third space procedures like POEM or ESD, etc. Here we are using a standard gastroscope. The patient is in supine position, and patient is sedated, and I'm passing my scope inside. So the standard procedure remains the same. Go across the pyriform fossa into the esophagus. Since the patient has a obstructing growth, we expect some residue in the esophagus. Fortunately, here she doesn't have any, but if you find any residue in the esophagus, you have to suck it out completely to prevent aspiration. Now you go slowly beyond this. Here, can you appreciate the growth, sir?
Yes, yes, very well.
This is completely stenotic growth. Now, since we are using FIAGES system, the way Olympus has NBI, FIAGES has another chromoendoscopy that is called as BLI. So again, with a click of switch, you can change the mode to, this is called LCI, link color imaging. It makes again the mucosal changes more prominent, and then you press it again, then you go into the BLI. So BLI is exactly similar to NBI. So like this, here since we already know the diagnosis, this is of not much relevance in this case, but in early cases, these both the techniques, they will help you to diagnose the cases early. And if you diagnose early CA esophagus or early gastric carcinoma, then you can easily do endoscopic resective procedures like ESD and prevent a major morbid resective surgery in that. So now as you can see, there is a completely stenotic growth. I am trying to pass my scope through that, but it is very difficult. And unnecessary, you should not try it also, because if you try it, either the patient will start bleeding or there is a possibility of perforation. So in such cases, unless you have a pediatric scope, you should not attempt to go beyond the growth. And another problem of that is if you try to go beyond the growth and to assess the length of the growth, in that sometimes you dilate the lumen, and that can sometimes lead to migration of the stent. So that's why it is not a very good idea to always try to go across the growth and to assess the length of the growth. Instead, you can take help of the fluoroscopy. So now I will pass a guide wire. Here I am using 035 guide wire. At my center, I generally prefer to use super stiff or steel guide wires, because if the patient has really very tight stricture, then to pass the stent, those stiff guide wires are more helpful. Now, can you see the distal end of the guide wire which has come in the lumen?
Yes, yes.
I'll try to negotiate it through the growth, and at the same time I'll monitor that on the fluoroscopy. Fluoroscopy दाखवा. ते दिसतंय त्यांना ते पण दाखवा. Fluoroscopy. Shoot. The guide wire should pass very smoothly. Otherwise, I will unnecessarily create a false passage. Shoot. Yeah. I think I have gone smoothly in the stomach. Can you see the movement? It has gone. पुढे घ्या थोडं माझ्याकडे आणि खाली थोडंसं खाली पायाकडे. Yes. Can you see I have definitely gone in the fundus of the stomach. So now the next step is to put the markers. So these are radiopaque markers which we have already made. So one marker will be kept at the proximal end of the growth. So here at the proximal end of the growth, I have kept my scope. So we have assessed the position of the scope on fluoroscopy, and there I have put the marker. And the second marker will be put somewhere which is at the G junction. खाली दाखव थोडंसं खाली. So this second marker is not necessary, because the patient is short and I am already at almost 33 centimeters. So the stent which I am putting will definitely cross the G junction. So it is not a must to put the second marker, but in the beginning it is always a good idea to put two markers, one to mark the proximal end of the growth and other one to mark the distal end of the growth. And your stent should cover both the markers. बाहेर काढा scope. Hello. Now I'll try to maintain my wire inside. I'll keep on looking at the fluoroscopy. मध्ये दाखवा. That I sometime with and at the same time the scope is coming out. My assistant is pulling the scope out.
Mandar, we are not seeing the fluoroscopies.
Sorry?
Fluoroscopy
images we are not able to see. Fluoroscopy.
Fluoroscopy दाखवा है ना? Yeah. So I'm just keeping the position of the wire intact. Now I have come out. The wire will be brought out of the scope completely. Now depending on the length of the growth, we will decide the length of the stent artistry we put. Here, as I said, the proximal end of the growth was starting at almost at 33 centimeters. And since the patient is short, I am expecting the G junction to be at somewhere around 39 at the most, or 38 centimeters. So the entire extent of the growth will be somewhere around 5 to 6 centimeters at the most. So here I have decided to put stent which has length of 10 centimeters, and it is partially covered. The majority of the stent will be covered. Only the proximal and distal end both are kept uncovered. That is to anchor the stent properly in the position. Sometimes if you are putting the stent for benign strictures, then we use fully covered stents, because in those conditions we expect the stent to be removed after say about 1 month or 6 weeks. If we put uncovered stents, those stents can get embedded in the mucosa, and removing those stents will be impossible. That's why in those cases we put fully covered stents. Here we want the stent to remain there forever, and at the same time we don't want the stent to migrate also. That's why I've decided to put a partially covered stent. Again, the reason why I'm not putting uncovered stent is, if we put uncovered stent, then there are chances of stent tumor ingrowth through the wire meshes of the stent. That's why we are not putting uncovered stent. Rather, we are putting partially covered stent, which gives us both the advantage of both covered as well as uncovered stent. Now,
Sir,
this is the
this stent is also anti-reflux stent.
Sorry,
is partially covered and anti-reflux.
No, this is not anti-reflux, sir. Sir, in my experience, anti-reflux stents are not that useful. They will not prevent reflux to that extent. So, plus the cost is an issue. So, generally, I prefer to put partially covered stents only, even though I am crossing the G junction. So, this is the stent. Can you focus on the stent, sir? This is the area of the stent. Here, if you can appreciate, this much portion is of uncovered part of the stent, and central part is fully covered part of the stent. Now, I'll pass the stent over the guide wire. Again, while passing, I keep looking at the fluoroscopy picture. Thodi wire bahar aali hai. Shoot, shoot. Yeah. Sometimes that can happen. Now, I'm keeping a tug on the guide wire and I'm slowly pushing the stent. Now, this is the proximal end of the stent. Distal end of the stent. I'm trying to pass it across this growth. The stent also has markers. Over dakwa. Over dakwa. Yeah, okay. So I have crossed the growth completely. Shoot, shoot. Yeah. Thoda over gaya. Thoda, sorry, maage khali gaya, khali. Shoot. Yeah. Free theva nahi, free theva. Shoot. So before deploying, you should make sure that, hey, free theva, hai baga. Dada, asa se free theva. He movement. Ha. Bar. Shoot. So this part of the stent has gone beyond the growth. Now, varcha rakha. Let's look at the proximal end of the stent. Okay. Since I have some margin, I can pull the stent to some extent. And after deployment, all the stents, they shorten by almost 1 centimeter. So that's why I have to keep that also in my mind. Pude gaya thoda sa, thoda. Bas, shoot. Now here, as I said, the distal part has already gone in the stomach. So I am more worried about the proximal part of the growth. So I have to make sure that proximal part of the growth is completely covered by the stent. So while deploying, I'll just keep the proximal part in the view and I'll slowly start deploying. While deploying, focus on my hands. So I'll just pull this part out and I'll keep this portion stationary. So as I go on pulling this, slowly the stent will start opening up. Shoot, like this. Many times while doing this, the stent gets pulled inside. Can you see the distal end of the stent opening up? Okay, over dakhwata. Show me the proximal part. Now show only the proximal part. Maikade ana. Shoot. I'll pull the scope out. Shoot, shoot. Banda. Yeah. Now I'll keep this position and I slowly continue deploying the stent. I'm just pulling the outer sheath of the stent out, holding the yes. Can you see the entire stent is opened up now? And I'll slowly and carefully take out the guide wire. Sometimes if the stricture is very tight, while pulling out the delivery system, sometimes the stent can get pulled out. So you have to be very careful. Now once the stent is deployed, Again, you have to go inside and check the position of the stent. Air.
Please show us endoscopic view.
Yes, sir. See now, my proximal end. Can you see, sir, here?
Sir,
from here the
endoscopic
covered portion starts, and this much portion is left uncovered. So that will help the stent to anchor into the mucosa.
Sir, endoscopic
so the
view
migration
is
will
not
not happen.
visible.
And since we have crossed the GE junction, gastric fluid will start regurgitating back into the esophageal lumen. So here we have to make sure that you suck out all the fluid.
Please show us endoscopic view.
Yes, sir. This is endoscopy. Can you see the endoscopy picture, sir?
No.
Show them the endoscopy picture. Is it visible now?
No.
Shoot kara.
The stent पण त्यामध्ये things झाले ना. It is not uncovered.
झालं? So can you see the endoscopy picture now?
Yeah. Now it is visible.
Yeah. So now I have gone back inside. This is the proximal end of the stent. I have deployed it at almost 30 centimeter, 31 centimeter. So from here the covered portion of the stent starts, and proximal about half to 1 centimeter is left uncovered. So that will help in anchoring the stent to the esophageal wall. Now, sometimes it is tempting to try to go through the stent, but you should not do that, because the stent takes almost 24 hours for complete opening of the stent. So till that time, there is always a chance of migration. So even if you feel like, don't try to go through the stent. Give it some time, give it 24 hours. In 24 hours, the stent will completely open up, giving pressure on the growth. And after that, if you want, you can try. But immediately after deploying the stent, you should not try to go across the stent. As I said earlier, once because here the stent has gone into the stomach fluid will start regurgitating back into the esophageal lumen. So that you should suck out. Otherwise, there is always a chance of aspiration. See, the bile has started coming back into the esophagus. So in this case particularly, you should give some important instructions to all the patients. The important thing is patient should always remain in 30-degree propped up position. They should not lie down immediately after eating or drinking anything. Then they can eat everything, but they should eat always after proper chewing. They should not gulp anything, because if the large bolus goes inside, so this is an artificial tube. It is not esophageal lumen. Esophageal lumen has peristaltic waves. The stent doesn't have that. So the food will go only by gravity. So the patient has to chew properly, make the food bolus into a smaller particles. Then only they should eat. And as a protocol, all the tablets and capsules should be broken and then taken. Because if he's taking a round tablet, the tablet being a small diameter, that will go through that. But if he's hitting a capsule, and if the capsule goes transversely, then that can get stuck. So as a protocol, the patient should be told to have every medicine in a powdered form, or at least they should be broken down. And we also tell the patient to have some carbonated liquid like Coca-Cola or Limca in the end at night, about half cup of carbonated liquid. So that will keep the stent patency better. So our Indian food has lot of oil and masala. So because of that, sometimes those things can narrow down the lumen, because these stents are covered stents. And on that plastic coating, those masala and oil, they can form another coating, and that can reduce the lumen of the stent. So to prevent that, they are supposed to have some carbonated liquid in the end, in the night, just going off to the sleep. So these are few instructions. Those should be followed by all the patients. So that's it. So are there any questions, sir?
Sir, later on, are you going to close the feeding geniostomy? It is already done.
Sir, I can't hear you.
Are you going to close the feeding jejunostomy later on, which is already done for this patient?
Okay.
Feeding jejunostomy. What about feeding
Close the-
jejunostomy?
They have already closed it, sir. They have removed the feeding jetty.
Acha.
Any complication you can expect, say, about like a migration, then what will you do in that
So
situation?
because here the growth was very tight, in such cases migration chances are not there, minimum. But yes, theoretically, any stent can migrate, particularly the stents which are kept distally, they can always migrate. But here I don't expect. Because initially I tried to pass my scope across the growth, but since the growth was really very tight, I couldn't pass my scope. So that itself will hold the stent in position.
No, I haven't.
But if there is any risk of stent migration, then you can fix the stent using normal hemoclips, or particularly in benign conditions, we also use a dedicated stent flick. One particular clip comes that is called stent fix. So that clip is used. So if the stent is used for, let's say, perforation, closing a perforation or fistula, in those cases generally we have to fix the stent in position, and for that we use those stent fix. But otherwise in such cases it is really not necessary to apply anything to fix the stent in position. The growth itself will hold the stent in position.
Very nice demonstration, Dr. Mandar.
Thank you, sir. I'll just take out the scope now.
I will take this.
And one more thing, after the stent is deployed, make sure that you remove the markers. Otherwise the markers will remain on the patient's body and relatives will not understand. So those are practical issues that we face.
Dr. Mandar?
Yes, sir.
How early after the procedure do you start feeding the patient?
So initially, just to do some show off, we used to ask the patient to drink some liquid on table itself. But that's not a good idea. But you can start after, say, 3-4 hours. That much time should be given for the stent to open up to some extent, so that the stent gets completely fixed, and the chances of stent migration will get reduced.
And any process or a protocol you follow regarding the gradual shift towards full diet?
Like in this case, since we have put the stent across the cardia, we start with liquids first. Give liquids for 24 hours, and then progressively we go on starting with solid food. But if you have put the stent for a proximal growth, where the stent is fully in the esophagus, then you can immediately start oral feeds or like soft diet also.
So probably by the day 3, the patient will be on full diet.
Sorry?
Probably by day 3, the patient will be on full diet. Probably.
Yes, by day 3 definitely.
Yes.
Because I told you, within 24 hours the stent will completely open up.
Yes.
So the lumen should become normal, and he should be or she should be able to eat normal diet after 24 hours. That's for sure.
One last question. How much of a pain do the patient persistently complain after the expandable stent?
See, in case of malignancy, I have not experienced too much of pain. If you have put the stent for a long corrosive stricture or particularly benign strictures, those patients, they feel pain. In malignancy, maybe because of the nerves are also not that remaining. That's why pain is not a major symptom.
Okay.
They do feel some pain, but those can be managed by simple analgesics.
Okay. Thank you.
Thank you.
What is your experience in when the post-operative stricture that occurs sometimes after, say, radical procedure of lower esophageal malignancies?
Can you repeat the question, sir?
What is your experience of the strictures that develops in radical operation for lower esophagus? Say, you are ruined by post-surgical, post-operative.
Like after esophageal surgery, malignancy.
Yes, in malignancies.
Yeah. So the problem is the length of the esophagus remains short. So in that case, we have to tailor-made the length of the stent has to be used. But we can use them. But most of the time, those are anastomotic strictures. So rather than putting a stent, we use other techniques like Mercedes-Benz incision or repeated dilatation, things like that. Only for intractable strictures, we go for stents. But in those cases, we have to use fully covered stents.
Fully
which
covered
can be
stent.
removed after some
Right.
period of time.
Right.
Friends, we have some update from the poem side. Dr.
We'll be shifting to OT1
Yeah.
to
Okay.
Dr. Suryawanshi, sir.
Thank you.
So Pravin sir dissected way down to the esophagus. He is now doing an endoscopy to ascertain how far he has come. So you can see the blue, methylene blue showing up along the lesser curve.
Hello.
Sir, they are with you,
Am I
sir.
audible?
Yes, sir.
Yeah.
Yeah.
See now, we have created submucosal tunnel till up to stomach, almost 3 centimeter on the gastric side. Okay. So another way of checking it is go into the stomach and J manure check for the blue hue on the mucosal side. If you are deep into the very close to the proximal, sometimes you may not appreciate. But can we appreciate the mucosal color difference? This mucosa and this mucosa.
Yes, sir. Yes, sir.
Huh? So
Yes,
this
sir.
is because of this mucosa has been lifted, and there is a tunnel has been created. Okay, see this mucosa and this mucosa. Okay.
Yes.
And now, if you see, esophagus, as we discussed, it is at 42 centimeter. Okay, I am withdrawing back. Withdraw back. Can you appreciate this mucosal bulge throughout?
Yes, yes,
posterior
very well
mucosal bulge?
appreciated.
This is because of the track that we have created.
Yes.
Again, as initially and rightly noticed by Dr. Ishwar Murthy, there is a little bit turning here. Okay? Because of the early sigmoid esophagus. So these are the challenging cases, to take that turn and follow the lumen. So endoscopically. So they were suggesting, that most of the endoscopies, they come into the lumen, they assess and, go again inside where they are. But we never did anything that sort. Because always we kept perpendicular to the circular muscle fiber. If you are keeping your scope perpendicular to the circular muscle fiber, as the circular muscle fiber take turn, you also take turn with the circular muscle fiber. So that is a trick.
Well said.
Okay. And that's why now we can appreciate. This is the site of our mucosotomy initial.
So you can see along the 6 o'clock zone.
So this is the site of mucosotomy.
Yes, sir.
I am
Yes, sir.
entering into the submucosal plane.
Yes.
Okay. Now you can see this anteriorly, it is a mucosa, and posteriorly it is a circular
Muscularis.
muscle. Can you appreciate?
Yes, sir.
Yes, sir.
So
Very
what
well.
we have done, we have tried to preserve all these vessels. So these are the vessels which are running from the subserosal plexus to the submucosal plexus. So they carry blood supply and also venous drainage.
Of course, sir.
So you must make every attempt to preserve all these channels
Mucosal blood supply.
To maintain the mucosal integrity. Okay. So now we can appreciate anteriorly there is a mucosa, posteriorly there is a circular muscle fiber. Yeah. So again I have preserved these channels on either side, and then here you can see this is the narrowest portion here. So this is esophageal junction. Here also you can see it is at 40.
External view, please. Yes, sir.
See, 1 minute. So this is 50 centimeter, this is 45 centimeter, and this is 42 centimeter. So this narrowest portion is matching with my external marker on the scope. Now I am passing through the esophageal junction and I enter into the stomach now. Once I enter, again lumen get opened up nicely, and can you see these palisade-like vessels on the wall of the gastric musculature?
Yes, yes.
So this is a definitely different vasculature what we see otherwise on the esophageal musculature. So this is the sign that we are on the stomach side. So from here, this palisade type of vascular pattern is there. So this is almost 3 centimeter on the gastric side. Is it clear?
Yes.
Okay. So now I'm coming back again. So this is esophageal junction here. This is matching 42 centimeter. I will come behind almost 6 centimeter. So now this is 40 and this is 45 centimeter.
Yeah.
Okay, this is now 6 centimeter. So I will start doing myotomy about 6 centimeter. If this would have been a type 3 achilles-cardia, almost 2 centimeter more, 8 centimeter myotomy I would have done here in this patient from here. Okay?
Yes, sir.
What fluid you use to irrigate the space, sir? What fluid do you use to irrigate the space? Normal saline?
Normal saline.
Like
So this is that.
prostate or other things, do you have any limitation that you have to complete in 1 hour like that, sir? Not
What?
that much. Like
No, no.
prostate surgery, they say not much of saline.
No, no,
because
we
of-
hardly inject not more than 20 to
So
30.
you don't use that large
No, no,
volume.
no. And we keep sucking every time.
Yes, sir.
So it is
So
just
they
for
don't
the,
percolate.
don't percolate. So again, ek minute. So I'm starting my myotomy. Open. Can you appreciate here now circular muscle fiber and vertical muscle fiber?
Yes, sir.
Huh?
Yes, sir. Yes.
Yeah, deeper vertical.
Just nicely getting going away.
Open.
Both the edges are spreading out.
Yeah. So these are vertical muscle fiber and these are the circular muscle fiber.
Does the cautery setting changes?
No. Same. So what I do, if there are any vessels on the, posterior aspect, so initially I am using coagulation burst like this, and then I am using cutting like this. Okay.
Yes.
Can you appreciate this vessel now in the mediastinum?
Yes.
Running across. So we have to be very careful. That's why.
You sacrifice the vessel, sir?
No, you should not. Open. So I will find a plane between the vessel and the muscle. I will lift it, first coagulation burst and then cutting. Okay, see.
Yes, sir.
So, some endoscopists, they are just dividing circular muscle fiber and keeping this vertical muscle fiber intact. But as we in surgery, we widely open the myotomy so that at least 1/3 of the mucosa should pop out of the myotomy. So until unless you divide the vertical muscle fiber, this mucosal popping will not happen. Okay?
Sir, what is the concept of that blowout of myotomy, sir? The poem people are much worried. When they do more wider dissection it happens, sir.
Now, see, this myotomy blood happens because of the hematoma inside the tunnel, or there is infection.
So perfect hemostasis is the key for
That's right.
successful myotomy.
See, you can see the vessels are very close proximity. So we have to be very careful, very careful. And then to avoid this injury, they, preserve this vertical muscle fiber.
Then it
But
becomes inadequate.
inadequate.
What is your take on tips, sir? Transfer and application.
I haven't started it, but I think it's very incomplete procedure.
Yes, sir,
Whatever
yes, sir.
I have seen, it is just and if at all I am really worried about
Not
the.
acceptable for you as a comprehensive
Yeah,
procedure.
exactly. I will do the
Surgical
proper fundoplication.
Yes, sir.
Okay?
Under no, sir. As you cut only, it goes away, right, sir? Both edges.
Yes. And your scope should be close.
Yes, sir.
So this scope itself, keeps adequate.
So less than 1 centimeter, your movement are happening, right?
Yes, sir.
From the cap end of it.
That's right.
Do we go ahead with that endoscopic management of preventing reflux? They go for a placation endoscopically. Fundic wrap. No, the endoscopic management to avoid the reflux they are planning. The gastroenterologists.
That's what Dr.
Vapaye.
Kanegwal is mentioning about these tips. So we are not. I have not done that, and because I am not really convinced about the utility of that procedure. So if at all I am really concerned about the reflux in any patient, I will go for the surgical
laparoscopic.
So we have done more than 180 poems so far, and only one patient required anti-reflux procedure because of the quite symptomatic reflux. Otherwise,
Post-procedure protocol, sir. You keep them on proton pump inhibitors like that?
we keep them for 3 weeks.
3 weeks.
3 weeks. Then we withdraw, and then we monitor without a proton pump monitor. We do a regular endoscopy at 3 months, 6 months, and 1 year. So if they are reflux, if they are symptomatic, then again we put them on the proton pump inhibitor. So truth is that 15 to 20% patient they require long-term proton pump inhibitors to avoid reflux disease.
80% are totally free of trouble.
Yes.
Sir, in which cases do you advise healers preferably?
As I mentioned,
Preferably healer you will advise. In which cases?
Healers, if there is a severe esophagitis and multiple ulcerations or a very bad, sigmoid esophagus, then sometime, poem will be challenging. In that case, I will prefer healers over poem.
Okay.
But now, patients are coming with the demand of poem. So this is how we can do very nice.
Do you also recommend this division of longitudinal fibers also here?
Yes. I practice what we practice in surgery, that we divide both longitudinal and circular muscle fiber so that there is nice mucosa get popped.
That we see on inhalers.
So I am reached up to this for gastric junction now. Yeah, see, all these vessels, they are traversing through the muscle layer.
Yes, sir.
So that's why we have to keep watching them and just bypass them and take, you must have noticed before, I did that.
Actually, they say they have multiple connections now, sir. Like they
Yeah.
have plexus rather than
Yeah.
linear. So both ends it has to be carefully identified.
Yeah, that's right.
I think you have come to G then.
Yes, that's right.
What is your post-operative protocol? Do you again shift for regarding nearby mouth, or you can
Just
start orally?
24 hour.
Oh.
Within 24 hour, we start liquids orally, and within another 48 hours, we start soft diet.
What is your take on endoflip, sir?
See, endoflip is good for the Hills type 1,
Yes,
but
sir.
type
Short
2,
myotomy.
very short, all that. But otherwise, not for, yeah. See, industry is trying to sell the technology for no reason, unnecessarily. Because, it's easy for some group of the endoscopists, doctors. But is it really worth? That is a big question.
Only for that type 1.
And your thickness has increased here. Huh?
Yes, sir.
Can you appreciate? Yeah.
Very nice,
So
very
I'm already on the stomach side.
The incidence of FIAGES has also increased. What do you think, sir?
I think because of this pesticide.
Pesticide.
Yes, yes. Injudicious use of pesticide is damaging our this plexus. It causing damaging our endocrine system. Diabetes is increasing.
Yes, sir.
Cancer is increasing. Ulcerative colitis is increasing.
Sir, by doing this, how many times
See, vessels are there. So I'm going on this side.
Yes, sir. Yes,
Okay.
sir. You're keeping
I'm
away.
avoiding. Yeah. This is how you can. So otherwise, I will have to sacrifice those vessels.
Yes, sir.
If I would have gone straight.
Electively.
Elective. But I'm going on one side vessel.
Sir, how often you have encountered pneumomediastinum or pneumoperitoneum in this, sir, when you are going into the stomach?
See, there are very high chances, especially in the beginning,
Yes,
to
sir.
create pneumoperitoneum.
Okay,
Because
sir.
already I am into the retroperitoneum.
Correct, sir.
Okay. So always there are chances that air will get leaked from
Okay,
the retroperitoneum into the peritoneal cavity. So this happens if unnecessarily insufflate too much air.
What is the pressure of CO2 you are keeping now?
So there are 3 flows. High.
Camera person show them.
This is medium. So there are 3 flow: low, medium, and high. So this is on the medium flow.
Yes, sir.
Okay. This is on the medium flow. This medium, MED. MED means medium flow.
Yes, sir.
Okay. And again, I am using burst of, CO,
Energy source.
gas. So I am
Okay,
not
you
keeping
don't
my.
continuously press the
yeah,
air button.
exactly. Okay. So that's why there is no leakage of the gas into the peritoneum. So you are always, if you see here,
Can you show the abdomen?
एक मिनट पाठीमागा हे दाखव. So if you see here, we are not covered patient completely. We always keep the abdomen
Available to-
exposed.
Yes, sir.
So we keep
Regularly
observing,
examining.
especially anesthetists our, they keep observing whether there is a pneumoperitoneum abdominal distension, and also simultaneously they keep observing the peak pressure and the CO2. It
Yes,
is
sir. Yes,
CO2.
sir. Yes, sir.
It is CO2. If there is a too much distension of the stomach because of the pneumoperitoneum, peak pressure will increase, it is CO2 will increase,
Yes, sir.
and also there will be abdominal distension.
Yes, sir.
So if you see, the anesthetists always keep this syringe with angiocath
To decompress.
ready to decompress the peritoneal cavity
Yes.
if there is a pneumoperitoneum. Okay. So again, always use carbon dioxide insufflation for the poem.
Very
So
important.
that is very, very important. I think we have done adequate myotomy on the stomach side.
Yes,
I will
yes.
just divide this fiber, open.
That fiber alone you have.
Enough. Okay. So this much, if you appreciate, from
So
here
totally how-
to here.
Very nicely appreciated.
So this is on gastric side myotomy.
Yes, sir.
This is a esophageal junction which we have divided.
Yes, sir.
Okay. And this is almost 6 centimeter of myotomy on the esophagus side. And now you can appreciate how I have avoided these vessels. So these are the vessels, they are entering
Important
into
for the
the
muscle.
muscle, and we have preserved them here also.
Yes, sir.
So if I have gone, this is I have avoided. Okay.
Yes, sir.
Can you see this vessel here?
Very
Deeper.
close. The mucosa also looks very healthy.
So what I feel, to avoid injury to these vessels, some people are leaving this vertical muscle fiber intact.
Yes, sir.
But if you really want to divide a vertical muscle fiber, we have to be very careful from injuring these posterior vessels.
Yes, sir.
Okay. And but I think that gives complete myotomy, what we practice in Ehlers cardiomyotomy. Okay. Any doubts?
Any questions?
Do you do again one more
Yes, of course, of course. So another way of, to confirm that myotomy is, so can you now appreciate between the mucosotomy and the proximal end of myotomy, there is a 3 centimeter of the normal mucosa, intact muscle and intact mucosa. Okay. And again we have to go in, and your now scope should walk in inside without, can you appreciate? It is
very well appreciated.
It is easily walking in without resistance. See now, from esophagus side, you just see, it is widely spatulous esophageal junction. Can you appreciate?
Much appreciated.
Yeah. So, that's...
The curves of the esophagus is also got straightened now, sir.
Yeah. So now we'll close the mucosotomy. Yes.
So this should be about 12 to 13 millimeters, sir, the mucosotomy.
Around 20 mm, because there is a cap.
Yes.
The cap is 16 mm.
Okay, sir.
So 12 mm is the scope, and 9 mm is the scope,
yes,
and with cap it comes to 16 open. Open cap. So the trick here is, again, bring it close to the tip of the scope. Dip it like this, okay? Oblique, and suck the all gas so the mucosa is collapse and fire. Okay?
Yes,
See
it
now.
covers more wider, in one single firing.
So in
Vertical clips, that's
in
not-
most of our cases, within 3
3 or
clips,
4, yes.
we close the
Don't put
mucosa.
7, 8.
7, 8, 9. So properly placed clip like this, it stands out into the lumen.
One
If
more
it
thing
is-
all of you should observe is there are 2 very skilled technicians. One person
open.
just holding the scope, not even a millimeter this way, that way. The other person who's passing the instruments without even sir once telling, I want this.
That's right. So it is a teamwork with good anesthetist and
not a single
technical.
buck a patient has given for the entire 1 hour or so. And the most important thing is they have a system of how much of fluid is being pushed. 5, 6, 7, 8, it keeps going so that you need not ask, have you pushed adequate contrast fluid inside?
Yeah, inject fresh. So whenever I'm, injecting saline, my assistant keep speaking loudly.
How many,
1 cc, 2 cc, 3 cc. So I need not to check at the syringe, or I need not to cross check. So whenever I think it's adequate, I just ask him stop.
So how often these patients, sir, post-operative, you do a contrast study or do a repeat endoscopy
No,
or anything?
no, we don't hardly do any contrast study.
So follow up these patients at the end of 3 months or 6
Open.
months, you repeat the scope forever?
3 months, 6 months, 1 year.
1 year. After that, a year on a lifetime basis, right?
And if patient is symptomatic.
Okay.
So that we do to, document asymptomatic reflex, if at all
Yes, sir,
anything
yes.
is there. So that's why 3 months, 6 months, 1 year is
And anytime they go for
Do you advise manometric studies?
post procedure?
Not immediately post-procedure, let's say after 3 months.
No. Why? Not required. Fire. Okay.
Pakka, sir. Thank you very much,
That's
sir.
it. Thank you.
Wonderfully
Thank you
done.
so much.
Very nice demonstration,
Thank you.
Dr. Pravin. Very well done.
Thank you, team. Thank you. What's your name? Maruti and Totke. Amarkani. And then one other person. Dinesh.
Hello. Now we would like to express our heartfelt gratitude towards the chairpersons of this session. I would like to call upon Sushil sir to felicitate the chairpersons. Dr. Kailash Patankar, sir.
Yeah, please, we'll wait. My dear chairpersons and the delegates in the auditorium across the country, after the beautiful demonstration of a poem, the mucosal blood elevation, navigating in the submucosal tunnel, trying to identify the exact endpoint, and doing a full thickness myotomy, dividing both circular and the longitudinal muscles, ensuring there is an adequate hemostasis, then coming out satisfactorily and closing the mucosal defect by 3 clips. Pravin has beautifully demonstrated why a surgeon is really in a comfortable position to do such advanced third space endoscopic procedure. Following that, we are going to go back into theatre 2. I'm sure you all gathered. This is a patient who needs a life-saving short procedure.
Senior surgeon
An
from
elderly man presenting with the hematemesis, and the previous endoscopy showed esophageal varices. So we are going to identify the varices, then we are going to proceed as per the situation. So like every time since morning, we'll just navigate in the oropharynx, keeping the tongue above and having a glimpse of epiglottis, then docking at the cricopharynx, and then entering the esophagus. Here, very important thing as a suspected case of varices is try not to make the patient retch. So you need a good anesthesia and ondansetron as a pre-medication and reasonably a conscious sedation. And as you can see, till now in the mid-esophagus, I'm just around 30, you can see some columns of veins appearing. At least you can all appreciate one at 3 o'clock, one at the 6 o'clock, what I call between grade 2 to grade 3 dilated tortuous veins, as you can see. When you see such veins, what you need to do is, what is the surface looks like? For example, and there may be some small stripes of redness, what we call a red veil sign, or some dots of redness, what we call a cherry red spot. And actually there is a small cherry red spot at the 7 o'clock in the monitor I could see. And you can get the advantage of this one. Let me just see. Is it a, can we have the NBI here? Can we put the NBI, which one? This one, huh? Yeah. This is the NBI mode. So as you can see here, you are actually, as you stay there, there are actually 3 columns, but the major one at the 4 o'clock at present and also 6 o'clock, both are about between grade 2 to grade 3. They are what I call is a virgin varices, which is first timer. So easily this is the one a beginner should choose to learn or do varices banding, and it is relatively easy. But before you do that, try to assess the rest of the stomach associated fundal varices. So I'm just putting a little bit of water, just to see the pavement pattern of the mild portal gastropathy. This is a very classical appearance of a mild. So they give something like a snake skin or a crocodile skin. But there is no redness in the middle. What normally you see is a little red dots in the middle. They are decided. So this means it's only very mild gastritis. Sometimes they may be more predominant in the antral region, like a cut watermelon, but even that is not there. So I would say probably it is a mild variety. And you navigate already into the duodenum. Sometimes congestive duodenal mucosa, even ectopic varices are not uncommon. So try to do what I call a pan endoscopy. And we are entering into the second part, shortening the scope, and by turning my body away from the patient. So this is the way we are deep down into the D2, then slowly fall back into the pre-pyloric region. Now the moment of the truth, how is the fundus? So to see the fundus, I station myself in front of the pylorus, look at my hand, the left hand, my thumb is over the big wheel. I bring the big wheel slightly towards me, that brings the incisura in front of me. And the big wheel completely towards me, that shows the panoramic view. And you can see a small varices. How many of you can appreciate the small varices along the lesser curvature? The part of the stomach which is hugging or very close to the scope is a lesser curvature. The greater curvature is somewhere here. So this is what I call a GOV1, gastroesophageal varices type 1. because most of the varices are filled from below upwards. By the time you do the banding at or above the Z line, these veins normally disappear. There is no real reason to tackle them from below like this. If it is in the greater curvature like here, then probably I need to debate like GOV2, then I may have to do them first before you go and do the esophageal varices. And here is a classical, called the venous congestion. Can you see here? This is the classical area of congestive gastropathy, because one has to be very clear when you see very close of view. Artificial intelligence has come in a big way to differentiate gastritis from gastropathy, because that is one of the areas where there could be interpretation challenges for the beginners. Then most important thing before you exit the stomach is to deflate the stomach. A distended stomach patient tend to retch, so I deflate completely as much as possible. Then next thing I want to do is to define the Z line, because that's where I start deploying the band. So I need to exactly know. Try not to suck over the varices. So I'm trying to do all the suction when I'm in the stomach, because we don't want to do what I call a suction-induced damage, which is another nightmare situation, because so far the varices are not bleeding. Don't make them bleed before you do the banding. So this is the Z line, as you can see, the transition zone of more or less at the hiatus level. So it is exactly at 40. So we know, because why it is important, the mental picture is very important for me. By the time I put the band, the vision is going to be 1/3 of what you are seeing now. So I'm just coming back, and there are 4 grades, probably people know, and they are so prominent, so it is fitting. If it is bigger than this, kissing each other, not letting me to go navigate, then you call it as a kissing varices or grade 4. It is below that grade, so you can eyeball it as a grade 3 or a big ones. Big ones, big enough, and the biggest one is at 3 o'clock. The second biggest is here. Try not to do banding beyond 35. It is 40 centimeter. From here to here only you need to do band. Because there is some veins here doesn't mean you have to band. Never band the one proximally. You have to always band from below upwards, 1 centimeter distance in a spiral staircase fashion. So I have all the roadmap. So this is the ideal case, especially with a history of hematemesis. This is what we call, we need to do a secondary prophylaxis, prevent him further attack. So we get it ready. Yeah, let me just get the thing, people are doing it first. So we have to have 3 important parts in the release mechanism. So I attach the red colored handle called the release handle in the access channel. So we have now the big wheel, small wheel, and I call a red wheel. So the red wheel is one you're going to turn now. The next important thing is there is a hook at the end. This is called the pull catheter. So this pull catheter goes through a small hole in the release handle, and it will come out. Essentially what it is trying to do is it is trying to railroad the thread which is having the pre-loaded bands. So I'm just, as my staff is going to do excellent, she is knowing exactly what is expected from her. So where there is very little teaching required here. So okay, so she is going to hook on this little thread. I am going to just reversely pull. As I pull, yes, please. Yeah. Yeah, that is a very important question. But my principle is stick to one which you are comfortable with. And this is one of the cheapest one, Indian make. But the most important bit of all this gadget is, yeah, just can I show you, the balloon. See this, what I call the rubber, the quality of the rubber. So it is all now in the expanded thing, it is already. But when they come out of this barrel, they have to recoil, go into the predetermined diameter. I am going to test it, whether it is a good quality rubber or a bad quality rubber. We know, because this is what the key important point. So what I'm going to do is now, if come closer, there is a very small groove in the release handle. So there I am going to dock this here and rotate clockwise the red wheel. And as I do that, the barrel comes very close to the tip of the scope here, as you can see. See, snugly fit in. Yeah, just push it in hard. Because you need to, now push it little further in. Very important thing is it should go fully in. Otherwise, the tip longer, it is intubation is going to be next challenge. As you can see here, the monitor, yeah, can you just put the, is it light on? Yeah, that's good. So as you can see now, the what I call the thread, single thread is this one. It comes around along the 7 o'clock trajectory. That is the trajectory of the biopsy channel in Olympus. So it's all fine. So now we are going to do. Now what was about 9.2 millimeter scope now becomes more or less like a 10 millimeter scope. The size of this scope is becoming this size. It is going to be more difficult now to intubate. So my job especially is challenge with intubation. Second thing is I don't know what is the quality of the band. Let us test the quality of the band. Sister, can you hold the scope with your left hand, like this hand? Yeah. Loosen your little finger like this. Yeah. Loosen, no, here. Just leave it like that. Yeah, hold it in, yeah. So what we are trying to do is, we are just going to see, imagine her little finger is the varices. I'm just going to suck. What you are going to see is a ballooning. This is called a whiteout. So you're having a whiteout, keep it like that. I'm just to rotate. A sense of giving way I'll have in my hand and at one fine moment I have the, yeah, so the finger like this. Yeah, now you can see the quality of the band I'll know roughly is reasonably good, but it's not good enough, still it is coming, but it's okay for a virgin bands, I mean the varices. This is what's going to happen. Similar thing you are going to do inside. Now I have one bullet less. I have about 5 more bullets. I'm going to use only maximum 3 in this case. So let us lubricate it. Suction is a success story here. So you need to have a good suction. Yeah, just to hold this way. This way. No, turn the hand. No. Yeah, that's right. Flex. Very important thing is make sure the head is nicely flexed. You can see the difficulty. Sometimes this may be the most difficult part of the whole procedure is trying to identify where you're going, and you have to have a good cooperating patient. Can you just, no, you have to take the patient. Yeah, that's will change it. So now you know where exactly you are in the postcricoid region. Let us see whether we are in the right place. Yeah. Yes. Just give a little flexion. Yeah. This is the moment of truth. So you just entered, then you have a, just relax yourself because intubation can be tricky, especially when the band is little longer in length. Just go slowly. Now what you see is something like a tunnel vision. You have only 1/3 of what you used to say before, but roughly I have a mental picture. You can see a red whale sign. See, this is the classical red whale sign. You see it around 12 o'clock in one of the varices. And this is another varices, but don't band immediately as you see. I need to go right up to OG junction, right up to OG junction. You just go a little further in. Yes, probably that is the distance, because the one along the 3 o'clock is the going through the lesser curvature. So come back a shade here. Yeah, just, yeah, hold the scope, hold the scope. Yeah, tightly hold. So what you do is suck. and you see the whole thing is out of focus, red out. This is red out. Then just to turn the wheel, keep the suction on. Yeah, I saw, and then keep another 5 seconds, then slowly release the suction. So this is what we do. Then you can see a band has been applied, and what was a varices now becomes like a big grape like appearance, like this is a juicy varices I would call. Then just to rotate the scope, by rotating the scope you can catch the one at the floor here. For example, there is a one here. Yeah, hold the scope. Don't be in a hurry. Very important thing is the moment you suck, don't deploy. Wait, wait, wait. The hissing noise is a sign the suction is effective. It is engaged, okay, but it is not engaged enough in my opinion. Just sometimes you just negotiate your way, then, yeah. Yes, two varices banded. There is one juicy one here, yeah. Let me just see. The procedure-related bleeding, fortunately, is not that common in a banding, unlike a sclerotherapy, which we used to do 20, 30 years ago. And see, I've released the band, but still my finger is not off the suction button. Then only slowly I'll take and slowly disengage, and just to see. So bands are not kissing each other, and there is one more. Let me just finally do this one. Yes, this is a good one. Yeah. So that's all done. As you can see, there is one more band if at all, but I am not going to use this. This is big enough. Every varices where you banded, there is going to leave a small ulceration. More the banding, more the chance of them having a rebleed. So what is necessary is you have caught all the columns necessary to be caught, and all the proximally dilated veins will slowly deflate and disappear. You can always do a second look endoscopy 3 to 4 weeks after this. And this patient, I usually keep them on liquid-only diet for the next 24 hours. If procedure-related challenges, if you had, you can keep this patient on the pharmacotherapy, either as an octreotide or a terlipressin, and keep them on a acceptable dose of beta blockers, usually about 10 to 20 milligrams twice daily. And one dose of prophylactic antibiotics is recommended in all cases of endotherapy. So that's what all I can tell you is, but for the challenges with the intubation, this is fairly easy to see one, do one procedure, and this is one life-saving procedure all surgeons should learn. Thank you. Thank you. Yeah.
Now we'll be shifting
Yeah.
to OT now.
The challenge is, see, we can have small esophageal varices, big esophageal varices, fundic varices. The way I tell my junior colleagues is, fundic varices, fundal varices is a gastric varices, G for G. You have to give only glue. They are not suitable for banding. Big esophageal varices, B for B, banding. Small esophageal varices, S for sclerotherapy, or you can leave them well alone. So sclero, banding, and glue. The glue is actually level 2 training in my opinion. Everything goes fine, it will go fine, but if it's misfire, and the bleed happening during glue injection can be a little nightmare for beginners to tackle. I won't recommend the beginners to do as a procedure.
Thank you so much, sir.
Thank you.
Now we'll be shifting to OT number 3.
Thank you,
74 years old male, came with chief complaints of difficulty in swallowing since 3
Grade
years,
3
solids more
varices.
than liquids. Dysphagia was gradually
3
worsening.
columns.
Operated case of laryngeal
Mild
carcinoma,
congestive
underwent
gastropathy.
radiation therapy and chemotherapy, now presented with
GOV1.
radiation-induced stricture. Upper GI scopy was suggestive of
Along the
narrowing
lesser
at 10
curvature.
centimeters. Esophageal stricture with narrow lumen. Scope could not be negotiated beyond 20 centimeters. This is the previous imaging of dilatation done.
Friends, once again, very good morning to all of you. We move on to the next in series of foregut dilatation. You would have seen from morning peptic stricture.
Our plan is esophageal dilatation, and learning objectives will be management of esophageal stricture. Over to you, Kanagavel sir.
Thank you, doctor. Am I audible at the hall, please? Friends, am I audible? Is there anyone in the hall? Can you tell that are you able to see us and hear to us?
You are audible, sir.
Thank you.
And visible.
Friends, you have seen multiple types of stricture. This is a case of radiation stricture. Patient has had a total laryngectomy almost 13 years before, following which he has developed stricture after 33 fractions of radiation. They have placed a needle insertion as brachytherapy. Patient has been on dilatation progress. Now patient is on tracheostomy. The anesthesiology team has given me a luxury of fully ventilated patient. Now the big challenge here will be the stricture is very high. So I have a good team here to help me to cannulate the guide wire into it. Let us see what we have in stock. They have noted 10 centimeters. So the challenge comes as high the stricture becomes, how to station the scope, because you don't have the luxury of tubular esophagus to retain the scope there. So the technical assistance make a lot of difference for you to handle this type of high strictures.
And to do pneumatic or Savary dilatation?
At this point of time, sir, the schools of thoughts are like this. Peptic stricture, I prefer balloon. Corrosive strictures and radiation strictures, I prefer SG still, sir. Because many times we can, nothing like I am against it, the balloon ruptures, sir. For some reason or other, even for the standard pressures, the balloon rupture. And these patients, generally in our hospital, we ask them to buy one Savary set. That way they come with their own set. Many are antigen positive and other things. So our dealer gives 3 numbers, like 9, 10, 11, 9, 11, 12.8, like that they give. So these people come carry, then take them back home. Many are trained to do by themselves at their home. So we have a batch of corrosive, sir. Our center is a fairly high volume corrosive center. All right, friends, then we'll move on. So I'll be very, very gentle here. The only luxury is you have only one passage. You will not enter into the airway. Many times, if I need be, I use a McCoy type of blade for me to assist it and then look into the scope. I think I'm getting into it. The lumen may not be that very wide, so I'll be meticulously searching for. So once again, I'm reorienting, coming back. So tongue, it's fine. Yes, can you appreciate that? So I'm doing it, sir. I'm going to do it. I'm just trying if my scope can be taken even closer. My scope is limited by the external pressure. So I'm going to retain here. My technician, his name is Mahesh. Mahesh is going to help me to hold the scope. As advised by Ishu, sir, we'll pass the guide wire. Can we have the external view here, how the guide wire is? This is a floppy guide wire. If you could see, can you see that?
Yes,
this
sir.
is a floppy guide wire. So any dilatations, it is prudent you use a floppy guide wire. Here you have a guide wire passage cannula, because many times these valves are governed with narrow openings because to protect the air leak. So these type of guide wire passes are very helpful. So please keep watching the endoscopic view. So this is a special type of guide wire. This is a metal guide wire. You can see like a spring tip. The advantage is they don't get broken. They can be used for reprocessed and used for multiple times. And the second advantage is they are relatively more stiffer than the typical tiger type of guide wire. So you can see guide wire is going without any stress. Can you see that?
Yes, sir.
So that is very, very important.
Can
We'll
we-
have a screen check.
Fluoro view, please.
Can we have the screening done, please? Madam, screen, please. Yes, sir. Guide wire has to go a little more. But then guide wire is not going, sir. Beyond that, it is getting stuck. They have noted one other stricture beyond. So I'll try to do it, sir. I'll use the guide wire as a guide. Maybe if necessary be, we can use a pediatric scope also. This part itself is firm, sir. Screen, please. Up till the tracheostomy tube, it is going. Screen. Screen, please. Up till that much only it is going, sir. 1 second. I'll try, sir. I'll try. Keep it like that, please. Screen. I'm not sure whether I'm getting in. It looks like it is going into the, let me see if it reaches the stomach. I think I'm winning here, because generally if it is in the mediastinum, they don't enter into the stomach. That is one other trick, because we have learned in a hard way. Many times we think we have passed the guide wire, we end up having in one of the mediastinum. So we allow the screening to happen, go till the stomach, ensure it is along one of the curves, greater curves. Can you screen? You can see the guide wire freely floating into the stomach. This is yet another technique we have evolved after so many tough experiences. So any upper GI stricture, place adequate guide wire into the stomach. That is the, are you okay, madam? Should I wait? Patient is little light, madam. Maybe you give some. Patient is a bit light. Can you have the screening chase towards the chest? Keep screening and moving. Yes. Keep going down. You can see the tracheostomy tube, the esophageal lumen, and then you can see the guide wire nicely into the stomach, nicely folded. So thank you very much. And then now I'm going to remove the scope. So can you gently remove the scope? Gently. Because I would like to retain the control of the guide wire. So camera person can focus the guide wire being sent, and the scope simultaneously comes out. So focus here. He is very efficiently holding the guide wire. The scope is now getting moved out. So here the average length of the guide wire should be minimum of 2.5 to 3 meters for you to pass the Savary gland. Savary gland length comes in, but the original Savary gland is roughly about 90 centimeters or 3 foot. But there are minor corrections which have come after the Chinese ones have started coming. If you see the tip from, can you have one of the, we'll use 9 or 7 we'll start with, 7. See, if you see, can you show this? There is a radio-opaque marker here. From here, it is 7 centimeters to the tip. So this have to be marked, And another marking is 9 centimeter. These two markings are very vital, especially these are the ones which help us to visualize when we are inside the lumen. So, metal guide wires are particularly useful for SG dilatation, like Teflon guide wires are useful for balloon dilatation. See, can you have the camera down here? So I am starting with 7 because I am unsure how narrow it is. Scope did not go, so that is less than 9.8, that is for sure. Guide wire also took some resistance to go. So I don't want to take a chance here. So I am starting with the smallest possible diameter. So can we apply jelly? See, the jelly needs to be applied, and yet spiral torquing. Spiral torquing is essential for safe thing. Never try to shut. Can we have a screening, please? Upper. Guide wire hold. Yeah, thanks. Always hold the guide wire like this along with the tube. You can see that Savary is just now coming. We have marked the upper border. I am able to pass the Savary down. SG dilator is going without much of a challenge. That's what I would say. So 7 is adequate. So from the first degree of tightness, we go up till 3 size higher. That's a rough formula. The 7 goes without a hassle. But again, I will take this opportunity to see whether it goes into the stomach. Can we see the stomach? See, it takes the curve. This is secondary confirmation. After that, you don't need confirmation. Stop screening. Till the Savary comes out of the stricture part, it may be little oriented or not allowed to be straight. So it will be cautious. Very easy for the guide wire to get pulled out. Guide wire have come out. Wait. Hold the guide wire. Got the guide wire? Wait. Don't pull in a hurry. Hold it. Right. Take the Savary out.
What's going to be your end point here?
Sir, ideally, I wish to give 10 millimeter minimum, sir. 10 millimeter. So here I will go one size above 10. So possibly 11 and then stop, sir. See, 5 gives dysphagia to liquids. 10 gives dysphagia to solids, anything less than diameter. So ideally 9 plus diameter is essential for a reasonable quality of life to swallow. Again, every time be meticulous in applying jelly. Spiral movement is safer rather than vertical movement. Can you hold? Yeah, a little bit. Thanks. A bit of alignment is helpful. I would say chin lift. Screen, please. You can see the dilator coming. I think once it crosses that level, esophagus is fairly friendly. It is taking its normal curve only. This is going with little bit of resistance only. Stop screening. After that particular part of narrowing, it goes without much of a hassle. All right, so normally we allow 30 seconds to 1 minute for it to hold so that radial fracture happens in a phased manner. Many times these tracheostomy tube bulbs, they are many times they are not competent. So you will have some amount of anesthetic gas leakage. So please ensure you don't allow the suction fluid to get into the airway. That is very important for them. In this patient, we have the luxury because they have done a total laryngectomy and end tracheostomy has been done. So you don't have that problem. But otherwise, if you have a common channel, especially in corrosive, where the entire pharyngeal complex is burnt, it is prudent you keep suctioning the oral cavity. So the technician normally keeps a Yonker suction all along so that you don't allow the fluid to go in. Because tracheostomy type of tubes are not that very great competent tubes like an endotracheal tube. So I am just coming out now. This is number 9. I will go to 11. Little tough. Oh, okay, no problem. Hold it. I am too cautious. Yes, sir. Once, many times, sometimes we may not be able to cannulate again. This is 11, right? Right. So again, this number they mentioned, this shows the amount of usage this average glad has gone through. But then generally, it is prudent you have a set of 5 numbers. Starting from 7 to 15 you keep. They generally don't give 13, so 12.8 remains the number. For want of the unlucky 13, they have made us 12.8. Otherwise, all odd numbers are the typical size of the salivary gland on the chart. Yeah, hold it. Generally, you can see the glove finger getting blood. The presence of blood indicates, again, successful dilatation, because they are normally passing in or non-dilated. See, when 7 went in, it just went in easily. When you see blood, then you know that you are effectively dilating. And with experience, you will start gaining to know when to stop. Otherwise, if it is not going, please stop. That's the general dictum. For beginners, till your hands are familiarizing how much of pressure you can exert, you keep caution. If you feel it is not permitting, you generally don't push it beyond. Screen, please. So you can see going in well without much of a hassle. This technically goes in without much of a challenge. So maybe we'll yield one more size, sir. I wish to, sir. Let me see how comfortable it is. This will alleviate the dysphagia for sure. Let me keep the scope and see, sir. Yes, sir. Sure, sir. Sure. Absolutely, sir. Generally, we say if you have a clock, you count by the seconds. Otherwise, we say we count 200 pulse beats. So normally it takes 3 minutes of time for you to cover. Sometimes you end up nobody carrying. Nowadays, it is becoming rarity for people wearing watches, the mobile phone on. But timers have come in. But then generally you keep counting for 200 pulse beats. That's what is the rough formula. So I am pulling it out. Not much of difficulty I am facing. So Ishwar sir suggestion is to keep a scope and see whether what is happening. So the next common problem, or at least we have seen in 5-6 cases, we believe it is a stricture. End of it, it could be a malignancy which is lying in, recurring. Very recently, the day before yesterday, we lost one young chap. Patient was diagnosed to have a tracheoesophageal fistula. Patient has consumed corrosive scope. Corrosive. Sure, sir. Along the wire only we can try. If not, sir, glove protocol, sir. Blood stain there. Keep it with you. So I am trying to pass in a scope. This guide wire sort of helps me to guide the. One second. There are enough.
We are not getting the endoscopic view.
Sir, nothing is seen in endoscopy. Don't worry. Anyway, we'll get the endoscope soon. The supine endoscopy is a typical example of it. So people should have a hang of supine endoscopy. Let me try. I may be winning. I may not push this, sir. It's not permitting. On the side, sir, on the 12 o'clock zone. So you can see nicely opened up, but for some reason, I am unable to pass the scope, and I don't want to stress also. So roughly up till 15, so that obviously means the site of the sixer is just above the trachea. So that means that's the area of maximum irradiation, but this should be adequate for the patient to swallow. See, please understand, this looks wider, but for technical reasons, because of the hyoid and other bones, it may not allow. Technically, if you see, this scope should go inside, but let me try once more.
It will pass.
We need to worry about the scope also. I may not push it, but then for some reason, technically it is not going. But whatever it is, we have achieved the therapeutic goal. So I will abandon the scope. But one thing I can tell is, beyond which the mucosa looks healthy. And the telltale evidence of fractured mucosa and other things are because of our dilatation. Mucosa by and large looks all right. You can see the radial fracture which has happened, but then you don't see any abnormal mucosa all around. So on that basis, I am coming out with good note that we are not dealing with coexisting other diseases. Yes, sir. So that completes the process. Thank you very much, everyone. Thank you, sir. Thank you. Thank you, madam. Thank you. Thank you, team.
Sir, excellent demonstration and a cautious
Thank you.
overview.
Thank you, sir. Now we'll be shifting to OT number 1. Case 40 years old female came with intermittent pain in abdomen since 1 month. Nausea since 1 month. She was operated on February year 2025 for laparoscopic necrosectomy with cystogastrostommy. Post which she developed complaints of abdominal distension again in February 2026 after 1 year. At that time, the CT showed 2 collections which were thought to be interconnecting. Therefore, we did endoscopic cystogastrostomy. Now we see in July 2026 that the first cyst has already collapsed and the stent is seen in situ by the yellow arrow shown in the CT. Now this is the other cyst that is seen in the posterior wall of stomach, which will be taken care of today. And our plan is EUS guided stenting. Over to you, sir.
Hello. Am I audible?
Yes, sir. You are audible, sir.
Yeah. So in our department, our protocol for the management of peripancreatic collections is that if there is a just pseudocyst which is symptomatic and which is not resolving and without much necrosis, so first we prefer to do transpapillary endoscopic drainage. That means through the papilla we enter into the pancreatic duct and we do pancreatic stenting, and most of the time this cyst resolves. But if there is a significant necrosis and infection, if the necrotic volume is more than 30% of the cyst volume, then we prefer to do laparoscopic single setting transgastric intraluminal necrosectomy. And if the pancreatic duct or ampulla, we cannot cannulate this ampulla, or we cannot, pancreatic duct is completely disrupted. In that cases, then we do endoscopic cystogastrostomy just, if there is no necrosis. So we do internal fistulization of this pancreatic collection in the gastric lumen. So this patient, she had initially necrotizing pancreatitis 1 year back. So we did laparoscopic necrosectomy with cystogastrostomy. And after that, she was all right for almost 1 year. And now in the month of February, she presented pain in abdomen and epigastric lump. So on investigation, there were 2 cystic lesions in the epigastric, in the retropancreatic, retrogastric area, and it was reported that it's communicating. So we did, since already laparoscopic necrosectomy was done, and if you have seen on CT scan, it is a very clear cyst. There is no necrotic component. So we did endoscopic cystogastrostomy. And after that, again we reassessed this patient, that the one cyst which was where the stenting was done, it has been completely resolved. But the another cyst, which is at the head of the pancreas, it has not been resolved at all. That means it was not a communicating cyst. And since it is a clear cyst, there is no necrosis, so again we will prefer to do endoscopic cystogastrostomy with the EUS cystogastrostomy for the second cyst also. If you see on the, on luminal endoscopy, we can see this previous stent still there. And appreciate this previous stent, previously done cystogastrostomy. On CM also, you can see CM. So this is a previously placed cystogastrostomy stent. If I now go towards the head of the pancreas, you can see there is another cystic lesion. उसको थोड़ा resolution ठीक करो ना. Can you appreciate there is a?
Yes, sir. Yeah, it's a very complex cyst with a very lot of necrosis around. It looks like quite deep, the cystic component.
एक मिनट ना एक मिनट let me. See, actually ना the resolution is not good. This is a demo. I'm not happy. See all lines. It is not very clear. So this EUS is more sensitive investigation to assess the amount of necrosome inside the cyst cavity than the CT scan. So if you are suspecting that there is a necrotic cavity, a lot of necrosome is there, then MRI is preferred over the CT scan to assess the necrosome. And again, more than MRI, EUS is more sensitive to pick up the necrosome. So if you see this part of the cavity, resolution ठीक करो भैया. So this is more liquid component. You can see this. So this is at the on the medial aspect inferiorly. But if you go, as you go towards the pylorus, you will see more necrotic area. Can you appreciate now?
Yes, sir.
This is more necrotic.
More
grainy and all that. So I think this is not a good candidate to this part of the cyst to do endoscopic cystogastrostomy. So LAMPS is a better option, but we are not prepared for the LAMPS. We don't have that LAMPS. So these are the So these are the lumen opposing metallic stents. So these are the better stents which can be passed through the stomach into the necrotic cavity. And so it has two benefits. One is that it forms a very wide opening for the drainage of the necrotic material. And second benefit, that we can pass the gastroscope through this state And we can do further, irrigation and necrosectomy, endoscopic necrosectomy. So repeated entry into the necrotic cavity is possible if you push the, these metallic stents. So I think we'll not go ahead with the abandon, and we'll do lamps in the next setting.
So
But this is how
what those shadows in front are the blood vessels? What do you see in front
so these
around
are,
1 o'clock?
These are no.
Yeah.
So these are the previously cystogastrostomy fibrotic tissue.
Okay.
So if you put on the this flow, there is no vascularity.
Okay.
Flow dal do. Okay.
Okay. Understood.
Yeah. So if I will just show those who are seeing for the first time, US. So this is the esophageal junction here. This is the left lobe of the liver. Can you appreciate?
Yes, sir.
This is the diaphragm, and before that is the IVC. Flow nikal do. Flow nikal do. See, this is the right atrium. This is IVC here, and after that you can see the hepatic veins. Can you appreciate hepatic vein? This is the left
yes,
hepatic vein. Okay, and then joining IVC. This is left lobe of the liver. Then you come behind and do clockwise torsion. You can appreciate the aorta. So this is aorta here. Okay? This is aorta. Once you trace the aorta below like this, down, we will appreciate the celiac trunk. The first branch of the, branching is the celiac artery. Can you appreciate? This is first branch.
Yeah.
And below that is the superior mesenteric artery. There are two openings from the anterior surface of the aorta. So the first is the celiac trunk, and second is the superior mesenteric artery. Can you appreciate?
Yes, yes.
Yeah, एक मिनट. Arrow mark ले लो इधर. So this is aorta.
Yeah.
And if you see anterior, sir, this is the first is the arrow mark उधर ले लो. This is the celiac trunk here, and below is the superior mesenteric artery. Okay, can you see these two?
Very clear.
Once I go behind and rotate it a bit, we can see the seagull sign. Can you see now? This
Yes,
is the
yes.
this is the splenic artery arising from the celiac trunk, and this is the common hepatic artery. So this is known as the seagull sign. Can you see common hepatic artery?
Yes.
Okay.
Thank you.
So endoscopically US guided, we can do this celiac block very precisely sitting on the aorta under vision. In case of chronic pancreatitis or for the malignancy. Thank you.
Sir, how much is the depth of visualization for the US?
Pardon?
How much is the depth of
So
visualization?
there are settings, depending upon the need, we can increase the depth or we can decrease. So this is a high frequency probe. So we can go up to the 5 centimeter comfortably. Depth. Range. See, now we have increased the depth.
Yes, sir.
Okay, so it depends upon the your requirement. You can decrease it or you can increase it. More you increase the depth, more it becomes more granular. You decrease the depth, the clarity improves.
Thank you, sir.
So in our institute, what is our strategy? That if there is a pancreatic pseudocyst with less than 30% of the volume is necrosis, then we prefer to do transpapillary, and if it is not complicated. The complicated in the form of it is not infected, there is no bleeding, and there are no multiple cysts away from the stomach. Then we prefer to do transpapillary endoscopic drainage. If we cannot access transpapillary, then we do transgastric cystogastrostomy. If there is a significant necrosome or if it is a complicated cyst, then we prefer to do surgical intraluminal transgastric cystogastrostomy. Even EUS is an excellent tool for the pancreatic fistulas or the pancreatic ascites or the pancreaticopleural fistulas. In all cases, we do EUS, endoscopic transpapillary stenting, and in 90% of the cases, this fistulous tract get closed.
So the transpapillary procedure is similar to the sphincterotomy during an ERCP.
Yeah. So we have 2 more cases now. After this, we'll show transpapillary management of pancreatic fistulas.
Yes, sir. Thank you.
Thank you. And shift.
Are you okay?
Check. Friends, again, good afternoon to all of you. Hope you all had a quick lunch in between, because we have a lot of lined up cases. We don't give a formal break.
Now we'll be proceeding to the next case.
Please tell about the clinical details, doctor.
25 years old male came with chief complaints of dysphagia, solids equal to liquids in 7 days, and burning sensation over chest regions in 7 days. HRCT chest was suggestive of hiatus hernia and mild circumferential asymmetrical thickening of the infracarinal esophagus with light mucosal irregularity suggestive of esophagitis. Our plan is upper GI scopy, and learning objective will be upper GI scopy for evaluation.
Thank you, doctor. Friends, I perused the records, and Dr. Musande sir is with me.
Over to you, sir.
Thank you, ma. Thank you. Friends, good afternoon again. Professor Musande sir is with me. The last scope he has done, he has noted extra long esophagitis and quite a friable mucosa. So he feels it could be not a conventional typical type of esophagitis. So when somebody says like that, I have in mind 3 or 4 things. One is inflammatory esophagitis or autoimmune esophagitis. Inflammatory can be Crohn's, but when you don't have any other disease, isolated esophageal Crohn's is not that common. The second thing is eosinophilic esophagitis. Here you see concentric rings, white exudates, sort of necrotic tissue and other things. Concentric rings can be there. And please be aware, at least 10 to 15% of the eosinophilic esophagitis can be totally extramucosal also. But inflammation alone are noted. The last troublesome elements are the following the HIV. We have noted a lot of experience on that. The herpes simplex virus, HSP esophagitis. The other one is the CMV, the cytomegalovirus esophagitis. And the other more common things are the Candida fungal esophagitis. So let us see what we are dealing with. So once again, the standard of care have to be well anesthetized patient. You can see the armamentarium the anesthetist is having, propofol, all 3 drugs, wonder drugs they are having. And they have given a comfortable, quiet patient for me. I have a team of excellent technicians from the morning. So again, I'll inspect the supraglottic zone.
So the endoscopic view, please.
So this will, can we have the endoscopy view to the hall, please? So this is the supraglottic vasculature I am looking upon. The Dubai consensus gives the grading of the supraglottic and laryngeal inlet telltale signs of esophagitis.
Sir, we don't have the endoscopy view.
Give me a moment, sir. Somebody is working on it. AV team, can you provide the endo view to the hall, please?
We now we extend our heartfelt gratitude to our chairperson for chairing the session. Thank you, sir. I now request Dr. Rahate, sir, to felicitate our chairperson.
So we are now moving on to the esophagus. The upper esophagus looks innocuous, innocent. You can see the normal fold and a bit of peristalsis is also appreciated.
Dr. Nilesh Soni, sir, Dr. Khandage, sir, Dr. Nitin Gotwal, and Dr. Yogesh Goye, sir.
Good afternoon, chairpersons. Very warm welcome to you on behalf of the MGM and Professor Pravin, sir. So we are now getting into the esophagus. I think now we are about 27 centimeters. You can see some mucosal changes coming into the vision. You can see almost 27. This looks long linear ulcerations. See, generally the herpes simplex is small, deep
We
ulcers.
now move on to the next
Here,
session. I welcome our esteemed chairperson, Dr. Ram Tirke, sir, and Dr. Abhishek Zadav, sir.
So now we can see a broad space, like geographic tongue-like type of lesions one could appreciate. My bet
Sir,
here
kindly
is,
come forward and commence the next session. Thank you.
so now my guess here will be either CMV or a possible eosinophilic. But eosinophilic has to be concentric. That is one thing which is not seen here. So we'll plan for a biopsy, certainly.
Can you put the NBI now?
I'll do that, sir. Can you appreciate, sir, the NBA? So the NBA helps me to take the biopsy from the respective zone. So that helps me to take the yield maximization. So again you see the G junction is not tight. So this excludes the peptic type of esophagitis, because with these type of deep linear ulceration, almost confluential, you expect a little more tighter esophagus in G junction. This looks very yieldy. But again, I will have my own reservations when such a patulous G junction is there. Could be still acid reflux also, severe form of acid reflux. I think the department is already planning for more pressure studies and 24-hour pH studies. Now, the regular scope, I am going along the lesser curve. This is there is some extrinsic shadow close to the pylorus. We need a biopsy forceps, probably spiked one or so. Keep ready. Thanks. Yeah, thanks. There is some extrinsic impression along the greater curve. Maybe need to review with the radiologist to look into this affair. So I'm going to take you through the process of doing a conventional endoscope again. So I've gone beyond. So duodenum looks fairly featureless. So that again indicates not much of small bowel contribution to this. So I'm trying to visualize. Can I have a gas piece, please? So let me see if I can show you more of duodenum. So I'm trying to shorten the scope. So little bit of this thing helps us to recruit the duodenum. But duodenum, this we have just come to the transverse duodenum. Looks fairly healthy. So I think I will withdraw the scope and concentrate more on the esophagus. So again, once again, I should take time to look into the entire circumference, not to see one wall and pull out the scope. Many times minor details emerge. Thank you, Ma. The team is so fabulous. They know my needs and they are too willing to help. So once again, the entire duodenum, D2 onwards. Now I have come to D1. It looks fairly healthy, I would say. Little bit of erosions. Otherwise, once again. Just to check the D1 again, once again, it slipped out of my view. Healed ulcer maybe. This looks technically all right. So duodenum, there is no contributor. I'm not sure what it is we are dealing with. Can we have a water jet, please? Press, please. Yeah, press, please. This is not an ulcer. Yeah, thank you. So this is the lesser curve. Again, make a point. You see, this is the posterior aspect of the lesser curve. This is the anterior aspect of the lesser curve. So the incisura has to be screened from anterior to posterior or posterior to anterior. It is not, many times we end up seeing like this and come out. No. So it has to be screened in full. The entire length of the incisura has its own secrets. So make a point, you see the entire thing. So now I'm coming back. So there is some amount of extrinsic impression. I wish the team, residence team, to have a discussion with the radiology group, colleagues. So you can see the OG junction looks fairly healthy, good tone, and it approximates the scope well. You can see a little bit of punctateness, but otherwise there is unremarkable arrangement of the fundus. So we are heading back towards the esophageal side. So I'll be doing a sequential biopsy. I wish all of you take time off to read the BOSS program. The BOSS program is the bariatric esophagus surveillance system by the Australian government. So something like that, I'm going to do radial biopsies so that the biopsies have to be started from the OG junction radially, say by quadrant wise or by clockwise you can take. And this has to be documented. When you send the report to the patient, this has to be documented. Where exactly you have taken biopsy, so that if and if you see some mucosal pathology, they'll be able to correlate, the next endoscopists will be able to graphically understand. I'm sure all of you would have had your turn off in your school using the graph chart to mark the XY axis, something like that. They do a radial marking. So here, if you see almost from the Z line, let me see a little bit of, this looks fairly healthy. Maybe I'll start taking a biopsy from there. The points, these are the whitish fellows where I'll be keen in taking a biopsy. So essentially these two zones are more active zones. All right. So I will do biopsies from the OG junction. I think they've kept enough, can you focus this? They've kept enough blotting papers so that We will label distal first, taking 2 or 3 bits, and then we label middle, and then we label upper end. Once again, the measurement is, the true OG is 40 centimeters. Let that be documented. So, and then the length of esophagitis is, see, almost starts from here. Yes, yes, yes. From here, here, here. Yeah. So, even less, 28, sir, 28. 28 to 40 is 12 centimeter long. So, quite a fairly lengthy esophagitis. Doesn't look like monilial because you don't see cardioid precipitates. The only thing is this necrotic slough. Without concentric ring, I will hesitate to tell a potential eosinophilic esophagitis. The second thing I have in mind is CMV esophagitis. CMV is essentially inclusion bodies in the histology, where the pathologist will find vacuoles. Very rarely CMV serology can tell CMV is high positive in IgM. Many times it is immunocompromised state. This boy looks fairly healthy only, but then if they have traveled to high risk zones, the next common thing we have in mind is now Ebola. This patient does not give history of any overseas travel. That is one other indication where people end up using disposable endoscopes. Can we open this, please? Thank you. Catch. So this is 6 o'clock zone. I will be taking vertically across. Open, please. Thank you. Close. This you put G, close to G junction, right? Fairly inflamed one. Open, please. So I am going to take along the 12 o'clock zone, catch. Ensure you are catching in the right zone before plucking. Yes. 12 centimeter esophagitis, sir. Open. Close. So please warn the patient that he may have blacky stools for a day. Looks little bloody procedure only. I will try now 3 o'clock zone. Open, please. Catch. So I am planning to take and taking a radial sequence biopsies. Now what I am left with is 9 o'clock position. Open. Yes, sir. Catch.
Lunch. Yeah, ready, yeah?
Open. So all this thing goes to lower bottle. Then prepare one, another bottle. Now mark this as upper end. This is lower end, or close to G junction.
Do we get a continuous linear ulcer in cytomegalovirus?
Unlikely, sir. Linear is typical of GER only, sir. Very, very unlikely to be anything else. Very, very rare for someone to get. Now I am sure maybe he's little bit of aspirating. I'll suck away all this. Are you okay, ma? This healing and this thing looks more of reflex only, sir. Because in between there is fibrotic healing. Yes, sir. You try pH, sir, 24-hour pH. Open. Catch. This is the upper end of the lesions. Not it, not it. Some more bit is there. Leave it like that. You put here. Okay, leave it. We'll take one more. Open. This is 12 o'clock zone. Catch. Yes. Open. Open. Catch. Open. Last one. Open. Catch. Yes. Open. Open. Yes. Thank you. So I'm going to suck thoroughly because I kept a lot of fluid to be washed, so that will help the anesthesiologist to handle the airway in a better way. Especially when you are irrigating the esophagus, keep little bit head low. But here the patient is quite comfortable, but again, as a caution, we generally advise head low in these patients, full table tilt. So I think fairly I'm clear, ma'am. The esophagus is free of this thing. Kana? Second. Give that biopsy forceps. 1 second, 1 second, but just hold a moment. Open, open. Catch bar. I'm not sure this is something useful, but let us see. Bhaiya, remove your finger, Bhaiya. Remove. Gas. Kana, don't pull, ma. Open. You have a good length of tissue. I don't know whether it's clot, but send it for. Looks like clot only. Send it. If they're able to get some tissue out of it, it's fine. Close the biopsy first. Put in the upper end. Thank you very much, team. So that completes the endoscope.
Cytology from that clot, is it useful, sir?
Sir, I'm not sure, sir. It looks like a clot only for me. We will wait for the pathologist to declare there is only clot, sir, because I don't want to lose any information, tissue information, which can be of benefit to the patient, sir.
Thank you. Nice demonstration, sir.
Thank you, sir. Thank you, chairpersons. Thank you, team. Thank you, anesthesiology and tech team. Thank you very much. Bhaiya, can you remove this, Bhaiya?
Hello.
Thank you very much.
Right, Alok. Hello, now we'll be moving on to the next case. 38 years old. 38 years old female came with chief complaints of pain in abdomen since 1 week, nausea since 1 week. USG was suggestive of 4 mm calculi, GB wall thickness of 4.9 mm and CBD stone of 3.9 mm with edematous gallbladder. ERCP with CBD stenting has been done outside on May 26. Cholangiogram suggested of dilated CBD of 10 mm and filling defect of 12 to 14 mm. And the impression was choledocholithiasis with extrahepatic biliary obstruction, cholelithiasis, sphincterotomy with CBD stenting done, impacted large distal CBD calculi could not be retrieved. So this is the ERCP report from outside. And now you're going to try to remove the large stone that was impacted and could not be done in the previous ERCP. Plan is ERCP with balloon plasty and learning objective is management of large CBD stone. Over to you, sir.
Yeah, so I'm just going to have a look at the ampulla, probably take the stent out, then do a, preferably with the sphincterotome, the guide wire, pass the guide wire, and because already she has a wide sphincterotomy, all the contrast is going to leak back. So I'll just push a balloon and do an occlusion cholangiogram to know the roadmap, then we'll proceed. So it's going to be multi-step, but essentially this is one of the 3 ERCP cases we are planning post-lunch for people in the auditorium. Just to introduce for the beginners, as we can see here, it is a side-viewing scope. And what will happen is, because of the side view, you tend to see only the side of the esophageal or gastric wall. To make the luminal view little better, sometimes what you can do is the big wheel, you can turn away from you a little bit like this. So if you do that, it'll give functionally, if you go in like this, then you may have some degree of luminal view. But the dictum is, don't push against resistance. As you can see, the caliber of the endoscopy is slightly wider than our conventional upper GI endoscopy. With that little introduction, we'll start navigating. As you can see, the patient is in a semi-prone position. What I request my colleagues is to lift the shoulder to one side until I enter into the D1. So this is the plan. So let's see. Yeah. Can we just bring her to the edge, little to this? That shoulder has to be lifted. Yeah, that's okay, that's fine. Yeah, that's good. So as you can see, now you are only seeing the side. If I just put a little away, then you will be able to see a little luminal view. See, you have a little luminal view. We are just at the OG junction. As soon as you enter, what we do here is you turn the scope anti-clockwise to any fundal fluid. Otherwise, you turn it clockwise and then go along the rugal folds and reach the pylorus, what I call a long route. And the pylorus is now, because of the side wing edge, is seen at what I call 6 o'clock, what is typically called a sunset position. See, this is a sunsetting pylorus, all of you see. So slowly you'll see the pylorus started disappearing, the D1 started appearing. Then at this place, your navigation is the key to, or the D2 is your small wheel. I'll turn the small wheel, and then just to go a little bit in, lock the small wheel. Then I pull the scope, I'll turn my body. So that way, I'm able to see. So I think probably I need a rat tooth better. You have a rat tooth, because now we need to remove the stent, preferably. Yeah. So my go-to instrument here is obviously the rat tooth. And one of the additional gadgets in the side-viewing duodenoscopy, I should have shown you, but I'll show you in a minute, is the elevator. So the elevator is going to help me to adjust the trajectory of my accessories. Just let me just get a little closer. Yeah. Open. Close. Yeah. See, I have checked. It is okay. It is slipped, I think. Is it? Open again. Yeah. You. Yeah. Close it. Have you got it? Can we just screen? Just let me just see. Screen? Screen? I think it is not moving, is it? Have you got this stent? I don't know. You got it, the stent. I think you slipped it.
Sir, can we put gastroscope and
So
remove
we'll
stent
just
first
go
and
again
then
one more time. Sunset position of the pylorus. We enter the duodenum, the D1. Yeah. Open. Close. Close tight. Tight. Can you screen? Slipped, huh? So I think we need to go for a snare only. You have a big rat tooth. This rat tooth is not working. It's already has come out partly. Let me just. Can you have a what is this? Big one? Same rat tooth, right? This is not going to work. Big one, or you need to have a snare. Yeah, snare. Get the snare. Let us try with the snare. Yeah. Open. Yeah. Close. Close. Yeah. Close, 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 close. Keep closing. Close, close. Keep. Yeah. Oh, it is snugly fit. You go and take all your team nurses, doctors. AV team also should eat. Yeah. Oh. Yeah. Let me just see the lower end. Can somebody hold the scope here? This position. Yes. Yeah, I think the scope has to be done. Somebody has to come on the head end, trying to hold the scope. This position. Somebody can put the glove. This position. Yeah, take your time. Take it. Yeah, just twisted position. Scope, twisted position. Like I have twisted like this. Like this. Yeah. Yeah, that's what I'm. Sometimes it bends. It never works like this because the snare is not big enough, you see. Ideally, I need a big rat tooth will do the trick. You have big rat tooth, that will do the trick. Open. Open? Yeah, that's right. Open? Are you open? Yeah. Just keep it open. Keep it open. Close, closely close. Slowly close. I think got it. Yeah, close it tight. Let me just try one more time. It's because already it is. Can I just screen?
Extended esophagitis is completed. Direct
Third time lucky. Let me just see. Yes. Yeah. Yes, fine. One more time. Yes. Make sure the airway, you put it back again. Yeah, now we managed to take it out. Big rat tooth, we managed it. The stent is out now. The first problem. Yeah, that is. Yeah, you can drop the patient. Just mark a, yeah. Can we have a sphincterotomy with the guide wire? So we can see now with the, we went for the big rat tooth that was able to take the double pigtail stent. Now we are able to see the ampulla, and is sphincterotomy adequate is the first question I'll ask myself. Before that, let us just see the mug car coming. Just let me cannulate and see whether I'm able to get a biliary anatomy. Then see a limited sphincterotomy, leave the guide wire, do a sphincteroplasty, then comes about a balloon sweep. So this is my line of action. So just to go at 10 o'clock position, I think the big wheel, you bring it towards you, it takes the cannula in the direction at 10 o'clock. The guide wire goes easily, and there is about a millimeter or two I can do a extension if I need. Can we just have the screen? Yeah. Please, yeah. Go in with the, yeah. Can we just, yeah, let me just go in deep, just start injecting contrast with this one, maybe. So ideally, you should not start injecting the moment you push it in. Can you just push with the guide wire a little further, deep? Screen? Yeah, it has gone in. So it has possibly gone into the left system. Can we just start injecting the contrast? Yeah, yeah. Yeah. Screen once. Can you screen? No, yeah, just we have to be mindful whether it is all air bubbles. Let me just see. This, if we can come down a little bit down. Just if you could bend, yeah, sorry. Yeah, there is a large stone, isn't it? Low down. That's fairly large one, actually. That's why. Okay. So what I have, yeah. Keep the guide wire in. So what they were given is, of course, a clever cut. The clever cut is, yeah. Can you just pull the straight? Yeah, bow the wire. Yeah. And what setting? Yeah. Just a minute. Can you just hold this scope like this? Yeah. Yeah, that's fine. Yeah, 40, you make it 40. Is it connected? Yeah, it is the. Give a wash. Yeah. Can you just exchange for a balloon? Belly. Just close the wire. Push the wire inside. Push the wire inside. So what we are planning is whether we can rely on our time-tested technique of balloon, biliary balloon, and sphincteroplasty. So this diameter of the CBD looks slightly smaller than the scope. So it is around 10 to 11. So I don't want to stretch it beyond 10 or 11 millimeter. So we have a 10, 11, 12 CRE balloon. Yeah. So can you feed it? Yeah. So when you decide to do a balloon sphincteroplasty, there is no need for a very wide sphincterotomy, and already been done. So I'm just hoping that this can be fed through the guide wire, which is decent enough inside, and you should not lose the guide wire. That is a trick. And you can see at 3 o'clock in the monitor, the elevator keep going up and down. So that is going to help me. So just suck on the CRE balloon, aspirate, yeah. So keep aspirating and keep putting a pressure tug on the wire so that we don't. So as I push the catheter, he is just putting a tension on this so that the wire actually, you pull the wire back, because as you can see it has come out. Yeah. Yeah, pull back a little bit. Is it with the contrast or just with the saline? Yeah, balloon started coming now. Just to go deep inside. Let me just go a little. So what you do is you make sure 2/3 of the balloon goes in, 1/3 of the balloon is outside like this. No, guide wire has to be in. Yeah. Yeah. Yes. Can we just slowly start putting, balloon, inflate the balloon. Wait a minute. I'll just go a little bit deeper. Yeah, that's better. Yeah. Start doing. Yeah. So this is a controlled radial expansion. So this CRE balloon has a multiple application. Even today we saw one case of anastomotic stricture dilatation. So this can be used again for a pyloric stricture and now here in the sphincter dilatation. So large balloon sphincter dilatation is now standard of the care. For people with the stones right up to 10 to 12 millimeter, this helps us to take the stone out without doing either type of lithotripsy, either as a laser lithotripsy or a mechanical lithotripsy. We'll just see how we are winning here. Yeah, that is 2.5 is what? Yeah, that is big enough. Just leave it. Yeah. Can we just screen once, please? Yeah. We wish we had contrast within this saline, but putting a contrast inside the balloon actually destroys the balloon. So very often you may not be use it multiple times. One of the reasons that's why we are a bit reluctant. But in a conference like this setting, we could use just to show how it's uniformly stretched. Instead of having a waist, the waist should disappear. But you can see the muscles are all spread out nicely, and keep it for 60 seconds and slowly deflate. There will be dilatation induced bleeding may be there, and if there is a bleeding is more than your liking, you can again inflate, keep it for another 30 seconds and slowly deflate. So that is what we do. So can you just deflate slowly? Yeah. Deflate.
Sir, will you please tell us how to differentiate between pneumobilia
Give
and
it one
stone
more
disease?
try. Just inflate one more time. Yeah, please go ahead. Inflate. Put the balloon back again. Just one more time. Second time when you do a balloon dilatation, it should be much easier. So this way it ensures that when we use the balloon sweep, it will be much more successful. Just go in. Yeah, go slow, and once you got into 13.5, you stop it. Huh? No, it all depends upon what is the diameter of the CBD above, and don't go beyond that size because the chance of splitting the CBD is high. We normally never go beyond 15. That's a maximum top limit. But here we are going to restrict with the 12.5. Can you deflate now? I'm just going to take the balloon out. You put the guide wire in. Huh? Yeah, completely deflate with a syringe. Can you deflate it completely? Can I just try to take it out? No, you have to deflate one more time. Can I have a gauze piece? Yeah. The balloon is not coming. Have you deflated completely? In the elevator is off. Let me guess. deflated. It is not coming out. Yeah. I think guide wire has also come, doesn't matter. Can you just give a biliary balloon? Biliary balloon. Basket, huh? Yeah. Okay, no, you can give the balloon directly. Preloaded balloon will be okay. Directly we go with. Yeah, because I was using more force than liking. Let us see. Yeah. Can we just I want to give this one?
We'll be simultaneously commencing OT number 1.
Yeah.
80 years old male came with chief complaints of pain in abdomen, nausea, and fever with chills since 10 days.
Yeah.
Serum bilirubin was 10.9. Serum direct bilirubin was 9.8. CEA was 6.05.
So we have just reinserted the guide wire. Now we have to put the faith on the effectiveness of our conventional biliary balloon. Why I'm not using a dot?
And CA99 was 71,000. CECT impression was suggestive of low insertion cystic duct with severe biliary dilatation secondary to the abrupt cutoff of CBD, likely secondary to the stricture. We can see the dilated CBD in the video. MRCP was suggestive of cholelithiasis without cholecystitis, over distended GB with GB sludge, low insertion of cystic duct, and severe biliary dilatation secondary to abrupt cutoff of distal CBD. Our plan is ERCP with CBD stenting, and our learning objective will be management of CBD strictures. Over to you, sir, in OT number 1.
Hello. Hello. Hello, am I audible? Hello?
You are audible, sir.
Yeah, thank you. So as mentioned in the history, he is 80-year-old male who presented with fever with chills and jaundice. And on investigations, there is a hugely dilated common bile duct, IHBR, gallbladder, and also there is a abrupt cutoff at the lower CBD. So with query CBD stricture and query malignant involvement of the lower CBD. So here the purpose of doing ERCP in this case is first is to exactly diagnose the cause of the, if you see the MRCP, there is a huge dilatation of the gallbladder, common bile duct, common hepatic duct, even IHBR. And they are not obviously, shown any mass lesion in the common bile duct or in the head of the pancreas. So we need to evaluate these lesions, whether it is really a stricture or it is a colorectal cyst which was there, which got secondarily infected. If this Ishwar Murthy has anything to share, we can switch to the other OT till I cannulate the con. So now the trick for the cannulation of the common bile duct is, this is the, can you see the ampulla here?
Yes, sir.
Hello?
Yes, yes, sir.
Yeah. So this ampulla should be at 12 o'clock position or 11 o'clock position, and your guide wire, this sphincterotome, it should go from 7 o'clock position to the 11 o'clock position. So now we are having optimum position for the cannulation. Just open there. I can also feel the ampulla. It is not that indurated, you know. Inject. Screen. So this is pancreatic duct. Screen. Inject this little thumb.
Can you put the guide wire in? Screen one more time. Yeah. Can you put the balloon up? Inflate the balloon. Inflate. 3 cc, yeah. Inject contrast. So let us do a balloon occlusion cholangiogram. Can you just... Looks like there is a filling defect just below or behind the scope, isn't it? It's fairly large. We need to go just to deflate the balloon. Now I know. Just we'll give one more. Yeah. Screen? Yeah. Now inflate 3 cc. Deflate.
Sir, will you please tell us how to differentiate between pneumobilia and stone disease?
I think in the... You're all right. You're all right. Thank you. Yeah, inflate one more time. You have a mechanical lithocrus. Huh? Yeah. Deflate. Yeah, basket is the only option. Basket or spyglass. Yeah, keep the wire in. So now the question is whether we can do a spyglass or a dormia. What is your plan? Whether, okay. Okay. Let us go for a dormia. Whether it's through the wire or along the wire. Huh? Without wire. Okay. Yeah, yeah. Okay. You have the. Of course, the air bubble is going to float after some time. See, you can see actually the stone just above. I can just see this. And it will be more round in nature, the air bubble. Whereas this usually irregular or a square shaped, the balloon, the stone. And if you inject more contrast, slowly you'll be able to appreciate the difference. But this is the problem when they fill the syringe with a little bit of air bubble, or if the patient already have a stent in, air gets in, pneumobilia confuses the issue. As you can see, actually, I can faintly see the stone. Just through the, just above actually. Let us see whether we can.
Cholangioscope.
Screen? Yeah. Can you just open the basket? Yeah. Yeah. Yeah, yeah. Sorry. I think we got the stone, I think. Looks like it. Can you just take this other guide wire? I think that is going to be caught. This one. Yeah. I don't want that. Yeah. Can you close the basket?
Hello? Hello?
Yes, sir.
Yeah. So I have cannulated, this common bile duct.
Yeah.
Okay.
Open.
So there is a huge dilatation of common bile duct with IHBR as is seen in the MRCP. I have done wide sphincterotomy also. But can you see the exposed this papillary mucosa?
Yes, sir.
So there is no any mass lesion seen here in the, at least at the papillary mucosa. So what I am planning now, I will do cholangioscopy. Okay. And also you can see there is a long common channel. Can you see on CM fluoro image?
Yes, we are able to see fluoro also, sir.
Ek minute. Can you see the dilated pancreatic duct? Can you see?
Yes, yes,
Appreciate?
sir.
Huh?
Yeah, dilated
Pancreatic duct is dilated and there is a long common
Just a
channel.
minute.
Okay. So we'll do cholangioscopy and we'll see whether there is any stricture, malignant stricture is there or not. Okay. If it is there, we can take biopsy also from this cholangio, lesion in the lower CBD.
Yeah, but that is not good enough, isn't it? We need to make sure. Yeah.
So if on cholangioscopy,
Open.
if there is no lesion, then we can label it as a colodocal cyst, which got infected. Screen. Can you see this common bile duct now? And this is the lesion here.
Oh, that is lesion.
Can you appreciate here?
Yes, sir.
There is a vascularity with the occlusion of the lumen with some nodularity. Can you appreciate?
Yes, sir. Yes.
On cholangioscope.
Yes, sir.
Huh?
Yes, sir.
So definitely
Scope
this is not a normal mucosa, common bile duct mucosa. There is a neovascularization with nodularity. So we will take biopsy from this site and then we will get diagnosis most probably. So again, I think it is a malignant stricture of the lower CBD. Can you appreciate? I will try to pass across it. Okay, biopsy process. This is proximal dilated common bile duct. Wash. This is dilated proximal common bile duct. This is a normal wall. Can you see? Appreciate? Hello? Hello? On CM also you can see my cholangioscope has gone almost up to the CSD. Wash.
Can you open it now? Can you
Wash.
Actually, the stone is somewhere low down here. I can.
Hello, Dr. Khandagre.
Yeah. No, you haven't opened it, huh?
Hello?
Yeah, open.
Yes, sir, you are audible.
Yeah. So can you appreciate this normal common bile duct?
Yes, sir.
Proximal? Huh?
Proximal bile duct is seen here, sir.
Yeah. So now I am withdrawing my...
Can you give me a balloon one more time?
Huh?
I can see the stone. Actually, what do you think? You want? Yeah, still there.
Can you appreciate this now?
Yes, sir. Yes.
Huh?
Yes, sir. Why it is not coming?
Okay. See, this is the...
But
I am
even
at
the balloon was doing.
you know,
Let me try one more time.
confluence of the right and left duct. This is the common bile duct. I am now...
The only option we have is FIAGES.
Sir, can we dilate this malignant stricture, suspected malignant stricture?
No, we should not.
Okay.
Yeah. Inflate. Yeah, guide wire in first. Wait, finally we'll just check. Yeah, balloon in. Can you just? No, just balloon in. We'll just inflate the balloon. Yeah. 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 Now you inject contrast.
So slowly, I am withdrawing my scope to come to the stricture area. Can you appreciate the stricture?
Yeah.
Yes, sir. Yes.
Screen. Screen. Yeah. Just withdraw the guide. Withdraw the guide. Yeah, just above the balloon, fairly large single stone. I think needs a CBD explosion. If it is not coming, that's what. Deflate.
Screen.
Yeah, that is what I think. Why? Yeah, this is quite a huge screen. Inflate. No.
Just I'm coming back. Just you can direct it either way. Now you go. Yeah, it should be okay. Yeah. Now inflate. Inflate. I think there is a large stone. Let us inflate 3 cc. Let us give it a final go. Yes. Only it is slipping back sideways, isn't it? So we'll put a stent. Oh, you have to take the, yeah.
Hello, can you appreciate the
Yes.
stricture with neovascularization?
Yes, sir.
Huh?
Yes, sir.
With distortion of the lumen and there is a nodularity.
Right now?
Distal CVD. कमी कर रहे हैं।
Yeah,
बाहर कर।
put it again one more time. It should go now. Yeah, that is the only option. Yeah, give us spectator. It's quite a large stone.
Freeze झाला image. अरे ही दिसत आहे एंडोस्कोपी फ्रीज झाली.
Yeah, try. Screen. Screen. Okay, okay, you are all right. You are not. Just try now. No, no luck. Why is that? Screen one more time. Any luck? Screen. You have to have can see. I think ideal, if you have a spyglass, yeah, why don't we do that? I think that may be therapeutic for the patient. Ask him, ideal case for a, because stone is staring at me. Screen? Just a minute. Just withdraw a little bit and then go. Yeah.
Clear out then. Stand down.
Wait a minute.
Patient is करना है.
Huh? Yeah, thermo is better. But are we not doing a, let us ask Pravin whether he wants to do a spyglass. I think that's probably kinder for the patient, young patient. Already, so we haven't achieved anything different apart from trying for an hour. So we should try, give it a chance, and especially when the stone is like this. I don't want to do an extended sphincterotomy. Do you think? And we have done at least 30 mm. It is much more. It is a 15 mm stone, I think it should be. Yeah, thermo, are you trying? Let us see. There's a probably wide cystic duct. The only stone has slipped. That is the only explanation. So big a stone. I'll just. Yeah, it's gone somewhere. Yeah. Yeah, we have gone, but whether he is happy putting a stent or do a spyglass tomorrow or what is the plan? What we'll do? Okay, if you think that is probably we can do. Just let me just change the guide wire into stiffer guide wire now. Because you can see the stone just staring at me, just quite a big one. Can you just? Yeah, you've gone deep inside. Yeah. Yeah. Then now you take it. Yeah, exchange to stiffer guide wire. Careful. Yeah. Yeah. Yeah, double pigtail, 10 double pigtail. And 7 fine. 7, is enough. We don't know anyhow. 7 French, 10 centimeter. Yeah. You have a release system. Huh? Yeah, okay. Seven French, 10 centimeter is ideal. Easy to put. Okay.
Open. Irrigate नको करो. Catch. चलो, guide again. Spring to dumb. Hello.
Yes, sir.
Yeah. So I have taken 2 biopsies from the stricture.
Yes, sir.
Under vision. So what we'll do now, we'll just put this plastic stent, and then after biopsy report, we'll plan further. So this is, very precise evaluation of the cholangiocarcinomas or the corn bile duct strictures.
If the biopsy turns to be a benign lesion, what will be the plan?
Benign?
Yes. What
Yeah.
will be the plan of definitive plan?
Definitive plan is then he will need, and if fitness and everything permits, we'll do
Screen?
hepatico-jejunostomy.
Yeah.
Okay.
Or colodoco
Can start releasing.
duodenostomy. Stent. 10, double pectin. Any questions? And I hope everyone agrees with this plan.
Yes, sir. Yes, sir.
So now most of these cholangio, like lower CBD strictures or the ampullary strictures, which we used to observe before. Now, if the benign workup like the IgG4 and all that, if it is negative,
The first one.
we do cholangioscopy for each and every, biliary strictures and take biopsy, prove that it is not malignancy. Then we, select other conservative management option.
Yes, sir.
Otherwise, for elderly patient, until otherwise proved, all these strictures should be considered as a malignant stricture.
Screen? Yeah, that guide wire is kinked there. You pull the guide wire a little bit.
So at 4 o'clock there will be inaugural ceremony, followed by oration by Dr. B.K. Rao, and his topic is why surgeon should be doing endoscopy. So it's going to be very interesting. I request everyone to be there to listen to this legendary surgeon who started, pioneer endoscopy work in India.
Yes.
Good.
Sir, you did very precisely demonstration of cholangiography.
Released completely?
And
Yes,
the
yes.
biopsies
Mark
also.
hasn't come.
Okay, so there is the white bile.
Screen? See that
Stent.
guide
You can
wire
see
is
on
bent
CM,
there.
stent is
Can you
nicely
see the
placed.
guide wire?
What's the
Can you pull the guide wire a little bit?
screen? Okay,
Yes, sir.
thank you.
Yes. Very nice demonstration, sir. Thank you.
Thank you, thank you.
Can you take the guide wire? Is it coming back? Guide wire, guide wire. Yeah, a little bit pull. Pull, pull. Pull, pull.
दूसरे
Little.
का था,
One more
pancreatogram
time.
में थे,
Pull.
pancreato को
Screen?
बंद करा है। हाँ? नहीं ठीक है ना, we'll just put the stent. हाँ? Okay, नहीं ठीक है.
That is not going. Screen? Yeah, guide wire is in. That is not. Pull the guide wire. I'll just go in little deep. Pull, pull, pull. What? Is it not coming? You deployed, pull, push, yeah. Release the stent. Yeah. It's not going in. I think it's already bent. I think we have to come out. Take it out. Can you screen one more time? Okay. It's there. Okay. Good. I think we are back to square one. Huh?
Sir,
Yeah. Okay, that may be sensible.
sir,
Yeah, so quite a large single stone. Yeah, yeah. Lunch, and from there we go to the auditorium. Okay.
we didn't put in a stent for that case.
Can we just, yeah, take this out?
We extend our heartfelt gratitude to our chairperson, Dr. Abhishek Zadav sir and Dr. Ram Tirke sir. I now request Dr. Naveen Kasliwal sir to felicitate our chairpersons. Thank you, sir.
क्या टेबल खाली है टेबल खाली करा तो औषध है कड़क Hello.
Hello. So we'll be starting with the next case. This is a special case that Suryawanshi sir is going to be performing. So this patient had gone to an outside hospital with a history of hematemesis. On upper GI scopy, outside hospital, doctor had detected that there was a mass at the GE junction, and he tried to take a biopsy for the same. And after which the patient suffered esophageal perforation. So this is how the perforation looked. As you can appreciate the perforation very well on this video. This is the perforation on the right lower part of the esophagus.
काही दिसत नाही
Sir did PEG for the patient then in MGM, and on CT we got to know that the patient had mediastinitis and pleural effusion, and there was no malignancy whatsoever. So because of the biopsy, the patient suffered a perforation, and then we had done PEG. After the PEG, when we did the repeat scopy, the perforation had healed, and there was no evidence of malignancy even then. I'll show you the images of the healed scar. This is the PEG being done.
Poor. एक मिनट स्टॉप हेलो बंद कर दो इसको हेलो सिटी किधर है सिटी इमेजेस वो पाइमा वो सब in brief, actually, this patient was presented outside with hematemesis, and endoscopy was attempted at that time. And on endoscopy, there was a report. The file gave. There was a report of esophageal growth at the esophageal junction, and biopsy was taken, and later on that biopsy turned out to be negative. And meanwhile, patient developed dyspnea and fever. Then he was admitted he went to another hospital, and in that hospital, because of dyspnea and all that, CT scan was done, and in that CT scan, there was a empyema and mediastinal gas in the mediastinum. And again, endoscopy was done, and in that, this perforation was diagnosed outside. No, we don't know, but see.
Biopsy causing perforation?
No, it was endoscopy induced, I guessed. But for Buraves, there was no history which was suggestive of, chest pain and all that retching. Everything started after endoscopy. Okay, so I guess there was a, reflux esophagitis which had caused minimum, bleeding, and maybe endoscopy induced. So this is the can you see on camera? So this is the report where it was mentioned that there is a file. Proliferative growth in the lower esophagus, biopsy taken. And these were the images. And again, everything was filled with blood. It was like that. Okay. And then he went to another hospital where CT scan was done. And then you can see this perforation was documented. Can you see 2 lumen? Okay, अरे इकडे दाखव. ठीक है. So this perforation was diagnosed almost 8 days later in another hospital, and their CT scan was done, which reported there is a empyema thoracic with gas in the mediastinum. So then this patient was referred to us. So when we saw this patient, there was a huge pocket in the right chest cavity, and patient was febrile, count was high. So what we did first put the intercostal drainage, and then we did again endoscopic examination where this perforation was diagnosed, and also simultaneously that distal malignancy or anything was ruled out. Since after putting ICD, patient was quite comfortable and his dyspnea, fever, everything had settled. So we planned to do PEG catheterization. And then this PEG was inserted. This PEG tube was inserted endoscopically, and patient was kept NBM. After 2 weeks' time, his chest completely settled down, that mediastinal pocket, that also disappeared completely, and patient was asymptomatic. So after that, we did again 3 weeks after PEG catheter, we did a check endoscopy, and on check endoscopy, there was no perforation, and everything, if you see this report, show this. So this was the site of perforation. This was the site of perforation. This is the esophageal junction, and this is the site of perforation. So it had completely healed nicely without any scarring or the luminal occlusion. So now it is almost 6 weeks. So we had done repeat endoscopy after 4 weeks. Now it is almost 6 weeks. Patient is on full diet, and we are taking out this PEG tube. So why I want to discuss this, there's nothing to show much, just we are going to take out the PEG tube. But important thing is that we have to be very, very careful while doing endoscopy. So easily we can perforate the esophagus. Otherwise, a very benign condition, whatever a patient had. And second thing, and again, there was a misinterpretation of the finding. Maybe that when that endoscope is perforated and he came back into the lumen, that time there was a bleeding and there was a raw area of perforation. And that raw area perforation considered as a malignant growth in the esophagus. And it was reported. And later on, again, patient had mediastinitis and all that. So again, this second problem is that this perforation was not suspected. What was suspected is the because I'm sure initially there must have not been so much blood in the esophageal lumen. And when the blood started and he noticed this raw area, that time at least something has gone wrong, should have been anticipated. But again, that was ignored and patient was sent home. And when it was diagnosed, so whenever there is a perforation, you must, assess three things immediately. Okay, what is the rent that you have created? Second thing, what is the contamination of the mediastinum or the pleural cavity? If it is a localized perforation without much contamination, without a very large rent, they can definitely, with antibiotic and conservative management, keeping patient NBM, you can manage this patient. But if there is a significant contamination, there is a patient is going into sepsis, and the perforation is very large, then in such cases, you must first put the ICD drainage, decompress the chest and the mediastinum, and keep patient NBM, and do this, maintain the nutrition of the patient. If the distal lumen of the esophagus is patent, then the PEG catheterization is the best option. But the distal esophageal lumen is not patent, like in malignancy, then you can do feeding jejunostomy also surgically. But keep maintaining the nutrition, keeping this patient NBM, and controlling the infection. It is the best strategy. We should not operate this patient as a first line of treatment options. If there is uncontrolled sepsis, infection, or bleeding which is not controllable, then and then only we should intervene with the surgical management. Otherwise, endoscopic management gives, conservative management is a best option. Now, even in a huge mediastinal pockets infection, we are putting suction catheter, suction sponges inside the mediastinum and sucking out all inflammatory exudate and allowing secondary healing with the granulation of that mediastinal pocket also and the esophageal perforation also. So that is also now can be done endoscopically. So this is the whole purpose of having this case today for the discussion. So any questions about this case? Your comment, Dr. Mandar.
While doing a normal diagnostic scopy. But as you rightly say, these things can happen. So you have to be vigilant while doing scopy. Very nicely managed, sir.
So this is again very rewarding procedure. PEG, percutaneous endoscopic gastrostomy. So we are doing quite a large number of, we have neurosurgery, neurology department very active. So we get a lot of patients for the PEG and insertion otherwise also. So if you see here, this was the size of the perforation. This was the site of the perforation. So there is no reason why anyone should perforate esophagus at this level. Now you can see this is a PEG catheter snare. So you need to cut the catheter once you open. So another important thing, though patient had started eating 4 weeks, after 4 weeks on full diet, still we kept this catheter for another 2 weeks because to get the tract matured between the stomach and the skin. So until unless 6 weeks are complete, we should not take out this PEG catheter. Otherwise, there will be a leak into the peritoneal cavity from the stomach. So minimum catheter should be kept there for the 6 weeks. So now we are cutting it from outside. So this is, we are divided. Now I am pulling it inside and taking it out. Thank you.
Thank you, Pravin.
Yes. Any questions? I was expecting more questions from audience.
Pravin sir, this
Ah.
particular patient seems to have some
Ek minute.
reflux.
I am not getting audio. Yeah, audio ikkada.
Hello?
Yes.
Yes. This patient seems to have reflux.
Pardon?
Patient had reflux there.
Reflex, that's what, yeah.
So why PEG? Why not feeding jejunostomy?
Feeding, yeah, so I told you, see, with control, initially we did small feeds, we can start with giving proper instruction to the patient, he should be sitting after feeds minimum for 1 hour. With all instruction, we did a PEG catheter and it worked. Suppose there would have been reflux and things were coming out from the ICD, then definitely we would have considered for the feeding jejunostomy. But if endoscopy is not and PEG is not possible, feeding jejunostomy initially only I mentioned should be the option.
But it healed very well. Congratulations to you. Thank you.
Our next patient is a patient of known case of drug-induced stricture at upper esophagus with alleged history of foreign body ingestion in January 26. Foreign body removal and Freca tube insertion for pill-induced ulceration was done, followed by stricture in January 26 in outside hospital. She has history of multiple esophageal dilatation and has now came with complaints of difficulty in swallowing solids more than liquids since 2 months, difficulty in passing stools in 6 days, burning sensation after passing stools in 6 days. This is a dilatation gastroscopy video. We are planning her for esophageal bronchodilation, and the learning objective will be management of benign esophageal stricture.
They have to come from all the way from there. Endoscopy room to here. I think somebody is still doing an ERCP.
नहीं रे सैवरी डायलेटर्स SG हाँ SG डायलेटर हाँ हाँ पढ़ ले स्प्रे दिया है स्प्रे हाँ करा 7 चालू करा आधी केले डायलेक्ट माउथ गॅग टाका आहे बंद करा दिला 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 hello hello
Yes, you are audible here.
Yeah, sir.
Audible but not visible.
So we are just,
Yes,
hello.
now.
So,
Okay.
welcome back to this post-lunch session of endoscopy. Hope all have had nice lunch and are ready to grab more knowledge. So, I think they have told you the history of the patient. There is a history of some Ayurvedic pill ingestion, and that pill has caused upper esophageal stricture. So, she has undergone multiple dilatation episodes, and now we will be demonstrating one more dilatation in this patient. And we'll discuss if we have any other modalities available for managing these such complex strictures. So, patient is in left lateral position, and she is sedated. Along with that, we have already also given her 10% lignocaine spray to anesthetize her throat. So even if we are doing it under, even if we are doing the procedure under sedation, it's always a good idea to give her local spray so that the post-op discomfort will be minimal, because will be putting the scope repeatedly, plus the dilators will go through her pharynx and oral cavity. So those things can cause some micro trauma to the pharyngeal wall. And if we have given her local spray, then the post-op discomfort will be definitely less. That's why even if we are giving her anesthesia, it's always good to give her lignocaine spray. So now I am putting my scope. So first we'll assess the injury. She has got a polyp.
Endo view, please.
Can you see the endoscopy view?
No, not yet. Yeah, now, okay.
So as you can see, there is a small polyp on the
She
left.
might be having a laryngeal injury at that time.
Yes. It's prolapsing. So now I'll go into the pyriform fossa. Yeah, can you see the stricture?
Yes.
Yeah.
At what length it is?
So it is very close to the pyriform fossa, hardly 15 centimeter from the incisor teeth.
Okay.
So now the choice is between using a CRE balloon for dilatation or Savory Gilead dilators. So I was told that when I saw the CT scan, it showed the length of the stricture almost 3 to 4 centimeters. So for such complex stricture, it is always safer to use Savory dilators. So in this case also, I am going to use Savory dilators. So I will pass a guide wire, pakda scope. So to pass the guide wires, we are putting a guide wire, and over the guide wire the dilators will be passed. So it is again a specially designed steel guide wire. It is extra stiff. So passage of the bougies will be easier over these guide wire. If you use a conventional jag wire or zebra wire, those are that way very soft. So if the patient has really tight stricture, then passing the dilators on over those guide wires sometimes become difficult. Can you show me the fluoroscopy? Yeah.
Patient had a single stricture or?
Sorry?
Single, it is a single stricture?
Yes, but it is very long. Which was, I saw the CT, at least on the CT it showed a very long 3 to 4 centimeter long stricture. Now the guide wire has gone nicely in. So I'll ask my assistant to slowly take out my scope. Kada? Yes, kada. I just have to make sure that my guide wire remains in position. Now he will hold the guide wire and I'll remove the scope completely. And now on the endoscopy you can assess or you can gauge the size of the lumen.
Hello.
So,
Dr. Rahate.
Yes, sir.
See, interesting story of this patient is that she took some very large Ayurvedic pill for the arthritis, and that pill got stuck into the upper esophagus, and it was there for almost 4 to 5 days, and then she, there was a complete dysphagia and swelling, face swelling. Then she went to the some endoscopist in Gujarat, near Gujarat, Ahmedabad. And there, first time they diagnosed that impacted pill there. Till then she was not aware. And then when it was, it was washed, and then she developed large ulcer, and later on that turned into an stricture.
Stricture.
Yeah.
Quite interesting story.
Yeah.
See, normally with the problem with these Ayurvedic pills is it can cause injury in 2 ways. Sometimes if they are not properly coated and if they have some odd shape, external shape, then that odd shape can cause mechanical trauma to the mucosa. Because they get lodged at
39-year-old male.
Because they get lodged at the natural anatomical narrowings in the esophagus. Or
known case of chronic pancreatitis with PD stenting with pseudocyst of pancreas. He has history of PD stenting done in August 25 for pancreatic duct calculi. MRCP of August 25 was suggestive of solitary thin walled cystic lesion near tail region of pancreas extending to lesser sac with hypertense debris within, showing communication with MPD in tail of pancreas measuring 7 by 8 by 8 by 8 centimeter with approx volume of 250 to 260 cc. ERCP in August 25 suggestive of dilated pancreatic duct with stone at body of pancreas with evidence of distal ductal blowout at tail of pancreas. Sphincterotomy was done. 5 French by 10 centimeter plastic PD stent was placed across the pancreatic duct. We are planning for pancreatogram SOS stent exchange. The learning objective will be management of PD blowout.
Hello.
Yes, sir.
So this patient had a chronic pancreatitis with pancreatic ductal blowout with a large pseudocyst formation at the tail of the pancreas. So it was a clear pseudocyst without any necrotic material. And this, the communication was demonstrated on the CT scan. So we did endoscopic, pancreaticogram, and we established that there was a ductal blowout at the tail of the pancreas. And then we did wide pancreatic sphincterotomy and the stenting. After that, within 6 weeks time, that pseudocyst completely disappeared. And patient now, it's almost more than a year, patient is asymptomatic. And recently patient came back for the follow-up. So usually we keep these stents for 6 months duration. Otherwise, there is this concretion formation around the stent, and stent itself get impacted, and sometimes it get fragmented also if we keep it for the long time. But now this patient has turned up after almost a year. So we could remove the stent. You have seen without it was a complete stent. So our plan is to get the cholangiogram again and see whether this the distal pancreatic blowout has completely healed. If it is healed and if there is no much distal obstruction, then proximal obstruction, we'll leave it alone. If there is some obstruction, then we'll do restenting again. Inject. Inject. एक मिनट.
Can you show the Siam image simultaneously?
Oh. Screen.
So I'll just take 1 minute. I have completely
Yeah.
dilated
Yes,
the,
yes, yes.
I have completely dilated the stricture, and I've gone in the stomach.
Can you show the endoscopy? Yeah.
Yes.
Endoscopic view, please.
Yeah. Now this is the fundic area.
No, no, we are not getting the endoscopic view from you.
Oh.
AV people, please show the endoscopic view.
Inject. Very good. Inject. इकडे दाखव.
Are you getting the endoscopy picture, sir?
No, no, not yet. Now we are getting it.
So now I have gone in the stomach after dilatation.
अरे
And
इकडे दाखव.
so this is the stomach. I am looking at the fundus.
Inject.
There is no obvious hiatus hernia.
But definitely a scar is seen in the stomach.
Yes.
Caustic
So-
injury might have caused
Yes,
that.
caustic injury might have caused this. But it is reasonably okay.
Yeah.
Pylorus looks normal. I can easily go into the duodenum. So there is no obstructive pathology distally. I'll come back and I will just examine the stricture area. I'm just coming out. This is the esophagus. Since the stricture was proximally, we don't expect much. Yeah, here. Here is the stricture. Can you see
Yeah,
the?
nicely dilated, yes.
Yeah. So.
Not much long.
Yeah, not very long. I could have done the dilatation using balloon also. Now retrospectively, I think like that. But okay, no harm done.
Yeah.
So
Nicely done.
Yeah. Okay.
Thank
So,
you.
but these cases, they are known to, the strictures are known to recur because I have created a raw area here. And once that raw area heals, she can again develop a stricture. So let's see. We'll keep her on.
Yeah, these patients, they need CT esophagography so that the thickness of the stricture can be judged.
Yes, sir. sometimes we instill injection triamcinolone to that can reduce the chances of restricturing.
Yeah.
But nothing can guarantee that the recurrence will not happen.
Yeah.
So that's the
Polyp
thing.
is to be removed.
Yes, sir. Okay, now we can shift to.
Yeah, thank you. Thank you, Mandar.
Thank you, sir. Thank you.
Yeah, shift the. Yeah, Pravin sir, we are with you.
So we have cannulated pancreatic duct, and we also got pancreatogram. There is no obvious leakage of the contrast from the pancreatic duct. Okay, so what I will do now, I will swipe the pancreatic duct with the balloon, and whatever concretions are there, take it out. And if the balloon is also coming out very comfortably, that means there is no actual stricture which will cause obstruction of the pancreatic, flow. So we'll leave this patient as it is. So,
Great.
okay, this is what my plan. Dr. Kanegwala had asked me, okay, show me head dakho, ikkada dakho. Okay, how to assess this part of the pancreas or corn bile duct behind the scope. So what even last case you must have noticed where there was a lower corn bile duct stricture. This is the short, root of the scope. Here we cannot see the retroduodenal portion of the corn bile duct or the pancreas. So what we can do, you can take the long route like this. See. Now we can see the, we visualize clearly. Initially it was like this. Like this. Yeah. So now, but it is like, yeah. Yes, yes. So once you take the long route, this portion is made. Yes. Takla, zebra.
Pravin, this papilla is so prominent.
Ah.
Anything to be done to that papilla?
See, but but it is very soft, supple. It is not, indurated, there is no mass like, it is very soft. So whenever there is, stents are there or stones are impacted, so you get such prominent papillas. If you are suspecting, any lesion, you can always take biopsy. Do you have any suggestion, Prashant?
No,
Yeah.
I don't have any idea about
No,
this.
no, no. So this is quite common finding, So we'll do pancreatic balloon swapping. Okay.
What size balloon you are going to select?
This is 7 mm. 7 to 9.
Nicely progressed to detail. Yes.
One enough. Can you appreciate these white concretions are coming out? Yeah, yeah. See, Dr.
Yeah.
Rate.
Yes, yes,
Huh?
we are seeing that.
Yeah. So these are the soft stone. Huh? So these can be managed endoscopically very balloon rupture. This way.
What post-operative medications you advise this?
Pardon?
Post-operatively, we supply some enzymes to these patients?
No.
No?
See, now for chronic pancreatitis or even for that matter acute pancreatitis, there is no role of pancreatic enzyme therapy if there is no pancreatic exocrine insufficiency. If there is a steatorrhea, loss of weight, then only pancreatic exocrine replacement therapy should be given. But just for the purpose of the pain in chronic pancreatitis, we should not give this exocrine replacement therapy. There is no role. See, in chronic pancreatitis, the pain is because of the three factors. First is increased intraductal pressure. So that increased intraductal pressure endoscopically we can manage with putting stent and with the stricture dilatation. Second factor is pancreatic inflammatory mass. If this inflammatory mass at the head of the pancreas, so unless you take out that inflammatory mass, this inflammatory pain will never settle down, even though we decompress the pancreatic duct with the stenting. Okay, and third component for pain. So for the first component where there is a increased intraductal pressure, that typically increases after meal, because after meal there is a stimulus, CCK-PZ stimulate pancreas to secrete more pancreatic enzymes, and there is a further secretion of the pancreatic enzymes which causes further increase in the intraductal pressure and the pain. But inflammatory pain is irrespective of the meals, because that inflammation will be there persistent. So this patient complained of persistent back pain irrespective of the meal in chronic pancreatitis. So if there is a persistent back pain irrespective of the meals with inflammatory mass on CT scan, unless you take out that inflammatory mass like FAIS procedures or Vegas procedure, that pain will never settle. And third component is involvement of the peripancreatic plexus, neural plexus in the inflammatory process. And for that pain, we have to initially do all this. If it doesn't settle, then we need to give celiac block. So these are the three different reasons for the pancreatic pain, and they should be treated independently. There is no monotherapy for everything. Infrared, 1 cc.
How many balloon sweeps you are going to do?
No, this is last. The last time the balloon got punctured. That's why I'm doing it again. So if it comes out easily without much, see, it has come out very comfortably.
Yeah.
And you can see there is a small stone also.
Yes.
Huh?
Yes,
See. So if it is coming out so comfortably, so I'm sure there is no stricture, and I'm good with stent removal. We'll observe this patient. Last 1 cc. Enough. That's all.
Yeah, nicely done. Thank you.
So this is, I think, last case for today's live demonstration. Tomorrow also we have almost 16 cases more. So let's see how much we finish. So by 1 p.m. we'll try to do maximum cases. But all again we have colonoscopy cases more. So we have sigmoid colon mass, we have transverse colon lesions, multiple polyposis, and the other pancreatic and biliary lesions. So I hope it was a interesting session for all of you, and looking forward to see you all tomorrow also.
It was an excellent day today, and
Thank you, sir. Thank you.
unbelievable collection of cases here.
No, sir. Thank you, sir.
Thank you.
And tomorrow we are excited to see your colonoscopy also, sir.
Yeah, thank you.
Thank you. Thank you. Now we have inauguration program immediately. Please stay back. Meanwhile, you can have cup of tea also. Thank you. Thank you, sir. Thank you. Thank you.
Now we'll take a break for tea and coffee. Our next session shall resume shortly with the inauguration ceremony.
Hello. Check. Check. Check.
Sir. Hello, check. Testing. Hello. Check. याच्यामध्ये जातं. Hello, check. Hello, check. Hello, check. Hello, check. Hello, check. Hello, check. आता येतोय का? पार इकडं आलंय. Hello, check. Hello, check. Hello, check. Testing. Hello, check. Hello, check. Hello, check. Hello, check. Hello, check. Hello, check. Testing. Hello, check. Hello, check. पारमध्ये गेलो तुम्ही आता. पार तर दरवाजाच्या मध्ये गेलो. इकडचं काय असं काही असू शकतं. तो आतमध्ये घातल्यामुळे हां. ठीक आहे.
Here?
Krishna Baheti. Yeah, I'll take it.
Okay.
Good evening, respected dignitaries, distinguished faculties, dear colleagues, and enthusiastic delegates. We, Dr. Shafali Khan
and Dr. Urvi Parekh are the hosts for today's event. Endoscopy is no longer just a diagnostic tool. It has become an essential extension of surgeon's hand, transforming the way we diagnose, treat, and care for our patients. It gives me immense pleasure to welcome all the distinguished faculty, respected surgeons, postgraduate students, delegates, and guests to the 4th Endosurg, Endoscopy for Surgeons, organized by MGM Medical College and Hospital, Chhatrapati Sambhaji Nagar, in association with Aurangabad Surgical Society.
Once again, a very warm welcome to everyone. We hope you have a memorable experience at the 4th Endosurg 2026. To begin the inaugural ceremony, I request our dignitaries to kindly come forward on the dais.
Shri Ankush Rao N. Kadam, Honorable Chancellor of MGM University, Chhatrapati Sambhaji Nagar, and Secretary of MGM Trust.
Dr. Krishna Rao Sir, pioneer in endoscopic surgery, past president of the Associations of Surgeons of India, Professor Emeritus, Tamil Nadu, Dr. MGR Medical University, Chennai, India.
Dr. P.M. Jadhav Sir, Vice Chairman of MGM Trust, who has continued to uphold the tradition of academic excellence, innovation, and service to society. Dr. R.B. Bora Sir, Dean of MGM Medical College and Hospital, Chhatrapati Sambhaji Nagar.
Dr. Pravin Suryawanshi Sir, immediate past president of the Associations of Surgeons of India, professor and head of department HPP Surgery, Deputy Dean, MGM Medical College, Chhatrapati Sambhaji Nagar.
Dr. Bhaskar Musande Sir, head of department General Surgery at MGM Medical College and Hospital, Chhatrapati Sambhaji Nagar.
Dr. Rajendra Shinde Sir, professor, MGM Hospital, Chhatrapati Sambhaji Nagar, Executive Committee member of the Associations of Surgeons of India.
Dr. Vikas Deshmukh, Professor General Surgery at MGM Hospital, Chhatrapati Sambhaji Nagar, President of Chhatrapati Sambhaji Nagar Chapter of Indian Medical Association.
Dr. Naveen Kaslewal Sir, Professor, MGM Hospital, Chhatrapati Sambhaji Nagar, and President of the Aurangabad Surgical Society.
Dr. Pankaj Vairagat Sir, Professor General Surgery, GMC Chhatrapati Sambhaji Nagar, Secretary of Aurangabad Surgical Society.
As a token of respect and gratitude, we now request Dr. Pravin Suryawanshi Sir to welcome our esteemed guests, Dr. P.M. Jadhav Sir, Dr. Krishna Rao Sir, thank you, sir.
Now I would like to request Dr. Musande Sir to felicitate Dr. R.B. Bora Sir. Dr. Pravin Suryawanshi Sir.
We now request Dr. Chabda Sir to felicitate Dr. Bhaskar Musande Sir. Dr. Rajendra Shinde Sir.
We now request Dr. Rajendra Shinde sir to felicitate Dr. Vikas Deshmukh. Dr. Naveen Kasliwal sir. Dr. Pankaj Vairagat sir. Thank you, sir.
Every auspicious beginning is marked by seeking the blessing of knowledge and wisdom. I now request all our dignitaries to kindly participate in the ceremonial lamp lighting and garlanding of the portrait of Mahatma Gandhi, symbolizing the triumph of knowledge over ignorance and our commitment to truth, compassion, and service. Thank you, respected dignitaries.
Now it gives me great privilege to introduce a surgeon whose dedication, expertise, and humility have earned immense respect from colleagues, students, and patient alike. A passionate teacher, an exceptional clinician, and an inspiring mentor, Dr. Pravin Suryawanshi sir has consistently set the highest standards of surgical excellence. To formally welcome everyone gathered here, I request Dr. Pravin Suryawanshi sir to share his valuable thoughts.
Good evening, respected dignitaries on the dais, chief guest for today's program, Dr. P.M. Jadhav, Vice Chancellor, MGM, Vice Chairman, MGM Trust, Dr. B.K. Rao, today's guest of honor, and also a orator for the ENDOSURG 2026. Dean MGM Medical College and Hospital, Chhatrapati Sambhajinagar, Dr. Rajendra Bora, Head of the Department of General Surgery, Dr. Bhaskar Musande, President, IMA Chhatrapati Sambhajinagar, Dr. Vikas Deshmukh, Organizing Treasurer for the ENDOSURG 2026, Dr. Rajendra Shinde, Secretary of President of Aurangabad Surgical Society, Dr. Naveen Kasliwal, and Secretary of Aurangabad Surgical Society, Dr. Pankaj. All respected senior teachers, respected invited faculties, my dear friend from Russia, Alexei and Anna, thank you so much for coming all the way and joining us. And all my friends from every corner of Marathwada, I am really thankful to them and dear students. It gives me immense pleasure to welcome you all for this ENDOSURG 2026. Since as a surgeon, I started my career as an endoscopist first and then laparoscopy. So endoscopy is always, you can say, my first love as far as my technical skills are concerned. And since those days, I strongly feel that endoscopy is a very important tool in the surgeon's armamentarium, which can be used not only for the diagnosis, early diagnosis and the right diagnosis, but for the effective treatment also. I always keep telling that we should not be a master of technology. We should be the master of science. And to deliver the best possible treatment options, whatever technology is there, we must utilize that technology to deliver our best scientific treatment options available in the interest of the patient. And for that, see, now endoscopy is there, laparoscopy is there, robots are there. So we may not able to stretch laparoscopy too much in near future. We may have to adopt robotic. That time, robotic surgery will be gold standard for most of the procedure. So what is more important, that the technology should not be a bypass or the substitute for the basic science learning and the expertise. So we must master that, and then you master the technology. And if you really want to do that, we must have everything in our armamentarium so that we will select right technology in the interest of the patient. And I was very fortunate, to get the highest position in the surgical fraternity as a ASI president. And whatever agenda I had, I could push it very strongly at different platforms. And I'm very happy to mention here and announce that the National Board of Examination has agreed to start 2-year postdoctoral fellowship program in surgical endoscopy. So this is a really very big, breakthrough as far as we surgeons are concerned, because most of the endoscopists or the physicians, they used to doubt, or they used to create a propaganda that the surgeons are not eligible to do therapeutic endoscopy. But now with this, everything has been resolved. In the faculty, we have Dr. Ishwaramurthy, Dr. Kanegwal, Dr. Mandar. They all are working since last decade, I guess, to increase awareness and train more, and Dr. Prashant is there, to train more and more surgeons for the endoscopic surgeries. I think this momentum will get a very big boost to take it further with great enthusiasm. This ENDOSURG, I feel it's a small, humble beginning that we started 4 years back. And I was not sure that it will go so long and with such a big way. This year, I'm again very happy to mention here that the first time more than 40 medical colleges across the India, they are attending it online live. And that way more than 400 residents, they are getting benefited. So this is not that we are, our ENDOSURG is getting more and more recognition, but what I feel that more and more junior surgeons, resident doctor, at the beginning of their career, they will be enlightened to take this endoscopy in their, enthusiasm will be created to take this endoscopy from the beginning of their career. So I think this is how all with everyone's effort and support, we'll able to achieve our goal. And I'm very thankful to the management, MGM Trust, for giving wholehearted support. Whatever technology you saw, whether it's a cholangioscope or endoscopic ultrasonography is there with us since for more than 15 years. And we are providing this advanced technology to the poorest of poor. They will not dream to have such services at their doorstep, but we are able to provide such services with excellent outcome. So thanks to management, thanks to all my endoscopy team and the surgery department team for their continuous support and efforts to make it possible. So again, I thank all the international and national faculties for taking out so much time to come here every year and to share their experience and endoscopic skills. So again, I wholeheartedly welcome you all. And tomorrow also, today we did 18 cases. Out of those 18 cases, 11 cases were major cases. And tomorrow we have another 20 cases lined up. Let's see how much, but all are again different cases. Tomorrow, more colonoscopy cases will be there. So colonoscopic polypectomy and biopsy and all that. And plus some pancreatic and the biliary therapeutic procedures. So stay back, don't go anywhere, and enjoy your further academics. Thank you so much.
Thank you, sir, for your warm words of welcome and for setting the perfect tone for today's event. It's now time to honor the stalwarts whose dedication to teaching, research, and patient care continues to inspire generations of surgeons.
I requested our dignitaries to kindly felicitate the distinguished faculty members. Now I would like to request Dr. P.M. Jadhav, sir, to kindly come forward and felicitate Dr. B. Krishna Rao, sir, pioneer in endoscopic surgery, past president of the Association of Surgeons of India, Professor Emeritus, Tamil Nadu, Dr. MGR Medical University, Chennai, India. Dr. Alexei Karpov, Deputy Chief Physician of Surgery, HPB surgeon at Botkin Hospital, Moscow, Russia.
Dr. S. Ishwar Murthy, sir, consultant surgeon, professor of surgery at Lotus Hospital, Erode, past president of Indian Association of Gastrointestinal Endosurgeons. I request Dr. Bora, sir, to felicitate Dr. M. Kanagaval, sir, Senior Consultant General Surgeon, St. Isabel Hospital, Chennai, National Executive Member of Indian Association of Gastrointestinal Endosurgeons. Dr. Prashant Rahate, sir, Chairman and Managing Director, 7-Star Hospital, Nagpur, Founder President of International Society of Coloproctology.
Dr. Mandar Daifode, sir, consultant GI endoscopist at KEM Hospital, Pune, and director at Gastro Hub Hospital, Pune. Dr. Makaran Patki sir, Senior General Surgeon at Samarth Hospital, Chhatrapati Sambhajinagar.
Now we request Dr. Pravin Suryawanshi sir to felicitate all trade heads associated with the conference. Dr. Atul Deshpande, Olympus Medical System India Private Limited. Mr. Hardik Shah, Fujifilm India Endoscopy. Mr. Sandeep Khedkar, Carl Stores India Private Limited. Mr. Ritesh Jaiswal, Johnson & Johnson Private Limited. Mr. Vinay Pawar, Vasu Group. Mr. Chandrasekhar Komatkar, Cipla Limited. Mr. Om Vagmare, Sun Pharma Labs Limited. And Mr. Shankar Zadav, Relivium Pharma Private Limited. Thank you, sir.
Every great event is enriched by the wisdom of its distinguished guests. It is now my honor to invite Dr. B. Krishna Rao, sir, pioneer endoscopic surgeon, Professor Emeritus, to address the gathering. Please, sir, grace us with your words.
Dignitaries on the table, my colleagues, ladies and gentlemen. It is an honor to be present in this august gathering and to share the advances and improvements that I have seen under Professor Pravin in endoscopic surgery. I was extremely happy that they have more than 45 cases lined up for the 2 days. And this is not only for us, but it has been almost a daily occurrence of schedule in the hospital. I congratulate you as one of the past president to another immediate past president on this occasion, and I am extremely delighted to be part of this celebrations today. Thank you.
Thank you very much, sir. Your words of encouragement and experience are truly inspiring and will certainly motivate all of us. Now, a very special guest will be joining us. Dr. Shivkant Mishra, sir, Senior Laparoscopic and General Surgeon, Honorary Professor of the Indian Medical Association, who will join us virtually via Zoom link.
Namaskar. Good afternoon, everyone. Greetings to all who have assembled at Mahatma Gandhi Mission Medical College and Hospital, Chhatrapati Sambhajinagar, for 4th ENDOSURG, a 2-day workshop on GI endoscopy. I must congratulate my dear friend Dr. Pravin Suryawanshi and his team for their commitment to train general surgeons in the art and science of GI endoscopy. General surgeons must learn GI endoscopy because it is a critical. I'm getting call from Dr. Pravin. If I'm audible? Hello?
So you're audible.
Okay. So I want to congratulate my dear friend Dr. Pravin Suryawanshi and his team for their commitment to train general surgeons in the art and science of endoscopy. General surgeons must learn GI endoscopy because it is critical for diagnosis, surgical planning, and intraoperative assessment. It allows surgeons to check anastomotic integrity, localize lesions, and perform combined laparoscopic procedures. Mastering these techniques improves surgical outcomes and helps manage post-operative complications. Endoscopic skills are needed for intraoperative guidance during complex foregut, bariatric, and colorectal surgeries. Endoscopy also enables surgeons to manage post-operative complications like marginal ulcers, leaks, and fistulas without a need for open reoperation. Endoscopy provides skills synergy with improved hand-eye coordination and deeper understanding of luminal pathology. As Praveen has already mentioned, I'm extremely happy to announce launching of 2-year fellowship program in GI endosurgery by National Board of Examination in Medical Sciences. FNB GI endosurgery will fill the gap between open laparoscopic surgeries and endoluminal procedures, thus giving advantage of minimally invasive technique and advancing technology to the patients, as largely general surgeons are the primary caregivers in the most part of the country. I congratulate Dr. Pravin Suryawanshi, who has been nominated as the convener of the GI Endosurgery Specialty Board by National Board of Examination in Medical Sciences. Lastly, but not the least, I congratulate all the faculty members,
your association, and I really advise to my students who may be sitting there that you will not get that opportunity. It comes once in a lifetime. Learn whatever you wanted to learn. Once you go after your post-graduation, then you are the boss of your own. You cannot ask to anybody. So take the advantage of today and tomorrow, and maximum benefit you must acquire. I'm very thankful to you for calling me here, and I hope that you will have a very pleasant time here. I will again welcome on the behalf of our management, and I stop it here. Thank you very much.
Thank you very much, sir. Your words of encouragement and experience are truly inspiring.
Every successful event is the result of collective efforts of many dedicated individuals. To express a sincere gratitude to everyone who contributed to the success of this inaugural ceremony, I now request Dr. Bhaskar Musande, sir, to deliver the vote of thanks.
On this special day, we have a special occasion where Dr. Ishwar Murthy is going to come up with his new book that he'll speak up about. I request Dr. Ishwar Murthy to guide us and give an overview of his book.
To appreciate the efforts taken by single-handedly by Pravin to train all the young surgeons in art and science, and we, the faculty from the surgical fraternity, have come up with the guidebook how to do an endoscopy,
colonoscopy, ERCP as a manual, so that it will be something like a Bible for all of us, and it will be the first step in the right direction. And not only we should teach, and we should record, document. So these are the two books I have written. I am very happy if Pravin and Bhaskar, the Department of Surgery head, to take these two books in the presence of Professor Krishna Rao sir. It will be a great motivation and occasion for all of us as a surgeon. Surgeon writing a book and teaching and training our youngsters. Thank you.
Congratulations, sir. And we sincerely thank you for presenting this wonderful book. It is a meaningful token of knowledge and inspiration, and we truly appreciate your thoughtful gesture.
Now, to express our sincere gratitude to everyone who has contributed to the success of this inaugural ceremony, I now invite Dr. Bhaskar Musande sir to deliver the vote of thanks.
Dignitaries on the dais, delegates, students, faculties who have come from Chennai, Pune, Russia, and my friends. At the outset, I would like to thank the management of our medical college for providing this beautiful infrastructure to hold such conferences and workshops. Then I would like to thank Dean, Dr. Bora, who is always a support to us whenever we go to him and ask for permission to hold these conferences. Then I would like to take this opportunity to thank Dr. Pravin, as now Dr. Shivkant Mishra told about the DNB course, because since last 2 years, I think we have been discussing and we have heard him talking to take this initiative to get a course or get something authorized from the government so that surgeons are eligible, are authenticated to do endoscopy, because there was always a gray area in our medical field that whether we should, are we permitted to do endoscopy or not. I think that chapter will be closed once this, once the DNB board has announced this course. So I would really appreciate whatever efforts which Dr. Pravin has taken in these last 2 years. Then the delegates who have come from all parts of the Marathwada or from Maharashtra, and all the students who have watched today's procedures and who will be watching tomorrow's procedures, I would also like to thank them. Then the pharma people who have also supported us, the Olympus, Fuji Films, Carl Stores, Johnson Johnson's, Vasu Medical, Cipla Limited, Sun Pharma, and Relivium Pharma. I would also give a big thanks to all these companies who have been a support. Then, before I conclude, my students, PG students who have helped me in all this, actually they are the backbone and they work behind the curtain and nobody appreciates them. So I think we should take this opportunity to appreciate them. Then our non-medical staff of the department, which is always there, who works overtime so that we can give best results or best outcome in the workshops. I have to take the names. We have Anita madam, Trupti madam, then our technicians whom we have. Maruti is there, Mahesh is there, Baban is there. All these people are there who work actually with us. They work even more than us because they always stay behind, because we leave early and they stay behind to wind up everything, maintain the scopes, maintain everything, and then go home. So I think their work has to be appreciated on such platforms so that they also get boosted and always be enthusiastic to help us in near future. Lastly, I am a surgical society which is always there with us in association with MGM Medical College. I would also like thank the office bearers of the Surgical Society and IMA, because this year we have Vikas Deshmukh, our own surgeon colleague, who is the president of IMA Aurangabad. So I would also like to thank him to be a part of our team. Thank you.
I request everyone to stand up for the national anthem. Thank you, everyone. I request everyone to stay back for the oration.